Haya. Check, check. Okay, assalamu alaikum all. And a very warm good morning. I'm on the behalf of organizing committee. I welcome you all in the PSO 2026. So this session is about the precision and pragmatism in CNS tumor management. So I would like our person, Dr. Professor Abdul Sattar Hashim, to please come on the side, along with our renowned or distinguished panelist, Dr. Aftab Khan, Dr. Rizwan Sharif, and Dr. Bilal Muhammad. So Professor Abdul Sattar Hashim doesn't require any introduction. He is a pioneer in gamma knife SRS in Pakistan. Dr. Aftab Khan is a world-renowned neurosurgeon who trained in University of Pittsburgh. He started, along with the Dr. Sattar Hashim, the pioneer of the stereotactic services in Pakistan as well. As he also started services in the Gulf countries as well. So let's start with the session. So our first speaker is Professor Abdul Sattar Hashim. As I mentioned earlier, he doesn't require any introduction. He is an acclaimed neurosurgeon and the pioneer of gamma knife radiosurgery services in Pakistan. He is the chairman of Muhammad Hashim Memorial Trust and the Neurosurgeon, Neurospinal and Cancer Care Postgraduate Institute, NCCI. His lifelong contribution to neuro-oncology and radiosurgery has transformed intracranial tumor management and shaped clinical services, training, and mentorship across the country. He will be sharing the pioneer experiences of gamma knife SRS in Pakistan. So I welcome Dr. Abdul Sattar. Thank you.
Bismillahirrahmanirrahim. Namaduhu wa nusalli ala Rasulil Kareem. It's my privilege to see my Mohsen, Dr. Shahid Hamid, is here with us. And I have seen him after 2013. I welcome you all, and also thankful to Dr. Aftab, who has come long away from Kuwait. So thank you very much. So I start the as topic given by Dr. Azhar Rashid to talk about the pioneering in Pakistan journey of vision, innovation, and perseverance. Actually, this is a formal talk, and this is not a research talk. As you know, that I have been trained from American University of Japan. So my professor used to say me that in Japanese, "Yume meru wa ii desho," यानी हमेशा ख्वाब देखा करो, हमेशा ख्वाब देखा करो, वो अच्छी बात है. So this is how the young doctors or young graduate, postgraduates being take learning from very beginning. During my residency, he used to send me different centers, and he used to send me for operations, different operations, even for moya disease. Those one of you who are neurosurgeons, is a very big operation. You know, we used to take them and just put on the whole brain, do whole brain craniotomy, and then do anastomosis, end-to-end anastomosis. A very big operation. So he sent me to Osaka Neurovascular Center. So this was me to Gamma Knife as well. And he also sent me to Professor Lars Lexel, and even and the faculties from USA used to visit our department. So it was very good interaction with them. This picture is one of the with Professor Sherman in 2004, but I was using to Amsterdam department to learn the stereotaxy long before, but I started to visit this department in 2019. This is the fourth time I was there to learn about stereotaxy. The goal of gamma knife radiosurgery, the primary goal of gamma knife radiosurgery is to achieve maximal disease control with minimal morbidity. It aims to treat deep-seated, high-risk brain lesions without opening the skull. Gamma knife allows anatomical removal to biological control of disease, preserving anatomy, intensive care admission, and prolonged hospital stays. This technology represents a paradigm shift from invasive surgery towards the precision image-guided function, preserving the treatment. Here, when I joined at JPMC as assistant professor in 1986, after my post-graduation as assistant professor, neurosurgery was actually in bad shape. Just in 1984, CT scan entered in Pakistan. Very bad shape. Morbidity and mortality was too high. And I was knowing that for small acoustic tumors, patients are dying. Very young females are coming, but I was seeing the dreams that one day what is happening in Western world, inshallah, we have to bring that technologies to Pakistan. Why we should open skull and go for the small acoustic tumors and giving morbidity and mortality to patients. Nobody in Pakistan could save the facial nerve. Every time we see the patients with the facial palsy, either he or she is going to die with the surgery. Just before surgery, I used to know that fate of that patient. The need for gamma knife in Pakistan. Pakistan carries a substantial burden of brain tumors, vascular malformations, and cranial nerves disorder. Prior to 2007, I used to send patients to Singapore, Western world, or even United States, because I know that gamma knife is here in world. Why we should open for but I used my first paper in 1985 was on the angiographically occult AVM and surgical neurology from USA. It's printed over there. And, but even then, operation is also there. First, but you have to for selected cases, not for every patient. So still, gamma knife is the gold standard, and it was at that time also was being treated on the gamma knife. Professor Takakura is famous for that, and he used to do all the AVMs on gamma knife. Many patients were forced to seek radiosurgery abroad due to the lack of local facilities, incurring high financial and emotional costs. So we saved the cost. I know few of when I met with the president, when vice president came to Pakistan, marked the beginning of stereotactic radiosurgery in the country. It was a bold initiative by a small private institution driven by a vision rather than resources. So that vice president, I just gave him few gifts from Karachi, English Wood House, and I left him at the airport at the end. So I said that my hospital, even I'm going to mortgage it, it could not offer you all the price you have said me, $4 million. I could not afford it. So he went back. After a few weeks, I received a email from him that why not you are putting this gamma knife there. I have got some idea that you can have deferred LC. Means maybe you don't know that. I was also not knowing about at that time about the deferred LC, letter of credit, that half of money you pay now and half of money later after earning. So he gave me such a proposal, and it was very nice to him, and he is still my friend, and I'm showing you that how he visited also Pakistan. Evolution of technology at NCCI to remain at the forefront of neurosurgical care. NCCI continuously upgraded its radiosurgical technology. In 2016, gamma knife icon was installed, enabling frameless treatment and fractionated radiosurgery. In 2025, last year, the latest gamma knives split further enhance the accuracy, efficiency, and patient comfort. Financial and administrative challenges. The acquisition of gamma knife involved enormous financial risk for the institution. Hospital was mortgaged to secure bank financing, reflecting complete commitment to the project. This decision was taken with belief that patient benefit and long-term national impact outweighed short-term financial strain. I used to remember my emotions. Here is Professor Manzoor Zaidi. I always remained in touch with him that how the things are going on, what should I do. And while installing the gamma knife at Karachi, I went without any introduction to Professor Shahid Hamid, is here with us, and I'm very grateful to him. Maybe I remain grateful for whole life, that he gave me two elite gifts, Dr. Azhar Rashid and Chaudhry Usman. He was physicist. He asked Dr. Azhar Rashid was in training in Birmingham. He asked him that please you join after returning from UK, you go and join Dr. Star Hashim. Just that's all. So Dr. Azhar came directly to me. So you have to form a team as an oncologist, neurosurgeon, physicist, radiologist. This is a whole team. Without team, you can't work. I thank you very much, sir. And we could not forget Professor Carlson from Singapore. He's a Swedish person. He visited our institution 3 times. He is saying me, I'm always on your disposal. He came to Pakistan for the first time, and when I got first patient on gamma knife, he insisted me that please do biopsy of brainstem lesion. He was a medical student. So I had stereotaxic frame at that time, and he said, no, it is a tuberculoma. I said, no, sir, I'm here and I have got a lot of patients. It's a malignant glioma. But on his request, he was not doing gamma knife on him at that time. So I is there, and the CEO, Captain Saab, is with me. And every time, the press peoples and other neurosurgeons with me, Dr.
Control while it spares nearby structures with sub-millimeter accuracy. So this study evaluates long-term outcomes in residual non-functioning and hormonally active adenomas. So what are the treatment consideration before choosing treatment, whether the patient is a surgical candidate or a radiosurgical candidate? So we have to think that whether the tumor is producing mass effect or a patient is developing any visual decline, then the surgery will be the best option for the patient. And our goal is to gross total resection, which offers long-term control. And we also think about the endocrine function of the patient. Can we achieve the biochemical remission? And obviously, and in the end, it's patient choice as well, whether you want to go for surgery or radiosurgery. So a little bit about non-functioning adenomas from the papers which have been written in past, like from the surgical alone series, the rate of tumor progression or recurrence at 10 years. So as I told you, the surgery is the best option for these tumors, but if the neurosurgeon has removed it subtotally resected tumors, the recurrence rate in subtotally resected tumors is around 50% reported in literature, and with cross-total resection is still there is a chance that the tumor may come back again, maybe from 10 to 25% reported in literature. So goal of gamma knife radiosurgery is to arrest tumor growth, and if the shrinkage or resolution is occurring, then it is we consider it as a bonus. So stereotactic radiosurgery is about concentrating dose on the target. On the right side, you may see that the gamma knife delivers a highly precise delivery of radiation to the target with sub-millimeter accuracy, and there are the 192 beams which usually converge on the target from the different collimeter sizes of 4, 6, and 8 or 16. So this is the gamma knife workflow. We usually apply a frame if we do it in single session, and if we are doing it in hypofraction, we usually do on thermoplastic mask, and after that the patient is imaged, and then we create a treatment plan on gamma knife software, and then the delivery of the treatment is done. So multidisciplinary team approach with the neurosurgeon, radiation oncologist, medical physicist. So what are the traditional indications of radiosurgery for non-functioning pituitary adenomas? For those for patients who are non-surgical candidate, recurrence or progression of tumor after surgery, or surgically inaccessible tumors like in the cavernous sinus or beyond. And for functioning pituitary adenomas, we usually the indications are same. But if a patient tumor is producing hormones which are not controlled after maximum safe resection and medical therapy. So in this study, we evaluate the tumor control, endocrine outcomes, and complications of our gamma knife, and compare outcomes between single session and hypofractionation, and determine the safety profile regarding the optic and pituitary preservation. So at NCCI, we have 430 patients from 2007 to 2024. Median age was 50. And in single session, we did single session up to from 2007 to 2016 with the dose of 10 to 20 gray in single session at 50% isodose line. And we did multifraction after 2016 when we have gamma knife icon. And the dose selected for these cases was 20 to 25 gray in 5 fractions. So in single sessions, we did 280 cases. And in hypofractions, we did 150 cases. So, and the median follow-up of the patient was 36 months, ranging from 6 to 24 months. So, total 430 patients, non-functioning adenomas were 70%, and hormone-active adenomas were 30%. Supracellular extension 148, cavernous sinus 182. Surgery was performed in all the cases, and we had a biopsy before delivering the radiation, and previous radiation in 35, and endocrine suppression in 90 patients. So in single session, the median tumor volume was 3.6 centimeter, and the tumor control we had is around 90%. and shrinkage was seen in 54%, while the stable disease was seen in 36, and 10% is a progression, and neurologic improvement was seen in 63% of the patient, while the new or worsened endocrine dysfunction was seen in 24% of the patient in a long-term follow-up. And for hormonally active, we have growth hormone adenoma, remission of 46%, and Cushing's at 35%, and prolactinoma at 40%. So it was in single session. And in hypofraction group, where we treated the tumor in 5 fractions with higher dose of 25 gray, the mean tumor volume was 3.9 centimeter, and the tumor control was slightly higher, around 92%. And the shrinkage was seen in around 70% of the patients, and we had pituitary stalk preservation in 92%. And while we did not see any visual or cranial nerve deficits in this group, and hormonal normalization for pituitary, hormone-active pituitary adenomas, we have, as compared to single session, we have growth hormone adenomas. We achieve remission in 60% of the patient, and Cushing's around 67, and prolactinomas around 46. So as we compare both the groups, in single session we have 90% tumor control, while in hypofraction slightly higher, 92%. Shrinkage was better in hypofraction, and again hormone normalization was again better in hypofraction. And while endocrine dysfunction, we have 24% in single session, while dysfunction was endocrine dysfunction 8% was seen in hypofraction, while visual deficits were very up to less than 3% we seen only in single session at follow-ups. So complications, we had around 4 to 24 again, 8% in single and 24% in single and 8% in hypofraction. Visual deterioration was very less, and cranial deficits were also not there, and radiation necrosis is very rarely seen. So overall, gamma knife showed excellent safety with low morbidity. So gamma knife radiation offers durable control in both non-functioning adenomas and hormonally active adenomas. Obviously, after the residual, if you left the residual, so it is a better option. If you have left the tumor inside, so it's better to go for early gamma knife radiosurgery, and long-term and hypofractions achieve better endocrine and visual preservation. So our findings support early gamma knife for residuals. So gamma knife is safe and effective for residual tumors. Hypofractions may offer superior functional preservation. Long-term follow-up is essential to monitor delayed endocrine effects. So, and multidisciplinary team approach remain cornerstone of management. So I would like to show a few cases we did in hypofraction. Like this patient, we gave 25 Cray in 5 fractions, and this is a 66 month of durable tumor control in this patient. And you can see on the left pre-gamma knife, and on the right post-gamma knife, 25 Cray in 5 fractions. Good tumor control again. This was a 20 Gray in 5 fractions. So patient is doing fine, and tumor is significantly reduced in size. And this tumor was invading the cavernous sinus on the left side. This is the case of prolactinoma, where we gave 25 Gray in 5 fractions. Patient was non-refractory to medical therapy and surgery. So this is also showing the patient is also into 6 years into the follow-up, showing shrinkage in size of the tumor with good tumor control. This is again case of a pituitary adenoma where we have given 25 gray in 5 fractions, and almost we have a follow-up of 6.5 years, and the tumor has significantly reduced in size. It was inside the cavernous sinus, so surgeon left it. And this is we did before 2016. This is in single session with frame application. And we delivered a dose of 12 gray, and the patient, this is the 10th into the 10 year of follow-ups, but this patient developed pituitary dysfunction in the follow-up after 10 years, and he is on hormone replacement therapy. So this is again another case where we did in single fraction first, but patient developed recurrence. So we did again in fractions of, we delivered a dose of 20 gray in 5 fractions, and patient also, this was a very old case. First we did in 2011, and then patient developed recurrence, and we did in hypofraction again. And on the right side you may see tumor has significantly reduced. It was inside the cavernous sinus. So thank you very much.
Thank you, Dr. Kashi, for sharing your institutional experiences. Now we are moving towards the next part of this session. This is a debate regarding the whole brain radiotherapy versus stereotactic radiosurgery in multiple brain metastasis. For this session will be moderated by Dr. Bilal Muhammad, and the two speakers are actually Dr. Agha Mohammad Hamad Khan. He is a consultant radiation oncologist at Ziauddin Hospital Network. He is alumni of Khan University Hospital. He went to Sultan Qaboos Hospital and then went to actually McGill University for his fellowship on stereotactic radiation therapy. He is also a founder of GWON, the global network for international cooperation regarding academic excellence. Our next speaker is Dr. Uzma Gul. He is a consultant radiation oncologist at CyberKnife Medical Postgraduate Center. She has an extensive experience in radiosurgery. She has also published different articles in different forums, and she has also part of pivotal role play in multidisciplinary tumor board. So I welcome both of them, as well as Dr. Bilal for the next session. Thank you. You will also see the QR code on the screen, so please scan and give your feedback. Thank you.
Yeah, I think we're running late, so I would just start with Dr. Uzma Gul. We know brain metastasis is one of the commonest presentations in our neuro-oncology MDTs. So we'll see what Dr. Uzma Gul has to say in favor or against whole brain versus SRS.
Assalamu alaikum, and thank you so much for my introduction, and thank you so much for having me here for this evidence-based discussion. So I am in favor of stereotactic radiosurgery in multiple brain metastasis and to leave the rest on the modern systemic therapies. This is my disclaimer. So in this era of stereotactic radiosurgery, prolonging survival is not the only concern. Preserving cognition is equally important. I will start with my first evidence, the cyberspace trial, which was published in 2025. It is a randomized phase 2 trial they included 202 patients with 1 to 10 brain metastasis. The primary outcome was freedom from whole brain radiotherapy with preservation of the neurocognitive function, while secondary outcome was the median overall survival. The indication for whole brain radiotherapy were leptomeningeal disease and exhausted SRS radiotolerance. They concluded that SRS delayed the need of whole brain radiotherapy in 77% of the patients at 1 year with low neurological death rate. The median overall survival was same in both the groups. Those who received the whole brain radiotherapy or SRS is almost 13 months. They concluded that SRS with frequent, with regular monitoring and re-SRS whenever needed decreases the need of whole brain radiotherapy and resulting in low neurological death rate. So SRS is favored for 1 to 10 brain metastasis. Interestingly, the individuals who received immunotherapy with SRS, they showed the better outcomes in terms of re-SRS and the need for whole brain radiotherapy. So this is N107C, which was published in December 2022 at JAMA. It is a randomized phase 3 trial. They compared the SRS to the surgical cavity with whole brain radiotherapy in surgically resected brain metastasis patients. They included the long-term survival. Total 54 patients were included. And they observed that there is a lower cognitive decline at 3, 6, 9, and 12 months in these long-term survivals with a better emotional and functional well-being. Cognitive deterioration was lower in SRS group at all time points. Though whole brain radiotherapy show a better tumor control, but there was a more decline in the neurocognition over a time scale, which will manifest in as a poor quality of life. So they showed that the SRS is better in terms of cognition, though the whole brain radiotherapy showed a better control, but at the cost of cognition. But this is the story of 22. So next slide showing more interesting results. This is a meta-analysis and systemic review which was published in 2025. They compared the survival between two groups of SRS and whole brain radiotherapy. And they found that the SRS and whole brain radiotherapy have similar overall survival at 1 and 5 years. There is no significant difference in local or distant intracranial recurrence between the two groups. With the similar outcomes, the SRS has an advantage because it provides the targeted treatment with more sparing of the normal brain tissue. So it has an edge and advantage for better cognition and better quality of life. And this slide summarizes the meta-analysis of individuals who were having the radiosurgery or whole brain radiotherapy after resection. So they included 248 patients who had their surgery for the oligo single brain metastasis. The individual either received radiotherapy, stereotactic radiosurgery to the surgical cavity only, or the whole brain radiotherapy after resection. After SRS or whole brain radiotherapy after resection showed the equivalent local control and distant control. There is no significant difference in overall survival to the both group. Even the SRS showed a better quality of life. So SRS preserved the cognition with a similar survival and control even in post-surgical individuals. So these two, both meta-analysis, they concluded that the individual either received radiosurgery with tumor before surgery or after surgery, the SRS is superior with a better or even same overall survival. But they both meta-analysis, they did not included the individuals with immunotherapy. So most of the patients we treat with the brain metastasis, we found they are having their primary from the breast or the lung. That's why I included the individuals who were having the lung cancer, having ERK gene rearrangement. So the data was pulled from the 2 single-arm phase 2 trials that both studies having the individual with ERK positive NSCLC. They were having a crizotinib progressed lung cancer. They received an alectinib 600 mg. The primary endpoint was the measuring the tumor response, primary tumor response, control of CNS disease, and the duration of CNS response using RECIST criteria and independent review. The median follow-up was 12.4 months. 60% of the individual, they were having CNS metastasis at baseline, and out of them, 70% had a prior radiotherapy. Surprisingly, the CNS overall response was 64% with alectinib. CNS disease control rate is 90%. The median CNS duration of response is almost 11 months. The CNS overall response rate was 36% for the patient with prior radiotherapy and almost 58% for the patient without prior radiotherapy. They concluded that alectinib showed good efficacy against CNS metastasis in addition to systemic activity. In crizotinib refractory ERK gene positive NSCLC, the alectinib is a better option, and all individuals they tolerated very well without any baseline CNS, regardless of the baseline CNS disease. This study was published in Lancet in 2018. There is the individuals who were receiving nivolumab and ipilimumab or nivolumab alone in melanoma brain metastasis. It is a phase 2 study. They included 79 individuals, and they followed them for a duration of 17 months. 46% were treated with ipilimumab plus nivolumab, and 20% were treated with nivolumab alone. They concluded that nivolumab and ipilimumab should be considered as a first-line therapy for asymptomatic, untreated brain mets. Then they published their 7-year follow-up data, which endorsed the same results. There is their ongoing trial in which they are incorporating the role of SROS in this new paradigm. This is literally a shift, a new shift. And this phase 2 trial was published in Lancet in July 2016. They included 52 individuals. They're giving them pembrolizumab for the patient with melanoma or NSCLC lung cancer with untreated brain metastasis. The intracranial response rate were found in 4 out of 18 patients with melanoma brain mets, like 28%. And the response were observed in 33% of the patient with NSCLC primary and brain mets. These response rates were comparable to expected extracranial response rate. So intracranial response were generally durable. All the patients maintained ongoing response at a median follow-up of 11 months in the melanoma except one. And the ongoing response were also observed in the median follow-ups almost 7 months in the NSCLC cohort. Here, the evidence I presented, I just graphically plotted them to make a better understanding of my audience. So here all that evidence I have presented. I plotted them for the cognitive decline in SRS versus whole brain RT. This graph is clearly showing that individuals who receive SRS are having less cognitive decline as compared to those who receive whole brain radiotherapy. All these studies are concluding that. And for the quality of life, the individuals who receive whole brain RT are having poor quality of life as compared to those who are receiving SRS, having better quality of life. And if we talk about the overall survival, almost same in both the arms. So a very better picture that what to select in this era. As I'm having time, so I would like to share our data of JPMC. Since 2010, we have treated 878 patients of brain metastasis. And just for the sake of time, I brought only the 3 follow-up results here. For the first follow-up, 482 patients were available. I divide the follow-up response into 2, clinical response and radiological response. For the clinical response, almost 400 patients were, showed the improved, clinically they clinically improved, and almost the same number, 360, they were radiologically improved too. The rest were stable or reduced. Only 30 patients, they deteriorated clinically, and the same number deteriorated, showed the progression on radiological response, on radiological assessment. The second follow-up was done on 6 months post-stereotactic radiosurgery. 310 patients were available for the second follow-up response. So out of 310, 252 showed improved clinical response and radiologically almost same number. And only 15 were deteriorated clinically as well as radiologically they showed progression. And in between, they were either stable or show a disappearance of the brain mets. And for the third follow-up at 9 months post-SRS, 244 out of 245 patients, 200 showed clinical response, 36 were stable, and radiologically almost 200, 170, 200 was reduced, 36 were stable, and 29 were completely resolved. Only 9 patients showed radiological deterioration, increased size or new lesions, and the same 9 were clinically deteriorated too. So I would like to conclude here that some systemic drugs may spare the cognitive as compared to the whole brain radiotherapy. High-level evidence on cognition impact is limited because we are very early in this. CNS active drugs benefit only selected metastatic patients, so these agents are shaping the modern practice strategies. Future trial need for the optimal therapy integration. References. Thank you so much. I'm open to the questions.
Thank you very much, Dr. Uzma. I'll invite Dr. Aga Muhammad to have his say. I think the purpose of this meeting at this session is to have some bit of a discussion, find some views of our attendees. So we'll try to gather your views, and we'll open the podium for a question to have some debate into the matter.
No, it's already, the time is gone.
Assalamu alaikum. Assalamu alaikum, everybody. My name is Dr. Ahmad. I'll try to make it a bit interesting because of the fact that we are in an era of SRS, and I'm struggling to open my slides here. Okay, somebody's, okay, perfect. So, my name is Dr. Aga Hamad, and I am a radiation oncologist, recently joined at Dr. Ziauddin Hospital. So, try to make it a bit interesting as, because, yeah. So, this is the little Yama. So the video is not playing. So the video is playing, but the voice is not there. So in the context of SRS and presenting in favor of whole brain, it's a difficult task to begin with. But this video will give you a different perspective, why I put this. You may get it maybe in the end. So, let's give it a try. Okay, so this is the chart of phase 3 randomized trial. As I said, SRS is the new norm now, and it's pretty much the standard of care. But in oncology, the golden cradle has been always the overall survival. And we can see, like in the summary, and suggested by our first speaker, there was no difference in overall survival. Either you opt for whole brain or you'd go for SRS. Okay? The only difference you would find here is like the neurocognitive decline. So how much neurocognitive decline are we talking about? And there was some given data from phase 2 randomized trials that there was like 50%. But on the retrospective arena, we have like a difference of range of, giving like 30%, 40%, 50%. So you have difference of opinion because of the phase 2 and the retrospective data that you have. So there's pretty much a debate of what neurocognitive dysfunction is and how it's being called. Though there are some tests being used in phase 3 trials, there I'm going to come in as well. So here, the whole evidence is being generated from limited brain metastases, which are called off 1 to 3 metastases. These are phase 3 randomized trial. With no overall survival benefit, either you choose one or other. With a slight cognitive decline dysfunction. Okay. So I'll try to move from here, I guess. Okay. So we know that SRS is highly conformal focal treatment for limited brain metastasis and spares whole brain, minimizing acute toxicity actually. So what's the overall survival of a brain metastasis patients that we usually read and we see in our clinics? 6 months. Okay. And with the new data coming up, we may say that, okay, 9 months to, she showed the data, like there were 3 follow-ups, right? And the third follow-up was on 9 months. And 1/3 of the patient were alive out of 2/3. So with the whole brain, you irradiate the whole brain. So historically, it was used for multiple metastasis, but it does reduce overall intracranial recurrences. The core limitation is that with high intracranial recurrences, this is the issue with the SRS, the new metastasis does develop because it's focal radiation, things pop up. It's a field of, cancerization, pretty much, it pops up at different. So you required MRI surveillance with it. And what is the cost of an MRI that we usually do in Pakistan? So it's a 50,000, or if you do it for free, you have to bring the, the cost of contrast in a resource-constrained setting. So the data, the phase 2 and retrospective does quote around 50 to 80% recurrences within 12 months. And you need something to do about it. You need a salvage treatment. Or you can do nothing, like as the CORS trial, the phase 3 trial, they said, you don't need to do anything, you just keep them on a steroid and they're going to die eventually. You're not going to add any overall survival benefit. So healthcare in Pakistan, we are a population of 230 people. Okay, the GDP that is being associated to us for healthcare is just 1.2%. This is the quote. This is the report from government financial documents. Okay, 70% of the patients are paying their treatment from out of the pocket. This is $38 per capita, like buying a Tylenol from a store or a Panadol. Okay, we have shortage of healthcare infrastructure, medicine, and especially trained professionals. Those who are being trained in stereotactic or stereotaxy or whatever, right, they leave. So 40% brain drain is being reported in the official documents. We have an interesting private and public model. 90% of the patients are being treated at 18 atomic energy centers. 10%, in chunks, we do it privately. So where the patient comes in, pay us, and do stereotactic treatment. So these are some of the programs. They offer stereotactic because I run a just WhatsApp survey. Okay, who's treating what? So I got these centers who offer SBRT or SRS, like for a 230 million population. We have like 3 or 4 institute who offer free of cost radiosurgery. Others are pretty much charging somehow, yes or no, or partially or fully. And we have like 80% recurrence, and we have salvage treatments to do with, and an MRI every 3 months. Very limited data from Pakistan being published. So I got this Shaukat Khanum data, who Akil is the first author. He's doing neurosurgery fellowship now, replacing actually, he replaced me actually, okay, there. And they report their brain failure is around 56%. And they identified that there was a core issue was the lack of novel agents, which improves the survival from maybe 6 months to 12 months or 18 months. Why there is an issue? Because the government is not giving, their priorities are different. It's 1.2%, right? So there's no money pouring in research and development. So you have limited availability of new targeted treatments. And immunotherapy, which is approved from government of Pakistan, would cost you 4 million PKR, which is like a salary of a radiation oncologist who is starting his career here. So how the patient is going to, afford that medication from a phase 2 trial evidence? Challenges. Lack of frequent MRI is one of the limitation. High cost, which is being paid by the patient. Very important. Training program and infrastructure. Lack of that. And if somebody is being trained, so they leave. And there are known barriers of follow-up, because we see patients from Balochistan, we see patients from Afghanistan, we see patients from different other regions. How are they going to do like 3-month follow-up with us? Do we have any setup for teleclinic or no? Or do we have areas where they can have an MRI as a follow-up? So follow-up demand is very crucial for SRS. If somebody is doing SRS from brain metastasis, they need to do 3-monthly MRI. If they say no, we don't do it. And it's a lifelong commitment. Say ye mar raha hai patient, usko aage MRI karana hai. Cost scans, limited MRI availability, travel time of a brain metastasis patient. So salvage burden, repeated SRS, whole brain RT, you need to have it in future as well. And we don't, unfortunately, we have surgeons here, but if you develop radiation necrosis, which is 10% or 20%, who's going to take care of that? Steroids, sometimes yes, most of the time no, and sometimes we need your help. So this is another issue. Cost is another issue that I'm just raising again and again as financial toxicity. Workplace strains. So if you do an SRS, you have to do it within 3 days from simulation to treatment, because they grow and delay in care. We know, we have lack of infrastructure and stuff. Competing standards is whole brain RT. Say it treats micrometastasis. It treats the the area which is going to pop up new metastasis. Leptomeningeal recurrence is going to control that. Less dependence on frequency. Patient don't have to do 3-monthly follow-up. So, but it would have neurocognitive decline. See? Okay, and what we say neurocognitive decline is the short-term memory loss that patient had. Okay, मैंने खाना खाया था नहीं खाया था. Okay, मैंने चाबी कहाँ रखी? They are not like a vegetative, vegetable that they're gonna lie down. They sleep more, yes. So cognitive toxicity is around 20 to 30%, which is being reported in the literature around 3 to 4 months. The key issue is memory, impairment, attention, dysfunction, and quality of life impact. So, but with the SRS, you have being reported as a standard comparative arm around 24 to 54% in different literatures. So, you have a neurocognitive dysfunction even with the SRS. So, what we can do? Bring in the solution Like can do like two things with them: hippocampus sparing and memantine. This is simple, straightforward. You draw hippocampus, you draw the whole brain, you carve out the hippocampus, give a 5 millimeter, and put your dose constraint over it. So systemic advancement, modern systemic control, ALK, HER2, BRAF, you have Destiny trial, you have checkmate trials, you have these trials. These are, they have like very good blood-brain barrier ability that they go on, but are they available here? Does it imply to us that, the data from developed countries? Immunotherapy, 4 million rupees, one cycle, does improve a lot of overall survival. I had an opportunity to, to see the McGill data. And those who had targeted mutation, who were on targeted mutation and have access to immunotherapy, they usually lived, more than 6 months, a year or maybe more. So, and with all the stuff, I'm just gonna, bring in to the end. For us, distal recurrences because of burden of imaging follow-ups, limited MRI access, and infrastructure and specialized program where we are trained with. Okay, agar hogi ye radiation necrosis, so how would you call it? How do we, do we have like a fusion imaging that we can, fuse our image to call it as a radiation necrosis or no? Or we treat it again and again the same area. Okay, पहले dose कम थी क्योंकि वो critical organ से करीब थी. And lack of availability of new drugs. So these are some of the scaring facts from our society. So, but I'm an advocate of SRS, okay, but it has to follow some basic rules. Patient needs to be fit, excellent performance status, need to commit a reliable follow-up, whatever if it, and there should be targeted treatments and immunotherapy availability as well, and they need to have like a very strong preference to preserve their neurocognitive nation, and they need to have a neurocognitive definition as well, what we are expecting. Okay. Otherwise, whole brain hippocampus sparing is a good option, a very pretty decent option. It's being reported, like Brown et al. In NRG 2019. You reduce the neurocognitive dysfunction to approximately, relatively to 20%. So what we are gaining here then? So my takeaways, SRS is an excellent focal treatment, but you have recurrences, frequent MRI is needed. Whole brain does have favors, but neurocognitive is at risk. We can't just say no to the evidence, but individualized decision is very important. As in, we need to discuss everything that, okay, this is your disease, this is your systemic disease, and you have these constraints as well. We just can't say, okay, this is the literature, you go, you sell your stuff, and just do SRS because this is the evidence of, this is the evidence of today. So for me, all patients has to be given an informed options, what we are going on, what we are going to treat you with, and what are the practical application or implication that aligns with it, and let them decide. So this is my side of the picture. Thank you very much.
I think, thank you very much for, please take your seat. I think we're running short in time, so we'll just have a quick few questions if you allow. One or two, just quick ones. Or if you want, I can just...
Excuse me, sir.
Dr. Hashim.
How many days you spend, excuse me, question from the last speaker, how many days you spend for the whole brain radiation?
So usually the criteria that we follow is 5 days of treatment.
35?
No. It's a 5 fractions, 5 din. 5 days, yeah.
5 days.
Yes, usually. So, and just want to add one more comment to that. Usually, patients are, the practice is being shifted from single fraction to fractionated. So 3 fraction and 5 fraction is going to be the norm in future, especially for those who are more than 2 centimeter lesions or post-operative. So it's going to be the same treatment days.
So I think I really feel for Aga.
One more question.
Sitting in here with plenty of people who've got backgrounds.
But I'm on.
Everybody is supporting
Only one thing that we both are living in the same city, isn't it? And,
Sir, I am an SMCN. I came in 2012, took your interview for my magazine.
My question is, you told about that we are receiving patients from Afghanistan,
Yeah.
we are receiving patients from Balochistan. So if you are going to ask him stay for 5 to 10 days in the hotel for the radiation, is it better, or for we peoples in Gamma Knife we just do it in one day? Was a cost effective, single session.
Yeah.
I think you've all heard of all of
Which one
it.
is cost effective?
Yeah, please.
Sir, it's 1,000 rupees per day for a normal routine hotels in Karachi, which are nearby the hospital.
No, I don't think. The minimum is 5,000.
This debate should not be about hotel costs. I
Yeah,
think
yeah.
Ala Ahmad has done a fabulous job. Education,
Yes, yes.
he's speaking against the standard of care. The issue should be that we should individualize patients. बलूचिस्तान से एक पेशेंट आके होल ब्रेन का कैंडिडेट भी हो सकता है और एसआरएस का कैंडिडेट भी हो सकता है, तो वी शुड नॉट बी फोकसिंग ऑन दिस थिंग कि इजी उसके लिए क्या होगा, बेहतर उसके लिए क्या होगा.
तो सर,
Of course, उसने आगा हमाद ने ये भी कहा है कि वो वापस जाके एमआरआई नहीं करा सकता. आई थिंक somebody would buy this argument, somebody would not buy this argument. इसकी बेस पे भी हम सिर्फ ये डिसीजन नहीं ले सकते कि वापस एमआरआई कराने के लिए नहीं आएगा, मैं नाराज़ हूँ तुमसे, मैं तुम्हारी एसआरएस नहीं करूँगा. वी हैव टू डू एसआरएस फॉर सच पेशेंट्स एंड होप फॉर द बेस्ट. बट अगेन और बहुत से फैक्टर्स आ सकते हैं. फर्ज करें हरसेप्टिन का कैंडिडेट है, हरसेप्टिन अफोर्ड नहीं कर सकता, आप क्यों एसआरएस पे पैसे वेस्ट करना चाहते हैं? होल ब्रेन रेडिएशन करें और let him go. So there are so many factors which are deep rooted और दाएं बाएं की चीज़ें जिनको consider करके you have to decide कि आप इस patient के साथ क्या करना चाहते हैं. कोई एक रेसिपी नहीं है कि ये बस.
I think that's very well said. Overall, if we have to conclude the session, I think it's a multifactorial entity. There is no black and white here.
Yeah.
Primarily, we're the clinicians. We have to sit by the side of our patients. We need to find out what best way we can help our patients, whether it's a whole brain in his kind of situations. Overall, it's going to be a palliative situation. The goals have to be set there. If the patient is somebody who's going to benefit from whole brain, if it's a leptomeningeal disease, got a lymphoma recurrence or multiple recurrences, you exhumed SRS, probably they are fair indications of whole brain treatment. Yes. Contrary to that, if somebody is in a good shape, has got more prospects in systemic treatment available, probably I would go for SRS as a priority, isn't it?
And in addition to this, I want to add that in stereotactic radiosurgery, we have our own indications. For example, our published literature shows that 1 to 10 small brain mets, the total volume is 25 cc or ml. Okay. More than that, we always said for whole brain radiation therapy. Okay.
एक और proverb है, if you have a hammer in your hand, everything looks like a nail. तो वो अगर आपके पास सिर्फ whole brain radiation है, आप कहेंगे मैंने सारों की whole brain.
Sir, may I interrupt for a while, please? Because this is a debate, it will not end by anyway. We know that. So, we are 20 minutes late. बुरा ना मनाइएगा. Faculty will be going to the Ambassador 3, and you people, everyone will be joining us on pool side for tea break. Because we have to start 11 o'clock next session, but we are late, so we will start at 11:15. 11:15 बजे हम अगला session start करेंगे. So we will have a discussion over the tea, please. Sorry for interruption. Thank you.
मैंने एक क्वेश्चन ये पूछ रहा था कि आप लोग सब पेशेंट जो ब्रेन ट्यूमर के साथ आते हैं इनकी हिस्टोपैथोलॉजी करते हैं या बस करते हैं? इंग्लैंड में तो करते हैं, यहाँ नहीं करते। ये मेरा एक क्वेश्चन था। हाँ, ये मेरा क्वेश्चन था। दूसरा ये था कि व्हाट शुड बी द गैप बिटवीन होल ब्रेन एंड SRS अगर डिफरेंस है या न्यू सम
Assalamu alaikum, everyone. I'm Dr. Sarish Abrar, and we are starting our session. Kindly please be seated, everyone. So my name is Dr. Sarish Abrar, and I'm a radiation oncologist. I'm working in SIUT Hospital, Karachi. So I'll be moderating the session today, and I warmly welcome you all in today's session, which is packed with a series of talks which are going to touch the very challenging areas in the management of hepatobiliary and GI malignancies. So before starting our series of talks, I would like to introduce you all with the chairperson of the session, who is Dr. Mohammed Fahim. Dr. Mohammed Fahim he needs no introduction. He is the president of ARO, so I would like to request Dr. Fahim to have a seat. So in our panelist, we have Dr. Siraj Abbasi, who is working in SIUT Sakkar. Please welcome, sir. And another panelist is Brigadier Shahid Rasool. He's working in Cancer Care Hospital, Lahore. So this is a surprise for you. So I am calling our first speaker, Dr. Kurratulain Badr. Dr. Kurratulain Badr is currently working as a consultant radiation oncologist. Acha, I'm so sorry. Okay, I didn't see you. So another panelist is Dr. Hafiz Khush Naseeb. He's a director of Sinar. So Dr. Kurratulain Badr is currently working as a consultant radiation oncologist at Ziauddin Hospital. She did her FCPS from AKU in 2012. She has a special interest in breast and GI malignancies. Dr. Kurat will be talking about esophageal cancers, critical appraisal and practical implication of the landmark trials in LMIC. Presenter's opinion.
So, Assalamu alaikum to all of you. It's an honor to present here in front of my teachers, especially Dr. Fahim and Dr. Romera. So I'm going to talk about, as Dr. Saris said, that it's a critical appraisal and practical implications of the landmark trials and LMIC. And it's my own opinion, so maybe you don't have to agree with it, maybe. Okay, so my mentor and my teacher, Dr. Nadeem Abbasi, always taught us to do a critical appraisal whenever you are seeing a new literature or a new trial. As we all know that most of the trials in esophagus, they have combined both squamous and adeno, which represents biologically and therapeutically distinct entities. And most landmark trials combine histologies under one uniform treatments and paradigm. Survival gains may be driven predominantly by one histology, so one size does not fit for all. SCC predominates in the LMIC Asian population and is highly radiosensitive, as we all know. Adeno is overrepresented in the Western trials. And landmark trials demonstrate efficacy under ideal conditions, and reported benefits may not be equally applicable, safe, or necessary considering our own population. So real-world LMIC practices faces limited surgical expertise, high esophagectomy-related morbidity, mortality, and restricted access to the intensive surveillance if we kept the patient for definitive CCRT. LMIC must prioritize acceptable harm, as we all know, because we are in a resource-constrained country. So evidence is essential, but unexamined evidence can mislead you. So you have to do your own judgment before deciding for any treatment for a patient with esophagus. So esophageal cancer has significantly evolved over time, the treatment of the esophagus, transitioning from primarily surgical resection in late 90s to a multidisciplinary approach that incorporates neoadjuvant CCRT for locally advanced cancers with recent advancements, including the integration of immunotherapy, particularly for advanced stages, especially in the adenocarcinoma. Coming to the landmark trials. So this is RTOG 8501, and Dr. Sarish, for your surprise, it was the first article which we have done the critical appraisal in my residency along with Dr. Nadeem Abbasi and with my another colleague. So this was the first trial for which we have done the critical appraisal in my residency. So it was initially published in 1992, NEJM, but we is still, referring this trial in our current practice as well. So the follow-up findings were published in JAMA in 1999, and that is chemoradiotherapy for locally advanced esophageal cancer. This trial have two arms. One is CCRT, that is chemoradiation, and another is radiation alone. And there was no surgical arm in that trial. Surgery was the mainstay of the treatment in that era, but that has not been the part of that trial. So I'm not a researcher, so I don't know about the difficulties in having a trial with the three arms, but that is my clinician point, that there was no surgical arm and CCRT was compared with the radiation alone. It was dominant by the squamous, 88%, and 12% were adeno. RT dose was 50 gray in 25 fractions, and chemo was cisplatin 5-FU. As we all know, that is 2 cycles concurrent and 2 cycles adjuvant, and it was compared with the 64 gray of radiation alone in the second arm. And they have showed that at 5 years, the combined treatment arm has 26% survival as compared to 0% in the radiation alone arm. This is the 5-year survival. Combined arm is 27% and RT arm has 0%. And significant survival advantage of combined CCRT was at 8 years was 22%. In adeno and squamous, there was not a much difference among the CCRT group. Coming to the MAGIC trial, and it was asked in my exam by Dr. Fahim as well. So there are a lot of memories actually attached with these trials. Okay, so MAGIC trial was regarding the adeno-CA, and that is a perioperative chemotherapy versus surgery alone for resectable GE junction cancers. Most of the patients have stomach, lower esophagus, and GE junction. Again, in that trial, there was no CCRT arm. As for the standard was CCRT, but the CCRT was not included in it, and it was compared by perioperative chemotherapy versus surgery alone. So in patients with operable gastric or lower GE junction, a perioperative regime of ECF decreased tumor size and stage and significantly improved progression-free survival and overall survival. And after these trials, the standard of care in the early 2000s after RTOG and MAGIC was, based on these studies, was for the squamous, we were considering definitive CCRT, and the esophagectomy was only reserved for the residual disease. And for adenocarcinoma, the best option was perioperative chemotherapy and surgery, except for few cases for definitive in which it was an unresectable disease. But then came the CROSS. CROSS has a trimodality. Before that, for adeno, there is a bimodality, chemo plus surgery. For squam, there's a bimodality with chemo plus radiation. But then the CROSS came, and it showed that the trimodality has a significant survival advantage. So whenever I saw the CROSS, I have reservation with that trial, and with due apologies to the authors who has done a wonderful job, but for me, it was not acceptable because in that era, they have compared the CCRT plus surgery with the only surgery thing. Surgery was not standard in that era. Surgery alone was not standard. You have to add some modality along with the surgery. So 10 years results also showed the significant advantage of the combined modality. Points of concern are, so there was no definitive CCRT arm and the perioperative chemotherapy arm, which were the standard of care in that era for squam and adeno, but that was not the part of our trial. So, we have to critically appraise it as well, because we all have accepted the CROSS, But compared with the surgery alone, not a standard treatment in that era, all patients planned for surgery, and they were mostly T1 to T3, N0, N1. There was no T4. RT dose was 41.4 gray, less than preoperative doses used in the previous trial. And as a radiation oncologist, we can say that maybe this is just a homeopathic dose, because we have never, for this SQAM, we have never think about 41 gray, but they have used 41 gray. The only positive thing about that trial for me, so that is a presenter opinion, that is a carbotaxol. Because cisplatin 5-FU toxicity is lot, and most of the patients were not able to receive the adjuvant cycles when we followed 8501. But this trial gave us the beautiful regime of carbotaxol, which is very acceptable toxicity. In this trial, 75% patients have adeno, and only 23% has squamous. But we accepted this trial for all of us patients, irrespective of the histologies. Mostly distal, because more was the adeno, and so there was more distal and G-junction tumors. 23% adeno had PCR, and 50% squam had PCR with the dose of 41 gray. So you can think that if you raise your doses, which we normally use, that is 50.4 gray, you can change your PCR rate more than that. With the dose of only 41 gray, you have achieved 50% complete response on the surgical pathology with the squam histology. And surgery alone, 70% R0 resection, and trimodality, 92% R0 resection. For me, I think the aim is to evaluate benefit of adding radiation in adenocarcinoma, but I think like in other trials, they have, for the accrual of the patients, for completion of the number of patients, they have included the squam as well. I think they have, it's for adeno mostly, because they have just seen the addition of the radiation in it. And in the follow-up, at 10 years, there was a difference of 25% versus 38% for the overall survival. Median overall survival was 48 versus 24%. For the squam, that is wonderful, 81 versus 21%. For the adeno, it is very close, 43 to 27%. Same with the progression-free survival. It prefers the squamous cell carcinoma, 74 versus 11.6%. So the best results for the neoadjuvant chemoradiotherapy plus surgery was seen in squam, maybe because of the good pathologic complete responses. And 50% residual tumor had a significantly worse overall survival as compared to patients without residual tumor, or patients with 1 to 49% residual tumor. So if you had a good PCR, then you had a very good survival as well. But look at the complication rates in that trial. They are almost, the morbidity is 50%, the pulmonary leakage, cardiac complications. And you can think about it that these morbidity can be converted into a mortality in our region, because they have done in an experience centers, but still they have around 50% morbidity in this trial. After cross, standard of care was trimodality, irrespective of the histology. And NCCN also incorporated this in their algorithms, and they have removed the definitive CCRT, and they have only preserved the definitive CCRT for the unresectable diseases at that point. So trials create evidence, clinicians create relevance. Following evidence blindly is not evidence-based medicine for me. So coming to the recent studies, this is for the squamous, there's a Cochrane review, and which showed that available evidence, the addition of esophagectomy to chemoradiation in locally advanced esophageal squamous cell carcinoma provides little or no difference on the overall survival, and may be associated with higher treatment-related mortality. For the Stack et al., it showed again that for the squam bimodality, that is chemoradiation, there is no difference in the 10-year survival when you add the surgery as well. For the adenocarcinomas, they have compared ECF with the FLOT, and they have showed that the FLOT has a good results in adeno. Again, the bimodality, chemo, perioperative chemo, and surgery. ESOPAC compared the cross modality with the FLOT, and they showed that the perioperative chemo plus surgery is better than the cross trimodality. So ongoing trials are, one is the SANO trial, which has the initial results of the 2 years presented at ESMO. Again, they have, they have mixed up the squam and adeno, but they have showed that keeping the patient on surveillance after getting a CR, the complete response, you can keep the patient on the surveillance, and it has a advantage on the survival, 75% versus 70% of the patient which have undergone surgery. The next is the NEEDS trial, which is completing the last. Okay, the NEEDS is, it's again the ongoing trial, and it is for the squamous, and it is again with the same treatment regime, that keeping the patient on the surveillance after getting the CR. So this is just our data of the response after definitive CCRT of around 50 patients. Dr. Asma, this is Dr. Asma's Khan work, and this is what we are showing, that for the squamous, we have a good PET response rate of 55%, 73% of the pathologic complete responses, which are more than the cross modality. So this is again incorporated in the NCCN now, that for the squam, you can keep the patient on surveillance after getting a complete response. And for the adeno as well, they have incorporated this after SANO initial results. So in conclusion, for the squam, predominant in the LMIC population, evidence must be adopted, not adopted. Definitive chemo-RT remains a rational, evidence-based standard when resources and patient factors are considered. For adeno-CA, landmark trials inform strategy, but outcome in LMIC depend on patient selection and system capacity. Contextualized multimodality care is superior to protocol-driven care. And remember that landmark trials guide practice, but do not replace judgment. Thank you so much.
Thank you so much, Dr. Kuratilan Badar, for this enlightening talk, and you showed a very impressive data from your institute. So our next talk is our next speaker is not present here, Dr. Jamal Khadar, and he was supposed to talk about the role of the SBRT in pancreatic cancer. So we are moving towards our third talk, which is by Dr. Yasser Inam. And Dr. Yasser is a senior instructor in clinical oncology at Shaukat Khanam, Peshawar. He holds FCPS in radiation oncology, and he has a site-specific interest in GI, GU, and head and neck cancer. Dr. Inam is going to talk about the optimizing perioperative chemotherapy in gastric cancer protocols relevant to our population and service. Over to you, doctor.
Thank you, Dr. Sehrish, and good morning, everyone. First of all, thank you to the organizer of ONCO 2026 for giving me this opportunity. For the next few minutes, I'm going to talk about the role of perioperative chemotherapy and the protocol relevant to our population and services. So I have no conflict of interest to declare. The objective of my presentation is to understand the rationale for perioperative chemotherapy. We'll go through some major clinical trial and latest evidence, and we'll also explore the role of targeted and immune therapy in neoadjuvant setting in gastric adenocarcinoma. So we all know that gastric cancer is the leading cause of cancer death worldwide. Surgery alone has got poor outcome with high recurrence rate and overall survival of just 23%. Perioperative chemotherapy does improve the overall survival, and the role of targeted and immune therapy is emerging. So currently there are so many options available for locally advanced operable gastric adenocarcinoma, but I'm going to mainly focus on the perioperative chemo approach. So the question is, can we improve the outcome with the addition of perioperative chemotherapy, and what is the rationale for perioperative chemotherapy? So yes, perioperative chemotherapy downstage the tumor, it target the micrometastasis, and it improve the negative resection margin rates and overall survival. So these are the few landmark trials which I'm going to discuss in a few minutes. So to test this hypothesis, the first trial was a landmark trial, MAGIC trial, which randomized 503 patients of locally advanced gastric adenocarcinoma and GOJ into surgery alone versus perioperative chemotherapy, ECF, 3 cycle followed by surgery, and then further 3 cycle of adjuvant chemotherapy. So this trial clearly demonstrates that perioperative chemotherapy does improve overall survival, and the overall 5-year overall survival was 36% for the perioperative arm versus 23% in surgery alone. And similarly, there is a clear benefit in the PFS as well. So after the MAGIC trial, perioperative chemotherapy was the new standard of care for locally advanced operable gastric adenocarcinomas. So the summary of this trial, PFS and overall are significantly better in perioperative chemotherapy arm. There was estimated improvement in the 5-year survival rate was 13%, local failure rate was 14 versus 21%, and the distant metastasis rate was 24 versus 37%. So another trial, the French FNCC trial, which actually introduced a true drug regimen of cis-5FU to avoid the toxic effect of epirubicin. And this trial compared 224 patients were randomly assigned to surgery alone versus 2 to 3 cycle of perioperative chemotherapy with cis-5FU followed by surgery, and then adjuvant 3 to 4 cycle of cis-5FU. And this trial also showed that the 5-year DFS for perioperative was 34% as compared to 19% in surgery alone. And the 5-year overall survival was also better, which was 38% versus 24%. This updated meta-analysis, which was comparing different perioperative chemo protocol from different trials, concluded that the new adjuvant chemotherapy was associated with a statistically significant benefit in terms of both overall survival and PFS, and new adjuvant chemotherapy was also associated with significantly higher negative resection margin rates, and the perioperative chemotherapy did not worsen post-operative complication and perioperative mortality or grade 3 or 4 adverse side effects. So the most important trial is the FLOT trial, and this FLOT trial randomized 716 patients into perioperative chemotherapy of FLOT versus ECF or ECX, and the 3-year overall survival for FLOT was 57% versus 48% in ECF or ECX arm. The post-op complication and serious adverse event were similar, and the or not resection rate was 85% for FLOT and 78% for ECF or ECX arm. So after FLOT, the current and the new standard of care is perioperative FLOT. So the most important question is, every patient is a FLOT candidate, or is every patient will be able to tolerate FLOT, particularly in our population? And we all know that most of these patients present very late and they remain nutritionally depleted for a very long time, which lead to weight loss, frailty, and poor recog. And there are also associated comorbidities, and hence these patients are not a candidate for FLOT. So, and if you still want to treat these patients radically, so there is the alternative reasonable option is perioperative FOLFOX 4 cycle, then surgery, and then adjuvant FOLFOX 4 cycle. Although there is no level 1 evidence available for this, but this evidence, this is extrapolated from the other trial like Classic and Resolve trial. So here is the story, surgery alone. Initially the treatment was surgery alone with a poor outcome, with overall survival just 23%. Then came the MAGIC trial, which showed a clear improvement in the overall survival, and they showed that with perioperative chemotherapy, the overall survival improved 36%. And then the latest is FLOT, which showed overall survival of 45%, and hence the FLOT is the current standard of care for perioperative chemotherapy. So here is the interpretation. The MAGIC said there is a survival benefit of perioperative chemotherapy. The FNLCC said that there is an equal survival benefit of perioperative cis-5FU with the avoidance of toxic effect of epirubicin, and FLOT said that there is added survival benefit of FLOT over ECF with similar toxicity profile. So far we know that perioperative chemotherapy is the standard. It does improve the overall survival. But is there any benefit of adding CRT to the perioperative chemotherapy? So initially it was suggested in multiple phase 2 trials that yes, there is some effect of CRT in improving the survival and outcome. But then the Top Gear trial, which demonstrated that adding CRT to the perioperative chemotherapy improved the resection rates and PCR rates, but it failed to demonstrate overall survival benefit. And so in the conclusion, the patient with resectable adenocarcinoma of the stomach or gastroesophageal junction, the addition of perioperative chemoradiotherapy to perioperative chemotherapy did not result in longer overall survival, and hence adding CRT to perioperative chemotherapy is not beneficial. So what is new? Is there any role of immunotherapy in neoadjuvant setting? To answer this question, the Matterhorn phase 3 double-blinded randomized controlled trial randomly assigned patient into 2 arms with durvalumab and perioperative chemotherapy FLOT versus FLOT and placebo. And it clearly showed the improvement in EFS, DFS, and overall survival. And the overall survival at 36 months was 61% in the FLOT plus placebo arm and 68% in durvalumab plus FLOT arm. So in summary, the perioperative chemo is standard for locally advanced gastric cancer. FLOT is the current gold standard. The role of targeted and immunotherapy is promising and emerging, and molecular profile before starting treatment is essential. Thank you so much, everyone. Thank you.
Thank you so much, Dr. Inam, for highlighting such.
Sarish.
Yes, yeah.
We can take questions. We
Yeah.
have got time.
So if the audience has any question from Dr. Badr or Dr. Inam, we can take the questions. Yeah, Dr. Irfan.
Irfan.
Mike.
You have shown that after the complete response, you can just
Mike, then go.
keep the patient on follow. Can you tell me what is the safest modality to predict about the complete response after this one chemoradiation in esophageal squamous cell carcinoma?
So there are 2 things, obviously, that is PET and the endoscopy plus biopsy from the same site of the lesion, the biopsies. If the PET is negative and the endoscopy plus the biopsy is negative, you can safely say that the patient is likely having a complete response.
What's the optimal duration? Because after chemoradiation, that particular area will still have some sort of avidity.
So,
So
yes.
the radiologist is always confused that this is residual disease versus
Exactly.
post-op
Yes, exactly.
post-radiation changes.
So what my practice is to do the first scan after 10 weeks, not 12 weeks, because you have to keep in mind that if there is any residuals, you have to send the patient for the esophagectomy, and for the good time for the esophagectomy is within 12 weeks. So first scan I do at 10 weeks. If it is showing very less avidity and it is towards showing the post-operative, post-radiation changes, then I'll do the endoscopy and the biopsy. You are absolutely right that the next PET shown the decrease in the avidity as well, and that is shown by the Dr. Asma's results in our study, that the second PET is, if the first PET is showing any residual activity, in the second PET that is completely resolved. So that is only the post-radiation changes. So usually I keep my follow-up, the first is at almost 10 weeks, the second is at 6 months, plus endoscopy and biopsy.
Thank you.
Okay.
One question. I have a question.
Yes.
If PET is negative, very less avidity, and if endoscopy showed no residual or no suspicious lesion, then you also do biopsy to confirm the pathological CR to label this patient on your first follow-up?
Ideally, the biopsy has to be done, but if the gastroenterologist said that there is no lesion from where I can biopsy the lesion, yeah, so you can keep it as a positive thing, and you can just have the
label
second.
this as a pathological
yes. Ideally, you have to do the biopsy, and I like my gastroenterologist to do the biopsy, and they usually do it. In 99% of the cases, they do it. Okay, thank you.
Thank you so much, Dr. Kurathalan. So moving forward, I'm going to introduce our fourth speaker, Dr. Mohammad Ramzan. Dr. Mohammad Ramzan is a highly experienced interventional radiologist with extensive expertise in both the diagnostic and intervention radiology. He currently works as a consultant radiologist at PKLI Lahore. His broad clinical practice spans adult, pediatric, and neuro-interventional procedures, and he is recognized for delivering advanced, minimally invasive, image-guided treatment for wide range of complex condition. So he is talking about the targeting liver tumors from within, the role of radioembolization.
Thank you very much. It was a really nice introduction. I really myself don't know. So I'm working as an intervention radiologist, so I'm going to talk about radiation, but it's not the external, it's the internal radiation. So the targeting from within, so what exactly we're injecting within the liver in liver tumors, metastases, cholangiocarcinomas. So I'm going to talk in next few slides about what exactly the basics are for this, like radioembolization, no disclosure. Liver cancer is the sixth most common cause of, you can say, death in overall in the world, and it's the, I think in Pakistan it's prevalent, and everywhere you have a lot of patients we see in our MDTs. I will not go into these details. So what exactly the radioembolization is? It's actually selective internal radiation therapy. We inject the radioactive material within the tumor from the arterial system, and yttrium is used in this system, and we have like glass and resin sphere in the markets which are used for this radiation therapy. What exactly the radioembolization is, actually it has curative as well as the palliative role, and we can target the lesion. What my experience is and what I want to say here, the tumors which we can't do like RFA or resection, they are bigger tumors, but they are well localized to the liver. So we can have a curative response in such tumors, like if the tumor is more than 5 centimeter and it's between 8 centimeter, you can get the curative response in these cases. And bigger tumors, you can downstage for the liver transplant, and even for the bigger tumors with portal vein invasion, you can have the palliative intent. And it's well tolerated. The embolization syndrome as compared to TACE is much less, and it's well tolerated by the patients actually. What exactly? It's a localized high radiation, beta emission, 64.2 hours is the half-life. It penetrates 2.5 to 11 millimeter. So anything very close to the liver is not affected by the radiation, and it is resin and glass spheres. So we all know the BCLC staging. I will not go into the details. Very early stage is small tumors. Early A stage is for resection, ablation, or liver transplantation. Intermediate or B stage, we can do some, in some cases, selected cases, liver transplant, in others we can't do. So here the role of radioembolization comes in. And we can do radioembolization to downstage the tumors, and then the radioembolization has a role in stage C tumors. From stage C, very selected tumor, we can bring down to make these patients suitable for transplant, or we can increase the overall survival benefit. Our radioembolization can be used in combination with other therapies like immunotherapies or other systemic therapies like sorafenib, lenvatinib, or sometime if there is some residual disease, we can use SBRT. So in combination, you can get a really good response. What exactly we are doing? These are further guidelines by BCLC, EASL, American, European, and Chinese, and there is a role of radioembolization in HCC. So to start, what exactly we do? When the radioembolization started, there was standard dosimetry that we inject this yttrium spheres non-selectively. So the liver tumor and the normal parenchyma were both affected. In these cases, the dose was very low, like 120, to save the liver parenchyma, and the results were not that great because we need higher dose for the to burn the tumors. So then the personalized dosimetry came in, and the personalized dosimetry is the actually thing that we have to give higher doses to the tumor actually. So it is multi-compartment and single compartment. The target is to at least give more than 205 gray to the tumor or the adjacent renal liver parenchyma. We calculate liver volumes, we look at what exactly is left behind, and that's why, and we can go up to even 400 or 500 gray in these cases. And as you increase the dose, the rate of necrosis will increase, and you can even get up to 100% necrosis with the higher doses like 400 and 500. So what exactly we do like curative tears or radioembolization. It can be a bridge to transplant, or it can be a palliative. Patient selection is, we look at this tumor size. We usually go for unresectable HCCs, but there is a role of radioembolization in colorectal metastasis, neuroendocrine metastasis, cholangiocarcinoma, mets from melanoma, liver-limited disease again, and breast, where the liver-limited diseases, and we have exhausted all other options, then the radioembolization come in and we can burn the tumors. BCLC stage, B or C, no extrahepatic disease, and tumor is not amenable to surgery or ablation. So anything which we can do, resect or ablate, we don't offer because it's an expensive procedure. Again, the liver functions should be good. We target only those patients with a good liver functions, like child 2A or B, early B, not the B8 or onward. Up to B7, we try. Bilirubin level, we can go up to 3, and ECOG level from 0 to 1. So we need a good performance status because you're spending a lot of money in this procedure. And we also want to know the arterial anatomy because we're going in and we're targeting the tumor from within, and we want to know what exactly the arterial supply is, and from where we can target the lesion nicely. And again, the last thing is the lung shunt. Lung shunt is what exactly we are injecting. It's also going into the lung, so it should be less than 20%. Anything more than 20 will cause fibrosis, and we don't do radioembolization. Contraindication, again, the child C patient with poor performance status, extrahepatic disease, if the bilirubin is more than 3, and if the lung shunt is more than 20, we don't do. And the liver volume, residual liver volume in cirrhotic patients, it is around 60% because the liver is not normal. And the normal liver, it's 70% of if it is involved, and need 30% of the residual tumor volume for the function actually. So these are various, you can say, scenarios which we come across. I will discuss a bit in detail. The first two, radiation segmentectomy and radiation lobectomy, is actually the curative. The next three are actually palliative, and like we can see multifocal unilobar disease without macrovascular invasion or portal vein thrombosis. It can be in bilobar disease or HCC with macrovascular invasion. You can do radioembolization even with the portal vein involvement up to like even if the right or left branches are involved, and if there's a good function, liver function. So these are the what's happening. So for the scenario 1, radiation segmentectomy, it's a curative thing, and there's a strong evidence, strong consensus for the radioembolization. Radiation lobectomy has a similar thing. Again, it's a curative, and more than 80% consensus. And 3 is palliative. Here we target the tumor, save the liver, and we can use for the future treatments actually. Again, the evidence is strong. And stage 4 multifocal disease, bilobar disease, is again palliative, and you can use with combinations with other like immunotherapies or other therapies which are available, and we can target. Again, the evidence is strong for these. The evidence for the like a macrovascular invasion is moderate, and consensus is moderate. Again, palliation, but you can get the good palliation and long-term survival with radioembolization, and it's better tolerated than the TACE actually. What exactly the baseline is. Technique, what exactly we do cross-sectional imaging like CT and MRI, and then we look at the anatomy and we evaluate the patient. We do arterial mapping, angiography, embolize the non-targeted vessel, inject MAA, technetium MMA, measure the, do the SPECT, lung shunt, measure dose, order the dose, we do tear, and after the tear immediately we do PET CT to see the distribution actually. Post-procedure is a single day procedure. You can send the patient home like the same day, and we do follow-up in 3 months. We don't do follow-up in 6 weeks or 8 weeks or 4 weeks. The reason is it works in 3 months. If you do early, that will confuse you what exactly is happening. So benefits, I will not go into these details because the minimal side effects, portal vein thrombosis, what exactly we have already discussed. So these are the differences between TACE. TACE actually block the vessels. The post-embolization syndrome is high, but the cost is low. In this case, we don't block the vessel actually. The radiation is working. We can use single session actually, but the only thing which is negative is the cost, and that's very high cost. These are few trials as the Lewandowski, you can say the published in 2018 that any tumors of single lesion less than 5 centimeter with child A had a really good survival rate of 98% at 1 year, 66% at 3 years, and 57 5 years percent patients. And in smaller tumors, if you look at 3 or less than 3 centimeter, the survival was 100, 82, and 75%. Should we continue?
नहीं लगी
अच्छा नहीं लगी इतने डर ही लगता है जी. And then was the legacy, you can say the study, that targeted from 2.7 to 8 centimeter, and the survival again was 86.6%. Here the dose was used that was personalized dose, and that was up to 410 grays. So then is the dosisphere study, which shows actually the personalized dose has a better survival than you can say the standard dose. So I'll go with my cases now. This was young patient, 32-year-old, A6, 6 centimeter lesion with portal vein invasion, good performance status. Transplant we can't do because of the portal vein invasion, and we plan to go for radioembolization. So if you look at, there was segment 7 lesion actually with portal vein invasion. These are the images. We'll go next. This is again the same like pre-tear CT. You can see the tumor here, and I will skip. This is how we do angiogram. This is the one of the angiogram for the shunt study. We do shunt study first. This is the SPECT CT after we inject for the shunt actually, and we calculate the shunt here. Once the shunt is done, we do the radioembolization actually, and it's the same like we do TACE actually. And this is the post injections PET CT, and you can see this lightened area is the tumor area, and you can see how nicely it is covered. And it gives you the confidence what we have injected, it is in the right place actually. We did follow up. So if you look at it's a filling defect actually. Everything is gone. It's completely burned out. This is how the radiation works here. This is these are static images. You can see very clear-cut margins, whatever the vessel we have injected, and you can see the vessels are patent inside actually, so we don't block the vessels here. Case 2 was a 72-year female with HCV, large tumor that was involving like portal vein, and even the biliary channels had PIVCA 40 plus, and AFP was 746. Her performance status was 1, and she was by B7. So we did imaging, and segment 6-7 infiltrating tumor with portal vein and biliary invasion. These are the images, static images. You can see the tumor here. This is pre-tear CT. It's a video, and you can see the tumor here at the segment 6 and 7. It was a large, big tumors. No other options apart from chemo or systemic therapy. MDT discussion, decision was TACE plus systemic therapy. We opted for TARE and immunotherapy. This is how we do actually. This is the angiogram. We do cone beam CT at the CT within the angio machine to look at the exactly mark the area, and it all rotates like anything. So this is the injection of radioembolization material, and you can see here it is nicely covered by the yttrium. By the way, the oncologist did CT 1 month after the injection, and this was initial CT, and we have a really good response over here. You can see the patent vessels over here, and this is video for the same. And you can see here, it's a nicely targeted and burned out lesion actually. So there are another couple of images. So the AFP went down to 15, and she is tumor-free on CT. Last case, I will quickly go through, had 2 tumors and 3 supplies. Actually, we can calculate the different doses. So here you can see there's a large big tumor with a nodule here, and there's one at the bottom actually. So this is how it appears on the angiogram, and this is how we calculate actually. There are 3 vessels actually, so we have to inject, order 3 doses and inject separately. We calculate the volume like this, and we order the dose accordingly. This was PET after injection. So it was nicely covered, and at the end it was all burned actually. So the TARE is a minimally invasive treatment for not only HCC, it's for cholangiocarcinoma, metastasis, neuroendocrine tumors, and we can use like TARE for complete downstaging, and we can achieve the 100% necrosis. It can be used, it's ideal for patients with portal vein involvement. The options are curative and palliative, and combination we can use, but keep in mind one thing, go through the MDT, hepatobiliary surgeon, hepatologist, oncologist of course, and the intervention radiologist should be on the board. Thank you very much.
Thank you so much, Dr. Ramzan. We can take 1 or 2 questions from the audience.
Dr. Ramzan, sorry. I'm Dr. Mohammed Ali. I'm also an intervention radiologist in Ziauddin Hospital. So Dr. Ramzan, I just want to ask 2 questions.
एक पे गुजारा करो यार.
आज एक हो सकता है. चलेगा. So we have done one case. We have downstaged the patient with TARE. The patient has large tumor in the right segment 6, and then we perform the TARE. And the patient also has right portal vein invasion. And the patient in the subsequent PET CT after 6 months, the patient has complete response to TARE. And then we do the transplant last year in February 2025. So we do the TARE at Ziauddin Hospital in April 2024, and then after 1 year we perform the transplant as well. So as PKL is also a one of the biggest transplant center now, so any experience of downstaging and doing the transplant?
Our first patient is Mudassir, is 32. Sorry, I have taken the name. Sorry for that. He's a 32 years. He's ready for transplant actually because we did first tear in March last year. So it's almost 8-9 months. He is disease free, and we are hoping that we will get transplant because in these cases we normally wait for both radiological response and biochemical markers response actually at least 6 months, but it's better to wait for 1 year actually to see what exactly the behavior of the tumor is. So our first patient, we do lot after TACE and RFA or combinations thing, but this is the first case which is ready for transplant actually.
One short question. Any case you have done a repeat tear?
No, but there are few cases because we have a funding, by the way, for a very limited number of cases for this radioembolization. We had few cases because we are doing palliative tear actually. We are not still at the curative part. So there are a couple of patients, those have a recurrent disease. One of my patients had a recurrent disease along the margin in the subdiaphragmatic area. I haven't done the tear. Patient was ready to go for. Because the lesion was small, I sent for a SBRT. And the response was really good because her initial AFP went up to 65. And after SBRT and Limetinib, it is down to 8 now. So here comes in the combination thing because definitely the tear is very expensive. We are charging 5.1 million. I don't know what others are charging, which is very huge amount. So in this case, SBRT was much cheaper. And even you can use in combination, you can use if there's a small lesion, you can do like TACE or you can do microwave or RFA. But yes, repeat it. Up till now we haven't done, but it can be done. Thank you.
So our fifth speaker is Dr. Saad Malik. He is present with us online, and we have his recorded talk with us. I would like to introduce Dr. Saad Malik. Dr. Saad Malik graduated from the Army Medical College in 2002 and gained extensive trauma and surgical experience through military service and disaster response. He completed advanced hepatobiliary and liver transplant training at the University of Maryland, where he is currently a faculty member and practicing liver transplant surgeon. So he will talk about the transplant oncology.
Now, traditionally, oncology and transplant Good morning, everyone. My name is Saad Malik, and I'm a transplant surgeon at University of Maryland. And today I'm going to be talking to you about transplant oncology. Now, traditionally, oncology and transplant have existed at the margins of one another. But in the last few decades, improvements in patient selection, immunosuppression, and oncologic understanding have challenged these long-held dogmas about cancer and transplantation. Transplant oncology represents the convergence of these disciplines by asking a fundamental question: can replacing an entire organ, along with its tumor-producing microenvironment, offer durable oncologic control in select cancer patients? To answer this question, I will discuss the role of liver transplant in hepatocellular cancer, cholangiocarcinoma, metastatic neuroendocrine tumors, and non-resectable colorectal mets. Before I start, I'm just going to go ahead and explain a couple of terminologies that will be used quite frequently during this talk. So MELD, or MELD, stands for Model for End-Stage Liver Disease. It is an objective score which predicts short-term mortality in chronic liver disease patients and forms the basis for liver allocation in most transplant systems. Patients with higher MELD scores receive priority. However, many cancer patients, including those with early HCC, have preserved liver function, and therefore their native MELD scores are low, and thus they are disadvantaged compared to other people on transplant wait lists. To address this disparity, MELD exception points can be granted when approved. Now, who approves those exception points? It's UNOS. So UNOS or UNOS stands for United Network for Organ Sharing. It is the non-profit organizations in the United States that manages the national organ transplant system. It develops and enforces organ allocation policies and maintains the national transplant wait list. It matches donated organs to intended recipients and also allocates MELD exception points in cancer patients. These graphs represent the recent transplant trends in the United States. As you can see, that the liver transplant activity continues to rise despite a relatively stable wait list. And in this bottom diagram, you can see that there are some changes in the diagnostic profile. So liver transplant for Hep C have gone down, and now alcohol-related liver disease, MASH, and HCC actually constitute the common indications for transplant, underscoring the expanding oncological relevance of liver transplant. You're all aware with hepatocellular carcinoma. Originally, the role of liver transplant was controversial until this landmark paper from a group at Milan in 1996. Their overall and recurrence-free survival at 4 years among the 35 patients who met the predetermined criteria was 85% and 92% respectively. Introduction of Milan criteria reshaped liver cancer therapy and reopened the door for carefully selected patients with HCC for transplant. Patients with HCC who now who meet the Milan criteria are given exception points so that they are not disadvantaged. What about cancers, HCCs beyond Milan? Now, Milan criteria is often reviewed as, quite strict in terms of tumor size. There is growing international evidence that demonstrates that selected patients with HCC beyond Milan can also achieve acceptable post-transplant outcomes after downstaging with local regional therapy. So this table shows some of these criteria, and the upper size limit for Milan was 5 centimeters. You can see for the UCSF criteria it's 6.5, and here they even allow more than 8 centimeter if the histological grade is low. And this bar graph here shows that the 5-year overall and recurrence-free survival for these expanded criteria are fairly similar to Milan. All right, let's go on to cholangiocarcinoma. This is the second most primary liver malignancy. There are 3 anatomical locations: intrahepatic, perihilar. These are the 2 that we will be talking about. We won't be talking about distal cholangio because that's treated with Whipple. Now, while surgery still offers the best chance for cure in localized resectable disease, it only constitutes 10 to 40% of the cases, and with a 5-year survival of 25 to 45%, which is dismal. So can we offer transplant for these cancers? Now, historically, liver transplant alone for unresectable cholangiocarcinoma had shown poor results. But Mayo Clinic developed this neoadjuvant protocol to transplant in highly selected patients without metastatic disease. Of the 19 patients that they enrolled, 11 successfully underwent transplant after neoadjuvant therapy. At a median follow-up of 44 months, all transplanted patients were alive and only 1 recurrence was observed. Their 1, 3, and 5-year survivals were 90, 80, and 71%. Further validation of the Mayo neoadjuvant protocol was, of course, then followed. So this is a European multi-center study It included 21 centers, 147 patients compared with and without Mayo Protocol, and they found that 5-year overall survival with Mayo Protocol was 59% compared to 21% without. Similar result was seen by this multi-center US study. They compared liver transplant to liver resection, and they found that the overall survival after liver transplant was 64% compared to 18% after liver resection alone. So these multi-center experiences confirm that in carefully selected patients, the Mayo neoadjuvant protocol improves post-transplant survival and reduces recurrence, and validating its use beyond a single center experience. What about intrahepatic cholangiocarcinoma? Now, this is a Spanish multi-center experience. They looked at patients with intrahepatic cholangio, and they found 1, 3, and 5-year survival rates of 77, 65, and 42% after liver transplant. And this study from Canada, this was a multi-center retrospective study. They evaluated recurrence risk after liver transplant in patients with intrahepatic cholangio. They found that patients with single tumor less than 2 centimeter had no tumor recurrence and 1, 3, and 5-year survival of 100, 73, and 73% respectively. This is a single center experience, 32 listed patients, I think. 18 of them underwent liver transplant after neoadjuvant. And despite, and their post-transplant survival was excellent, 1, 3, and 5-year overall survival of 100, 71, and 57%. So these studies suggest that carefully selected patients with very early intrahepatic cholangiocarcinoma can be suitable transplant candidates. Moving on, neuroendocrine tumors are slow-growing tumors, but they're often discovered when they metastasize, and they metastasize to liver most commonly. And liver mets are also responsible for most clinical deterioration of these patients. Unfortunately, only 10 to 25% of these mets are resectable. This is a matched cohort study of 88 patients who had metastatic neuroendocrine tumors. 42 of them received liver transplant. Transplanted patients had markedly higher 5 and 10-year survival, 97 and 89% compared to 51 and 22 without transplant. They found that after adjustment, liver transplant remained independently associated with improved outcomes. These findings support liver transplantation under strict selection criteria as an effective treatment for selected patients with the hepatic neuroendocrine mets. Based on this, UNOS has come up with a very strict criteria where if the patient satisfies, they will grant them exception points. And lastly, colorectal mets. Now, 50% of these patients develop mets, liver mets. Liver resection, however, is only feasible in 20 to 40% of these patients. In 2005, the first prospective pilot study on role of liver transplant in non-resectable colorectal mets was initiated in Norway. From 2006 to 2012, 23 patients underwent liver transplant, and this is their long-term follow-up results. 1, 3, and 5-year overall survival was 95, 68, and 60%. This was followed by the PSCO trial from the same group in Norway. And here, their 5-year survival was even better. It was 83%. Here's a little comparison between these PSCO-1 and PSCO-2 trials for non-resectable colorectal mets. And as you can see in the PSCO-2 trial, the selection criteria is just more strict. And they have mandatory PET and CT imaging. Duration of chemotherapy has to be at least 6 months. CEA has to be less than 80. And then their 5-year overall survival is reaching 83%. Based on their study, these are considered the positive prognostic factors for liver transplant in patients with unresectable colorectal mets. And based on this criteria, UNOS will give exception points to select group of patients which fall within this criteria. In conclusion, Liver transplantation for transplant oncology is evolving with promising future for selected colorectal mets patient and intrahepatic cholangiocarcinoma patients. Initial results are encouraging with overall 5-year survival in excess of 60%. However, data is limited, but multiple trials are currently ongoing. Essentially, we are transplanting the best tumor characteristic patients among the worst and advanced disease patients of that condition. Right? Role of transplant in resectable liver mets is yet to be determined. And this brings to the end of my talk. Thank you so much for allowing me to speak, and I'll happily take any questions.
Thank you so much, Dr. Malik. We can take one, he is with us online, so we can take one or two questions from the audience. So moving forward, thank you again, Dr. Malik. So moving forward, we are going to have a debate on the omission of surgery in rectal cancer management. So Dr. Fan Heather, I would request Dr. Fan Heather to moderate the session.
Good morning. As Dr. Sarish mentioned, that the debate is about the whether we should go for surgery or observation after achieving complete response in locally advanced rectal cancers. As we know, rectal cancer management is continuously evolving, and surgery has remained, and still the surgery is the main cornerstone of the treatment. But with the recent advances, especially with the management approaches like total neoadjuvant treatment, long course, short course radiation before the this one surgery, have been put us in a point where it is very essential to exactly know, can we safely put the patient on surveillance after achieving complete clinical responses, especially when we regularly see in our clinical practices that the patient who had residual disease are not always in the mucosa. Sometimes the residual cells are in the submucosa, in the muscularis layer. So can we safely omit the surgery? So in order to discuss, I would request Dr. Sarish, who need at least no introduction for now. Please go on.
Thank you so much for this kind introduction. So I'll be talking in favor of omission of surgery in rectal cancer management. So I'll be talking in favor of watch and wait approach, and Dr. Sadaf Usman, who is sitting with us, and she'll be talking that surgery is still the standard of care. All right, so when the word management of the rectal cancer comes in our mind, the other word comes along with that is the permanent stoma, especially in the patient who have the low rectal cancer diseases. So we need to change that. We need to change that. And I'm going to start my talk with the statement of Professor Bill Heald, who is a surgeon, who is the pioneer of the TME. He said that for me, surgery is primarily a craft, and I see little shame in regarding a surgeon as a person who exists to do operations. So the idea of organ preservation was coined by the surgeon. We see the management of the rectal cancer has changed from only surgery to the multimodality approach in last many years. And if you see the downsides of the rectal cancer surgery, you can see that there is a risk of 10 to 20% risk of anastomotic leak with the surgery. There's a risk of bleed. There is a risk of anterior resection syndrome, and 40 to 50% of the patient face the urosexual complication after the surgery. In recently, we see many game changers in the management of the rectal cancer. And one of the game changer is the MRI pelvis. So Professor Regina Brown mentioned in 2 papers, in Mercury and Mercury 2, the importance of the MRI pelvis to get it done on the baseline and for the response evaluation. Because we, in today's world, I'm sure you also face, you also see these kind of scenarios where the patient is being managed without having a baseline MRI pelvis. I'm looking these kind of patients, and I really feel sad that we should not do that. The MRI pelvis, getting the MRI pelvis should be the minimum standard. Because if we do not get the baseline MRI, or you don't have the MRI pelvis in response evaluation, we can lose the chance of organ preservation. So again, get the MRI pelvis in a baseline, and then again get it done for the response evaluation, which we call the YMRI. And again, this is very important for the organ preservation. We get the idea about the response of the disease from the neoadjuvant treatment. We get to know about the residual or the viable tumor as well. And now we have tumor regression grades available. So we can stratify the patients as per the MRI as good responders or the bad responders. So if I give this one question, this one message, getting the MRI pelvis done, I think my job will be done. Again, the paradigm shift, we'll talk about the paradigm shift. So recently we have seen that the paradigm has been shifted. Now we are talking about the total neoadjuvant therapy. And the total neoadjuvant therapy is doing the radiation therapy and chemotherapy before the surgery. And then when we see the response, tumor response on the MRI, we can opt for the minimally invasive surgery or the organ preservation as per the response. So the newer standard of care for the locally advanced, especially low rectal cancer, is in a stage 2, 3, get the chemoradiation done or the DNT done, followed by the surgery or the watch and wait approach as per the MRI response. And we all know that from the many retrospective surgical series, when we do the chemoradiation therapy, we see a lot of patients with a pathological complete response. So the surgical series or the data from the surgical papers showed that 15 to 24% of the patients showed the pathological complete response after the neoadjuvant treatment in locally advanced cancer, and in 40%, more than 40% of the patients have the complete response in early tumors. So according to the ASTRO clinical practice guidelines, the organ preservation is a conditional recommendation. When the patient have the complete response on the MRI, on endoscopy, and the DRE, then offer the organ preservation to the patient. We need to talk about what patient wants. Does the patient only wants the cure, or the patient wants good quality of life? So the patient wants both, the good quality of life and the cure as well. So avoid the permanent stoma, maintain the good quality of life, avoid the low anterior resection syndrome. This is a very interesting survey which emphasizes the importance of avoiding the stoma. So this survey was being conducted, and surprisingly, the patient give the same importance to avoiding a stoma as they give importance to the cancer cure. So the patient wants the cure with a good quality of life. Now let's talk about the total neoadjuvant chemotherapy. So recently, many trials has been published. So I'm going to talk about the PRODIGE 23 trial. So in PRODIGE 23 trial, the total neoadjuvant chemotherapy was compared with the standard of care, and FOLFIRINOX chemotherapy was used, followed by the conventional fractionation concurrent chemoradiation therapy, followed by the surgery, and then followed by the chemotherapy. So we can see that 27.8% of the patients showed the pathological complete response in the experimental group. So now this it's a new standard of care. Again, in RAPIDO trial, they use the short course radiation therapy followed by chemotherapy and then surgery. But again, when we do the radiation first, our surgical colleagues are not happy with this approach. They find it difficult to operate in a patient who developed the fibrosis because of the radiation. So I think all of us have these kind of discussion with the surgeon that they don't like this approach, the radiation first approach. Again, in the Rapido trial, you can see that the pathological complete response was 28% in the experimental arm. Moving forward, we are now going towards a personalized treatment. We are also talking about the omission of the radiation therapy. So recently, the Prospect trial showed that you can treat the patient with intermediate risk cancer, rectal cancer patient. You can treat the patient without radiation, and you can safely omit the radiation therapy in some of the patients who are good responders to the chemotherapy. Now let's talk about the OPERA trial. So the OPERA trial was being conducted in distal rectal cancer patients, stage 2 and 3, and there were two different approaches were adopted. There was one of the approach was a consolidation approach, and the other one was the induction. So in the induction approach, the chemotherapy was given first, and then the consolidation, the radiation was given first. And then they did the response evaluation with the help of MRI, DRE, endoscopy, plus minus biopsy. I'll talk about the role of the biopsy as well, because it's not mandatory. According to the guidelines, it is not mandatory. But what mandatory is to get the MRI pelvis, get the endoscopy, and the DRE. And they followed the same. And then the patients who had no clinical response, they go for the TME, and the patients who are good responders, they go for the watch and wait. And surprisingly, you will see that the patient who had the radiation first showed the very good response, the clinical complete response, the 58% versus 43%. This data shows that the patient who had the complete response, the clinical complete response, they had the better overall survival, they had the better distant disease-free control. So they had the better overall survival and the distant disease control. So the OPERA gave a very interesting finding that if you do the radiation first, you will see the more clinical complete response. But again, this is a matter of debate. The surgeon doesn't like this approach. They want us to do the chemotherapy first and then radiation therapy. Otherwise, they have to deal with the very fibrosed pelvis. All right, so this is another trial, the STAR Trek study. And the STAR Trek study, they took early intermediate stage rectal cancer patients, and they compared the short course radiation therapy and the other group had the concurrent chemoradiation therapy, the long course. They have, on 1 year follow-up, they've seen that 80% of the patient had the long course ECRT and 61% had the short course radiation therapy. They did not require the radical surgeries. So these data are very promising. So we can talk about the organ preservation. So now what are the advantages of the TNT approach? We all know that when we don't do the surgery, we have intact pelvis, the vascularization is good, and the chemotherapy works very well in that setting. And the chemotherapy tolerance is better in total neoadjuvant setting. So the other advantage is, in that way we get the better responses. We can offer the organ preservation to the patient. All right, so this slide is about the radiation dose escalation. So as per the guidelines, we should not go above 54 gray, especially in the locally advanced rectal cancer. But in the early rectal cancer patients, for the early rectal cancer patients, the promising data is coming up, like the OPERA trial, which showed that the contact, if you use a contact X-ray brachytherapy, you will find the good responses. So now I'll define what is the complete clinical response. So in my first slide, I said that the concept was coined by the surgeon. The organ preservation concept was coined by the surgeon. And the professor Angelita Habergama was a colorectal surgeon in Brazil, and she first talked about the organ preservation. According to her, the clinical complete response should be defined as the absence of any palpable tumor on the DRE, and there is a flat scar and the widening of the mucosa. The definition of the complete response and the poor response are easy to understand, but the definition of the near complete response is very dubious. That's why we need to have MDT discussion. When we are talking about the organ preservation, we cannot do it alone. We need to sit together, have a discussion. Is it a complete response or a near complete response? So as per the literature, we know that if we use the DRE, MRI pelvis, and the endoscopy, there is 90% probability of the prediction of the CR. And you can also you can also assess the nodal response on the MRI as well. When I said that I will talk about the role of the biopsy, so this was a retrospective, it was a surgical series, and this surgical series proves that when you do the biopsy, there is a high risk of false negative results. So that's why it's not mandatory. You may find the tumor cells deeper inside the mucosa or deeper inside the layers of the bowel wall, and you are not picking up the right area at the time of the biopsy. So you may have the false negative results. Outcomes of the non-operative management, there's a risk of the local regrowth in 20 to 35% of the patients. So, and that risk is very high in the initial 2 years. So that's why the follow-up protocol is very stringent in the first 2 years. What should be the timing of the response evaluation? There is a paper which showed that maximum patient, the 95% of the patient showed the clinical complete response at the 10th weeks from the end of the radiation therapy. But again, when we delay the timing for the response evaluation, our surgeon becomes unhappy. Okay, because of the risk of the fibrosis. So we have to be very mindful that till what time we can call the patient for the assessment. So when we should do the organ preservation in the cases of clinical complete response, in the cases of near complete clinical complete response, those scenarios, the near clinical complete response needs a lot of discussions. I'll discuss the follow-up protocol now. So for the first 2 years, we have to be very stringent and closely follow up the patient. Like we have to do the CEA level, DRE endoscopy, and the MRI pelvis every 3 to 4 months, and then the interval increased for the next 3 years. So the take-home message is that non-operative management option should be discussed with the patient at the time of first consultation, and we should have a MDT discussion when we see the good response on the MRI after TNT. Thank you.
Thank you, Dr. Sarish. You talked about surgeons, so we are lucky to have one of our colorectal surgeon, Dr. Mohammad Fahad. If you can please come onto the front seats, because later on at the end of next talk, we will have a debate, so we will be needing you. So now I would like to invite Dr. Sadaf Usman. She is trained and my colleague, in fact, in Shaukat Khanam Hospital, Lahore. So currently she is working in radiotherapy, Colchester General Hospital, UK, and she is the oncological lead over there and also developing contact in brachy services. So please, and she will be talking about the surgical role in the colorectal cancer management. Please, Dr. Sadaf.
Thank you. Thank you. So I'm Sadaf, one of the oncologists trained at Shaukat Khanum Hospital and currently working at Colchester, as Dr. Irfan introduced me. So today I'm going to talk about the cons of watch and wait. I don't think I would be appropriate to talk more as a standard of care, the surgical treatment, because I'm an ardent supporter of organ preservation myself. But we can look at the downsides of watch and wait and see if it is appropriate for this population and the group of patients. So if you look at the incidence of the bowel cancer, it is the fourth most common cancer in the Western world. In UK, it is seen very commonly, especially in the younger group of patients, although the average age is about 75. But in the last few years, we have seen that there is an increasing incidence, especially in patients who are less than 50 years of age. And there are many concerns regarding the cause for this increasing incidence. This is the second most common cause of the cancer death as well. If we look at the incidence in Pakistan, it's the third most common cancer, and again, it is seen in younger population. One of the studies said that 32% of patients are less than 40 years. And what they have found is that the patients who are diagnosed, especially the younger group of patients, they are diagnosed with poor prognostic factors, which includes the advanced stage, mucinous or signet ring cell pathology, which is associated with worse prognosis. And there are also bad biological factors which have been seen in these patients. Men are more likely to develop the bowel cancer as compared to the women. This is the slide from Cancer Research UK, and at the moment we are screening for a few of the cancers there, which includes your bowel cancer, breast cancer, and the cervical cancer. If you look at the bowel cancer, which is the blue bar, we can see that more than 70% of the patients would take the screening program. So there is a very well-embedded screening program there, where we do the fit testing for the patients. And recently, because of the increasing incidence in the younger group of patients, the screening age has now been reduced to 50 years as compared to the previously 55 to 60 years of age. So there is a very good intake, which obviously indicate that this can lead to diagnosis of the cancer, especially the bowel cancer, at an early stage. So the important thing here is to pick up the blue bar, which is the light blue and the dark blue. And we can see that the screening patients, more than 70% of the patients who are being diagnosed by screening, they are diagnosed at stage 1 or stage 2. Whereas the patients who are coming through emergency or the 2-week wait referral, so just to say the 2-week wait referral are the patients who are coming with the symptoms, especially the PR bleeding, abdominal pain, weight loss. These are all patients who are directed on the fast-track pathway. So these patients are more likely to present with the advanced stage, which is the stage 3 and stage 4. It's very important to indicate this here, because we know from the data which Serish has just presented that patients who have locally advanced disease, the risk or the benefit of organ preservation or how much we can achieve in those patients is much less as compared to the patients who present with an early stage cancer. Now, what is screening? Obviously, unfortunately, we don't have any national screening program in Pakistan, and this is the thing which we need to work at. With the increasing incidence, younger population, we don't want to lose all of our people from this ugly cancers. There's a high prevalence, as we have seen, and that is all because of the inadequate screening management and the patient education. The screening will help to diagnose the cancers at early stage, and obviously then we can move on to the next step, which is the prevention as well. Prevention comes obviously first thing, but they can both go hand in hand, and that can help us to improve the outcomes for our patients. If we don't do the screening, we end up with these kind of cancers. Now, this is called as locally advanced cancer or an ugly cancer. And although the data from the Western world, where they say that these are the locally advanced cancers, they're not actually the locally advanced cancers, because when we look at the patient characteristics, which we are going to do in a moment, they are the medium, intermediate category of the patients rather than the bad or the ugly cancers. Now, when the patient comes to the clinician with this kind of cancer, he wants to have a good quality of life, improved survival, and organ preservation. They want to save their hours. But how we can achieve that. And then the clinicians start thinking about all that data which have been bombarded to us in the last 2 decades. And I'm sure there will be more trials which will be populating this screen, and then we will be more confused in the clinic, in the patient, and obviously we cannot give a very clear answer to the patients, so what is the best way to treat them. So I'm not going to go into the detail of all of these trials, but just to give a bit of critique to them. So OPRA was the first trial which integrated watch and wait in the TNT approach in the so-called locally advanced rectal cancers. But only 5% of patients had grade 3 cancer. 15% had T4 disease, which is more common here, and especially in patients who are presenting with the emergency presentation. And the left lateral pelvic lymph nodes were only seen in 18% of patients. We understand there was a higher organ preservation in the group which had the radiotherapy first as compared to the induction chemotherapy, and that's because of the duration between the radiotherapy and the surgery, because that was longer in this group of patient. There wasn't the primary endpoint was disease-free survival for this trial, which they failed to meet, and it was the same in both the groups. There was no improvement in the overall survival. There wasn't any subset analysis, which was mentioned in the later stages, about the tumor size, EMVI, or the CRM positive patient. So we don't know if a patient has a T0N1 disease with a small lymph node, which have been given this kind of treatment, as compared to a patient who has a CRM involvement with N2 disease, what was the difference, or what is the significance of them. It failed to define the near complete response, as Serish mentioned. That is the dilemma here. We understand what is the complete clinical response or the poor responders, but it's very difficult to identify that intermediate group of patients. Importantly, there was more than 1/3 of the patients who had grade 3 plus toxicity, and they did not differentiate between the radiotherapy and chemotherapy-induced toxicity in this trial. Obviously, we did see the regrowths, which is the downsize of the watch and wait approach. Obviously, this is one of the risk factors for the organ preservation. And we have to look for the regrowths, and it's very important to pick up these regrowths at an early stage if we want to salvage these patients. Again, Rapido and Prodige 23, these are the trials showing us the pathological complete response in patients who had incorporated a TNT approach. Rapido did have a good representation of T4N2 disease with the EMVI positive and the CRM, whereas if you look at the Prodige 23, which in my opinion, obviously you can differ with that, but in my opinion, it was quite an over-treatment for this group of patients, with a triple regimen in the neoadjuvant chemotherapy, and then subsequently after the surgery, they were also given 3 months of chemotherapy. This was the only trial which has shown some improvement in the overall survival in all of these trials. Other than that, none of the trials have shown significant overall survival improvement up till now. And if we look at their outcomes, Rapido did show an improvement in the disease-related failure. However, if we look at the 5-year outcomes of Rapido, we have seen a large number of delayed regrowths, and that can be attributed to the short course radiotherapy treatment. And obviously, we understand that the poor radiotherapy cannot be compensated by chemotherapy, even if you give them. So Rapido, it did try to change the treatment paradigm, and if in many of the European countries, they have adapted the short course radiotherapy in the neoadjuvant setting. But if you look at the local regrowths, which is much higher in the experimental group, now people have become more reservant about it, and they are going back to the long course chemoradiotherapy treatment. So again, it's important to early recognize it so we can do the salvage for these patients. Most of the time, these failures are seen within the first 2 years. However, the late failures are also very commonly seen, and we know that this can also lead to the distant metastases. Does T size matter if we are talking about the organ preservation? So this is a retrospective review by Habagama, and what they did was they gave patients neoadjuvant chemoradiotherapy, and they looked at the complete and the incomplete responders. And initially, the complete responders were almost equal in the T2 group as compared to the T3 and the T4 patients, whereas if you look at the early regrowths, they were quite significantly different from the patients who had early cancer, which is the T2 cancer, as compared to the T3 and the T4, which means that, yes, it does matter if you're looking at the T size, if the patient will be more appropriate for organ preservation or not. And again, similarly, you can see that there's a difference in the distant metastases-free survival as well for these patients, because it was higher in the T3, T4 as compared to the T2 group. Role of biopsies, Serish has already touched upon it. So there's a very high risk of false negative results. So it has a negative predictive value of around 21% in this particular review by Habagama. And so the post-treatment biopsies, they're of limited clinical value if you're talking about the rectal cancer in particular. Also, we have to be very cautious, because if the patient has if the patient is going on to have a complete response, you have to ask your surgeons or your gastroenterologist not to rush to biopsy if they see that the picture or the endoscopic response, they can see there is an improvement as compared to what they could see at the baseline, because this patient can have an evolving complete response. And if you biopsy these scars, which can be the complete response, this can lead to radiation-induced necrosis, and this is not going to heal then. OPERA trial, I would just like to briefly mention this trial. This was mainly conducted in UK and France, and they looked at the very early cancer patients. They had the T2, T3A, and the N1 disease. N1 lymph node was up to only 8 millimeters. And it showed, and what they did was they randomized the patients between the standard chemo-RT with an external beam boost versus the chemo-RT with the Papillon boost, which is the contact brachytherapy. And they gave patients upfront versus the sequential boost. And they proved that if you give the patients the upfront Papillon boost in patients who have less than 3 centimeters of tumor, you can actually achieve organ preservation in 97% of patients, which is, I think, a game changer. And again, going back to the screening, we need to pick up this group of patients if we want to achieve the organ preservation. And if we look at the whole group, again, it was 59% in patients who had the EBRT boost versus the patients who had the Papillon boost. They had 81%, including the patients who had 5 centimeters of tumors. And this is going back to our radiobiology, which we know that the rectal adenocarcinomas, they are the radio-resistant tumors. And this dose response curves, it shows that if you want to achieve the TRG1 in up to 50% of the tumors, you need to escalate the dose up to 92 gray. And we know that we cannot do this until we do the contact brachytherapy. This cannot be achieved by external beam boost. So this is the background for the Papillon treatment, which although it's a more than 60 years old treatment, but it is now coming into the fashion again, and many centers are developing this treatment. So based on this trial results, NICE has recently approved Papillon treatment, and now it has become a standard of care along with the surgery for patients who have early rectal cancer. So although I am here to advocate for surgery, but I would say that this is a group of patients where you can safely achieve organ preservation if you have the resources to do the surveillance for them as well. So what is the local data about the rectal cancer? If you look at this retrospective review from Shaukat Khanum, it is a big group of patients, 301 patients. And we can see that more than 90% of the patients had advanced disease with T3, T4, node positive, notably N2 disease, which is seen in 76% of the patients. So this is the true representation of our Pakistani population with the rectal cancer. And these patients had TNT approach with K-POX 4 cycles, 3 to 4 cycles, followed by chemoradiotherapy, 45 to 50.4 gray, followed by surgery. And the most common toxicity with the chemotherapy was diarrhea, followed by neuropathy. And they could achieve the pathological complete response, 22%, which is, I believe, comparable to the international data. This is another paper from AKU. They had 77 patients, and they looked at the outcome of patients who had the standard chemoradiotherapy followed by surgery versus the TNT approach. Although the numbers are small, but if you look at this group of patients, mostly the patients are grade 1, which is almost 78%. They are PNI, LVI negative, so relatively a good group of patients with N0 disease of 41%. And if you look at particularly the T stage, 20% of patients are T0 and 47% of patients are T1 to T2. So obviously this, I believe it's just because of the a representation of that of the group of the patient which are coming to them. So these are the relatively early group of patients, and we can see that the pathological complete response is much higher. It is 40% in the TNT arm as compared to the standard chemo-RT arm. So this is more of a representation with the OPERA trial and the Western trials, what we have seen earlier. So again, complete clinical response, we have just learned from Serish that this is the definition. So there shouldn't be any visible disease on the MRI scan, along with when you do the scope, the flexisigmoidoscopy, or when you're doing the proctoscopy for the lower rectal cancer. That is the most important thing. You need to visualize that cancer. And then obviously it needs to be adjunct with your findings from your MRI scan, that there shouldn't be any residual disease there. Surveillance, that is the main problem for these patients, and we know that this is going to increase the burden on the patients as well as the health system. And we obviously we don't know what is optimal frequency, because if you look at the different protocols, every protocol is slightly different, so there isn't any standard surveillance protocol. ESMO and OPERA trial, which is the European trial, they are more similar in line. They are saying that you need to do the flexi along with the DRE and the MRI every 3 months for the first 2 years, and then you can move 6 monthly. Whereas the OPERA American trial, they are more relaxed with the MRI scan, whereas they are still doing the flexi every 3 to 4 months. The annual CT scan is recommended in OPERA trial, whereas it is not recommended in the European OPERA trial, because maybe it was more of early cancers. Therefore, they didn't specifically said about the CT scan. If you look at the cost effectiveness, so obviously that is another argument which we see about the rectal surgery. These are just arbitrary numbers which I tried to put, if you look at in our setup here in Pakistan. So radical surgery, obviously it can be different in private setup, it can be different in the government setup, but around 100,000 cost. I haven't included anything about the stoma, about the all other things, because unfortunately I couldn't get all of that information. And if you look at the watch and wait, so these patients need endoscopic evaluation quite frequently, and roughly it can be around 70,000 per scope. MRI scan can be around 30,000 per scan, and each follow-up visit, either with the surgeon or the oncologist, it can be around 5,000. So overall, to me, it doesn't differ much in terms of the cost, because I've not included the CT scan, the CA, and all other levels. Obviously, in the Western world, the patients have got their insurances, and they're not worried about the actual cost of all of these scans. But if we have to discuss all of these to the patient, if we are talking about the organ preservation to them. Compliance, it could be a loss to follow-up as well if you are talking about the watch and wait, because the patient would say, I'm completely free of the symptoms, I am cleared of the cancer, I'm cured, I don't need any surveillance. So that can be a very big problem and a big challenge for this setup. This was a prospective registry from US, and they determined adherence to recommended surveillance, and they tried to identify the predictors of the poor adherence in these patients. So what they did was they followed up the OPERA trial surveillance plan. Along with that, they also collected the variables, including the patient age, ethnicity, their insurance, their post-secondary education, their social deprivation index, which we think could be an important factor if they are adhering to the surveillance protocol or not. So only 59% of the patients in US who actually were earning quite a good income, they could achieve that. The overall surveillance for 2 years, which is the most critical period, was only 41%. For the second year was 34%, and the first year it was 50%. although these predictors were not p-value significant, but still, I think these are very important. We know that the adherence which we see in the clinical trials is completely different from the real-world data. So it could be a challenge to achieve. This is just quickly another survey from Canada, and they surveyed the 40 centers where the chemoradiation or the rectal surgery was being offered, and they asked the clinicians, including the medical oncologists, surgical oncology colleagues, and the radiation oncologist, what are the major barriers to do the surveillance for the complete clinical responders. And what they saw was that only 50% of the centers were offering organ preservation to the patients. And the major barrier were the access to MRI, the flexisigmoidoscopy, the timely surgery if it is required. So again, just because of the time, I'm just going to skim through these. So although this is a Canadian study, but the obstacles are broadly prevalent, we can well relate to these problems in our setup as well. So collaboration among centers is necessary. We need to educate our patients and then try to implement this approach. So one size fit for all does not work here. We have to work on improving the screening, personalized treatment. These are the ugly cancers. We have to give them the TNT approach, but then carefully select the patients who can have the organ preservation and then salvage for local regrowth. Okay, thank you.
Thank you, Dr. Sadaf and Dr. Sarish for their elaborative talks. So Dr. Sarish has mentioned quite a few times about the surgical difficulties and surgical worries. So we have Dr. Fadshah. He is a laparoscopic colorectal surgeon. So if you can just tell us about what is the optimal timing for the surgery, and what is the time period when you got worried, when you don't want radiation oncologist to send the patient to you. Yeah.
Thank you so very much, Irfan, for giving me this opportunity. Dr. Sarish, excellent presentation. Probably there were a few things that I might not, like or disagree with. All right, Dr. Sadaf, very nice presentation as well. You were absolutely right. No surgeon wants to operate on a post-neoadjuvant, radiotherapy, because there's so much of fluid over there. There are a few things, we need to keep in mind. One, you mentioned about near complete response. All right, so that is the gray area, how to differentiate whether this patient after neoadjuvant chemoradiotherapy has he got a complete response, or is he going towards the complete response? What is the optimal timing, as Irfan mentioned? Or shall we give them a little bit more time, to show whether after 3 months, we have done a surveillance scan, there's some, fibrosis or a tumor, for that matter. Shall we do an MR scan again after 3 months? So, or would it, grow again in those 3 months? So these are really very difficult questions. Probably our experts over here in radiation oncology would be in a better situation, or would answer it in a much more detail. But secondly, I've got, is MR a tool to, differentiate between post-neoadjuvant tumor, or the fibrosis? Is it a fibrosis? Is it, because it is really, we don't have a radiologist over here. I don't know if somebody is a radiologist, because sometimes it is really very tricky, to differentiate between fibrosis, which is post-neoadjuvant, and an actual tumor over there. So that's another, or shall we do a PET scan for that? What do we know? So these are all the gray areas. If you ask me personally as a surgeon, if the patient has a chance of getting a permanent stoma, and there is a chance of having a watch and wait, which I feel that, he is going towards a complete response or a near complete response, I would personally like to give him a benefit of doubt and put him on surveillance. If he has got a low rectal cancer and a chance of having, a permanent stoma. On the other side, if a patient has got a mid or an upper rectal cancer, in which I'm confident that I'll spare the sphincters. So rather than putting him through, a rigorous follow-up protocol, which Dr. Sadaf rightly mentioned, that it is really very difficult for the patient, to say that now I'm tumor-free and being compliant with the follow-up. Because it is very difficult for them to, to absorb that I have to be here for another 5 years and do the surveillance and pay for those as well. So for those cancers, I would prefer to do an anastomosis. Yes, it has got its own downsides in the form of the ones that you mentioned, leaks. Post-neoadjuvant anastomosis, it has got a higher, leak rate. Fortunately, we have got Irfan and Yasser with us, who takes care of these patients, probably not giving them too much of radiation or stuff. I don't know what's their protocol. But fingers crossed, alhamdulillah, our leak rate is less than 4% for low anterior sections. So, all these things need to be kept in mind before deciding. And Dr. Sadaf, you are absolutely right. One size doesn't fit all, especially in these kind of, situations. You have to discuss it. We have got with us a lovely MDT team. We discuss each and every patient, especially if we are going to put them into surveillance. So all those patients and the radiologists are dedicated rectal radiologists. So we discuss the imaging, we discuss the histopath. Secondly, you are absolutely right about not taking the biopsies of the scars. You can put more harm, and the patients, can be at more harm rather than, giving them any benefit. So that was my take on it. I don't know what the panel
Thank you.
all
I
the
would request Dr.
staff.
Fahim to please
Thank
say
you.
a few words about it, and then we can take questions. Yeah.
I think Dr. Fahad has mentioned only pro-surgical things. And Sarish was on the other side. So is there any radiation oncologist to support Sarish? Humera.
I think all three of them are correct, and all three have given their point of view quite clearly. Even organ preservation approach is not wrong, and not preserving the organ looks correct as well. We need to be very, very meticulous when deciding for organ preservation. As Dr. Irfan initially said, that the malignant cells after neoadjuvant treatment are not always residing on mucosa. If you are taking superficial biopsy and the malignant cells are lying in some mucosa or in deeper layers, you are easily going to miss that. So, and on the other hand, it can also lead to necrosis. So just taking biopsy of whatever residual scar is we are looking at is not sufficient to decide whether there is residual disease or not. So if clinically we have an idea that there is complete response, but then in only those cases we can go for organ preservation, for instance, which are clinically T1, T2, N0, or very, very small node size, as you mentioned, less than 8 millimeters. So we need to be quite selective when we are going for organ preservation. Otherwise, all three are correct.
Okay, so Dr. Kurat, you have a question.
Again, it's a comment. As a radiation oncologist, one thing is that I am always an advocate for the organ preservation, like I talked about in esophagus. But esophagus is squam. And the doses of the radiation are same in a preoperative as well as in a definitive setting. These are 50.4. But in rectum, I have to decide it upfront that either I am going to, keep the patient for the watch and wait, because as both of them said, that the dose escalation in rectum is essential. And usually we offer 50.4 in a preoperative setting. And then we are saying that at the response evaluation, if there is no disease, then we can watch and wait. I don't think so that is true, because our doses are less than. 50.4 is not, in my opinion, it's not enough for the organ preservation. Then we have to decide it upfront. If we gave 54 is maybe keeps, the surgeon will face difficulties after giving 54 or higher doses in the rectum. So there are issues for the organ preservation in rectum. I think the only candidate is, as the surgeon mentioned, who requires a permanent stoma. Then I think in that patient we can consider the watch and wait, but with a higher doses of preoperative radiation or a definitive radiation doses.
Okay.
Thank you. So my name is Dr. Hamad. I'm a radiation oncologist. My question is for my surgeon colleagues, my good friends. It's regarding like an approach that if we do a minimum surgery of a questionable residual disease, followed by a PET, how about that as an idea, especially in our like somebody who wants to really pursue this option of watch and wait?
You know, so there's a question now. What the Western world goes is that what to do about the regrowth. If a patient has got, you know, complete clinical response, and in 6 months down the line or a year down the line, he gets a localized regrowth. You know, so what to do about that? Shall we go for an abdominoperineal excision and give him a permanent stoma, or should we, you know, do so? So the Dutch group, they have done this study to locally excise that regrowth, all right, and save this patient if he hasn't got any other mets or any other pelvic lymph nodes or anything like that. So it is safe for a localized regrowth to be excised and save the patient from a permanent stoma. Yep. Thank you. Sorry? Mini, yes, so you can do it per rectal, just excise and save the patient.
One more
from
and last question from the back.
So, sir, I'm Dr. Shahzeb from CMH Rawalpindi. My question is for my surgery colleagues and sir, for our colorectal.
He is the only one here. So
sorry, for Dr. Fahad. That, sir, mostly we are against APR or permanent colostomy because we are also saving the dignity of the patient and we want to improve his quality of life. As per your knowledge, is there any new surgical approach or new advancement in APR or any sort of other surgical procedure? Like, as we know that there are implants in many, we can make any artificial sphincter or any sort of surgical technique which APR is also done, the surgical issue is resolved and a patient can pass stool from the normal passage. Thank you, sir.
Yeah, so unfortunately, you know, there's no such thing as a transplant, rectal transplant so far that I know. You can do TAMIS, that is transanal endoscopic microsurgery for the regrowth or something like that to save the sphincter. If you take 20 to 25% of the sphincter, you know, the contents will still be there until and unless you take the whole of the sphincter or more than 25% of the sphincter, you know. So at that point in time, you will have, the patient will have an incontinence, all right? Otherwise, you can safely take the sphincter with that. So transanal endoscopic microsurgery is something that you can consider for local regrowths. And no other transplant option, unfortunately, if the patient, you know, the tumor is involving the sphincters, all right, so then you have to take the sphincters along with that. There are a few controversies, you know, so let me mention the controversy if you allow me, if the time allows. So if, you know, what happens if the tumor is involving the sphincters initially when the patient presents, and after that, once you have given the new adjuvant, it has shrunk, the tumor is still there, but it's not involving. So are we supposed to take the sphincters with it, or shall we leave the sphincters? So that's, you know, that's another controversy in these things, because sometimes what happens is there's acellular mucin. When you resect that, so that's the dead cells, so they can become viable later on. All right, so there are a few controversies in these things, but probably we'll save it for next time.
Yes. Thank you very much, Dr. Fahad. It was a really very good debate, and debate make it sense ke kyun debate hai. So it will not be finalizing anything. Two announcements, please.
Both the speakers are ladies, then there is no. Not decide about that.
Two announcements. One is this: faculty, international faculty, will be moving for lunch to Ambassador 3. All the remaining will be having the GBR foyer. This is about the lunch now. The other one is about the poster presentation, because we have competition today for poster presentation in Ambassador 4. Ambassador 4 में 5 से 6 बजे तक जो है, जहाँ पे US सिम्पोजियम चल रहा होगा हमारा, उसके पैरेलल पोस्टर प्रेजेंटेशन एम्बेसडर 4 में है. वुमेन फॉर ऑन्कोलॉजी, यंग ऑन्कोलॉजिस्ट और रेजिडेंट कॉर्नर तीनों कैटेगरीज जो हैं वो मर्ज करके यहाँ पे हैं. और जजेस का पैनल जो है, वी हैव डॉक्टर मोहम्मद बिलाल, डॉक्टर कुरतुलैन बदर, डॉक्टर खलीकुर रहमान और डॉक्टर फातिमा शौकत, ये चारों जो हैं उसके पैनलिस्ट हैं। उनको जो स्कोर शीट दे दी गई है। इसमें हमारे पास रेजिडेंट कॉर्नर में 12 पोस्टर प्रिपेयर होके आए थे। वी रिसीव्ड 55 टोटल। जिन्होंने प्रिपेयर किया है हमारे टेम्पलेट के ऊपर सिर्फ वही कॉन्टेस्ट करेंगे। तो 12 रेजिडेंट कॉर्नर में हैं और अबाउट 10 जो है वो हमें वुमेन प्लस यंग ऑन्कोलॉजी मिले हैं। सो टोटल जो कंपटीशन में होंगे दे विल बी अबाउट 22 पोस्टर्स, आउट ऑफ विच वी विल बी हैविंग 6 प्राइजेस। एक कैटेगरी के अंदर जो है 1, 2, 3 3 प्राइज़ हैं फॉर रेजिडेंट कॉर्नर। जो दूसरी कंबाइंड है उसमें भी 3 प्राइज़ है, 1, 2, 3, और it is like 50,000, 60,000 and 70,000 with the recommendation of our executive member Dr. Mohammad Fahim. So I would say कि आपके जो लोग हैं, अगर presenters आपके नहीं हैं तो किसी को बुलाना है, आप बुला लें अपने residents को. If they are there, तो it's a very beneficial business, I guess. Thank you very much. Please lunch के लिए यहाँ पर.
Dr. Sarish, Dr. Sadaf, Dr. Fahad, please come here for the picture. Picture.
Assalamu alaikum and good afternoon. My name's Saba Imtiaz. Loud to nahi hai na? Accurate diagnosis. Accurate diagnosis is pivotal. Yeah, but ठीक है.
Hello, Bismillahir Rahmanir Rahim. Bismillahir Rahmanir Rahim. We are going to start the session 8 with the name of Allah Jalla Shanahu. First of all, continuing the prayers, one more prayer for Dr. Arif Jamshed. Allah Jalla Shanahu unko wahan khush rakhe. So before starting this session, I have been advised to announce the poster presentation will be from 5 to 6. This session is on the sarcoma and lung cancer, and it will be comprising of 2 parts. First part will be of 4 talks from our national and international speakers, and second part will be of debate on the maintenance therapy of the PD-1 and PD-L1 inhibitors, whether for 2 years or continuation. So now, before starting the session, I will request the chairperson, Dr. Madan Kumar Pia. Dr. Madan Kumar Pia is the chairman of National Hospital and Cancer Research Center and esteemed patron of SFO. I will request him to address the gathering, and we welcome Dr. Madan Kumar Pia. So, sir, please come on the stage. Now I will request the panelist. First panelist is with us, and she is Dr. Sabah Imtiaz. She is consultant medical oncologist, and she is working at Churchill Hospital, Oxford University Hospital, NHS, UK. So, madam, please come on the stage. We have got a second panelist, Dr. Abdul Rahman and Dr. Khurram Shahzad. Second and third panelists, unfortunately, due to their personal reasons, have not come. So we have Dr. Khurram Shahzad with us. He is consultant medical oncologist at Oxford University Hospital, UK. Yes, sir. Sir, Dr. Khurram Shahzad is radiation oncologist at Oxford University Hospital, UK. Sir, please come on the stage. Thank you. And sorry for the introduction. So, starting the first talk, I will request, this talk will be on the NGS-driven management of the metastatic soft tissue sarcomas. So, I will again request Dr. Sabah Imtiaz to come and talk. Thank you, madam.
Assalamu alaikum and good afternoon, everyone. I'm really grateful to the president of PSCO and Chairman Madan Pia and the organizing committee for this privilege. So I'm going to talk about next generation sequencing in metastatic soft tissue sarcomas. I may be touching overall sarcomas, actually. So sarcomas, so I don't have any conflicts of interest. Sarcomas are considered the lonely cancer. And this is because it comprises about less than 1% of all cancers. We know 175 subtypes of sarcomas, and out of which only 70 are malignant. And then 20% out of these are ultra rare, hence really poorly represented in trials or sometimes absent. It's considered a heterogeneous group because it varies in pathology, molecular biology, clinical presentations, and of course, treatment responses. Genomically, we divide them into simple and complex. These simple sarcomas would have specific gene alterations, fusions, amplifications, or kinase mutations like MDM2 in dedifferentiated liposarcomas or KIT mutations in GEST, which is the gastrointestinal stromal tumors. And we've got specific targeted treatments for this. There's another group of sarcoma which is considered complex, and by this I mean they display pleomorphic cells and have extensive chromosomal rearrangements, which is absent in a recurring fashion, and hence less suitable for precision medicine. We've also found that the sarcoma diagnosis rate is missed in 10 to 25% of the cases. As we've already known, always known that there are limited treatment options for sarcomas. We've got first or second line treatments in metastatic settings, and the life expectancy has always been very modest. So the diagnosis of sarcoma, as I said, the misdiagnosis rate is significantly high. It's really important that in addition to the clinical and clinical information, radiological and information, the pathological diagnosis comprises of morphology, immunohistochemistry, and molecular testing. The recent most WHO classification of sarcomas shows that molecular confirmation is desirable rather than essential. The NCCN, which is the North American Cancer Network, it acknowledges the utility of testing doing molecular testing, whereas ESMO, which is the European Society of Medical Oncology, recommends complementing pathological diagnosis with the molecular profiling wherever there is a doubt in diagnosis or there's an unusual presentation. Initially, we knew the genetic analysis was done by Sanger techniques, RT-PCRs, or FISH. This allows for a limited number of target regions to be identified and the known variants. And as the genetic science has progressed or evolved, we've now got next generation sequencing, which is a high throughput technology. It allows for comprehensive and a rapid analysis of a large number of genomes and epigenome changes. And this can be done by either by a whole genome sequencing, whole exome, or just an RNA sequence. The next generation sequence enables discovery of novel drivers and actionable alterations, which are critical for precision medicine. I'm going to talk shortly about how a whole genome sequence was evolved and how it evolved in UK. So in 2012, there was a 100,000 genome project, which was initiated by the UK government during the reign of, I think, David Cameron. This was for all rare cancers, solid tumors and rare cancers, which included sarcomas, to look at genetics and gene alterations, and this led to the basis of NHS England Genomic Medicine by 2018. It was further found that whole genome sequencing was very essential for sarcoma and rare cancers, and hence by 2022, standard of operating procedure was devised how to attain the sample. Essentially, it should be fresh frozen biopsy. So after a core biopsy of a sarcoma tumor, it should be maintained on either a liquid nitrogen or frozen ice and is sent to the genomics lab. And unfortunately, we had this funding to do sarcoma whole genome sequencing for about 4 years, from 2020 to 2024, and thereafter it has been partially withdrawn. And the reason is quite many samples were being sent on as formalin fixed from various centers, which were not sarcoma expert, and this led to DNA degradation, and hence no results could be verified. So it's very essential to maintain the cold chain, and a fresh frozen sample without formalin fixed is sent. At Oxford is one of the 5 national bone and soft tissue sarcoma centers. This is where I work. We have a 10 million population in the south and the southwest. We see about approximately 400 cases every year, and our genetics laboratory hub is the Central and South England in Birmingham. So this is exactly what I said. So initially, a tubal biopsy or a resection is done, and a sample, fresh frozen sample, is kept separate. On a cold chain is maintained and sent to the laboratory. It is very important to see that ROD is a report of discussion. This is to be done by a clinical geneticist. Whenever a genomic testing is being done, it's important that the patient is informed about the possible implications which may or may not be required. So hence, a record of discussion has to be done before actually doing a biopsy or sending a sample for whole genome sequencing. Once the sample is procured, a blood sample is done at the same time to detect the germline mutations. It's then sent to the genomics laboratory hubs. The data is analyzed, and then it needs to be discussed at a GTAB. GTAB is a Genomics Tumor Advisory Board, or you may want to call it a molecular tumor board, where there's a medical oncologist, which should comprise of a medical oncologist, a pathologist, a molecular biologist, and a genetic clinician, and which discuss and come with a conclusion if there are any actionable mutations. I'm going to just go through some data that we did at Oxford. We looked at 128 patients, which comprises of bone and the soft tissue sarcomas from 2024. This is the time period where we had the funding for all sarcoma patients. 1,200 patients initially, but we were able to analyze whole genome sequencing for only 110 patients. This is the age and sex distribution. And so between bone and soft tissue sarcomas, we had a higher number of soft tissue sarcomas. Leiomyosarcomas and undifferentiated pleomorphic sarcomas were the most common. Now, the outcome of this whole genome sequencing, 2% patients had refinement in their diagnosis. So because we are the Sarcoma Expert Institute, when we did the whole genome sequencing, we found that 2 patients out of the 110 had change in their diagnosis. 44%, sorry, not the percent, it's 40% patients had prognostic markers. No actionable mutations were found in 64% patients, which is a significant number. Potentially actionable mutations were found in 34% patients. We found 5% patients had novel mutations, and germline mutations was 5%. Amongst the actionable mutations, which is the most important, for which mutations you can use some drugs, it was 60% soft tissue sarcomas like leiomyosarcomas, undifferentiated, and GIST, and the likes of it. And which potential actual pathways we found, HRD, homologous recombination deficiency, was the highest number. There were 19 patients out of these 110. The rest were CDK4/6, mTOR inhibitors. We had MMRD, and we had the potential therapies. Now, a breakdown of this 38 patients which had the actual mutations, 18 patients died and were not able to have any actionable mutation targeted treatment. Out of the 20 alive patients, only 2 patients received the targeted treatment. I would like to share a few cases here, and I'll skip this one because this is osteosarcoma. So we're talking about soft tissue sarcomas, or might as well quickly go through this. So this was an osteosarcoma patient of the tibia who had resection and adjuvant treatment. He then progressed within 6 months to develop lung metastasis. And we did the whole genome sequencing, and we found that he had high MMRD or a tumor burden for MMRD. These diagrams you see in whole genome sequencing, these are called circus plots. And this is more of my molecular biologists and clinical geneticists who can interpret this rather than me trying to explain to you this. This patient developed metastatic disease in the lungs. Initially, there were 3 lung mets, so they were resected, and thereafter he had further progression in the lung. Due to the high MMRD, we were able to recruit him in a trial that's called Replimune trial, where an oncolytic virus was injected intratumorally, which means inside the lung metastasis, and this oncolytic virus helps the immune therapy, and hence he was given immunotherapy alongside this. Patient had a response to the lung metastasis but developed an right atrial metastasis, which was then radiated, and the rest of the disease was stable. Few months down the line, he had we continued the combination treatment. He had further progression, and this is where we had another trial which used the DGK zeta inhibitors. Again, this is a T-cell activation, causes T-cell activation, and it was used with pembrolizumab in this patient. The patient had 3 cycles of this combination. However, after this, he progressed in the right atrium, and thereafter treatment was called off, and it was end of life of care. This is another study in an MMRD case in a metastatic undifferentiated pleomorphic sarcoma. And if you see the lung this is 6 months after the treatment with pembrolizumab in this case. So you can see there's a larger lesion here, and that has responded. And similarly, his pelvic disease, which was large at 6 months on pembrolizumab, has shown significant improvement. Also, we found quite a lot of patients in our study set had homologous recombination deficiency, 19 out of 38 patients. And most of these were BRCA or ATRAX or RED51B. Most of these were soft tissue sarcomas, leiomyosarcomas, and undifferentiated. Amongst these 19 patients, 7 died without any treatment, any new targeted treatment. However, 12 were alive, and out of these 12, 3 patients received a PARP inhibitor. In summary, we can say that whole genome sequencing is diagnostic. It changed the diagnosis in 2% of my patients. It is prognostic, so 40% patients had mutations linked to the prognosis. It's been therapeutic in 35% of the patients. However, it translates poorly to the treatment because we don't have, and I'll explain in a little detail further as we go along, why not much treatment is available. And then, of course, novel fusions were found in 5% and a germline mutation. Now, this is what I've just explained is what a small group study that we did at our sarcoma center. Do we have any guidelines for next generation sequencing? I'm afraid we do not. So what happened was, this is the recent most paper in JAMA Oncology published in October last year. And it's a working group of medical oncologists, pathologists, and molecular biologists from sarcoma expert institutes in Europe, North America, and Australia. They met at the 2023 and 24 ESMO Rare Tumor Sarcoma meeting, and hence this paper was published with consensus on how and when the NGS should be done. These are the group of studies, and if you see, the Pendergrast was from a Stanmore, London group who prospectively looked at 100,000 patients, and only 350 patients had whole genome sequencing. And the change in diagnosis was only in 3 patients. At the bottom, the 2 studies are from the Cambridge University and Netherlands, and most of these studies are retrospective, only few are prospective. So because there are not many patients in sarcoma or rare tumors, we are unable to carry out large randomized trials. Approximately 2/3 of sarcomas, especially those with complex genome karyotypes, are unlikely to harbor any specific genetic alteration. The diagnosis of sarcoma should be performed and reviewed at sarcoma expert institutes, and a sarcoma expert pathologist should decide whether a molecular testing is required for diagnosis and which test is optimal. Again, this data set or analysis shows single institute studies where local practices, which reflects local practices, and it's difficult to extrapolate the data. The best known gene mutations are from the GIST, which is the KIT and the PDGFR, and hence we've got targeted agents. The rest of the studies, if you see, the level of evidence is from the SCART and the ONCO KB is really low to suggest any targeted treatment for the mutations present. Talking about the agnostic markers, again, we're aware now that the agnostic markers are being used in other solid tumors and there is clinical benefit. However, in sarcoma, we see these studies show really small numbers, hence not much role. With regards to the targeted treatments, again, in this data set, there is really small number of patients who benefited from the matched therapies. The current evidence does not support clinical use of NGS in sarcoma patients because of the low tumor burdens. And the indication for targeted agents in treatment of sarcoma is based largely on sarcoma subtypes, and therefore accurate diagnosis is indispensable. The actionable tumor-agnostic alterations with matched therapies are present in sarcomas to similar rate, but observed in the other cancers. The knowledge of molecular knowledge with ultra-rare types is extremely limited. Germline mutation is about 8% in all the cancer patients. And some sarcoma subtypes appear to be at high risk of bearing heritable genetic predisposition, amongst which the MPNST neurofibromatosis, leiomyosarcomas, Lee-Fermani syndrome, picomas, tuberous sclerosis, and the rest. In terms of cost effectiveness, there are no studies evaluating the cost effectiveness of multi-gene NGS panels in sarcoma, and hence this group is unable to provide any recommendations. It's only GIST, the gastrointestinal stromal tumor, where it is cost effective, and hence we've got adjuvant treatment in the first and second line now as well. So my key takeaways is molecular knowledge in sarcomas remain limited, and 2/3 of the sarcomas are unlikely to have any specific gene alterations. Traditional pathology, immunohistochemistry, and the RT-PCR FISH are sufficient for diagnosis as of now. Upfront use of NGS in all sarcoma cases is not recommended and should be reserved for specific subtypes or clinical scenarios where you've run out of investigations. It is extremely important to refer these sarcoma patients at the time of diagnosis to centralized and specialized sarcoma centers. And I understand I say this because I work in a sarcoma center and it's the West. But I think if it's a message that even here in a developing world, this is how the sarcomas should be diagnosed and treated. We need to refer them to specialized centers. And of course, the NGS should be performed by the iOS standard laboratories and interpreted via molecular pathologist and discussed in molecular tumor boards. The last two slides, I'm sorry, I'm going above the time. So what we are doing at Oxford University is we've got these two trials running, and these are nationwide trials. So one is a target national trial where all solid cancers can be recruited for molecular profiling in the circulating tumor DNA and sometimes in the tumor as well. And that kind of helps now that we have the funding for whole genome sequencing has been withdrawn. And secondly, we're running a determined trial. Again, that's a multicenter trial for rare cancers and sarcomas. What we're doing, it's an umbrella basket trial, and we're using different drugs. I'm not sure if you can see clearly. So we've got treatment arms where drugs are being used according to the agnostic markers. And this is an ongoing trial. Thank you.
Thank you, Dr. Sabah Imtiaz, for a nice discussion on the NGS-driven management of the metastatic soft tissue sarcomas. So much has been done. Still, we have to mature our data for the NGS in metastatic soft tissue sarcomas. So for the second talk, I will request Dr. Adil Ilyas. He is consultant oncologist, FCPS, FRCR, and is working at NSS Trust UK. So sir will talk on the role of immunotherapy in the irresectable lung cancer. Thank you, sir.
So thank you very much for having me. So again, I've got quite a bit of slides and we're going to whiz through. And I literally mean whiz through. Right. So we are here to discuss role of immunotherapy in resectable lung cancers. We are going to talk and focus on non-small cell lung cancer. My disclosures, again, a slide to tell you about the treatment journey for resectable lung cancers. 25 years ago, we were barely having anything with only adjuvant chemotherapy to offer. Next 15 years, in terms of treatment, very few treatment options were available. However, the focus was on diagnostics, improving the surgical techniques, getting the molecular panels sorted out, and then from 2020 to 2025, last 5 years, the world just opened up. Whatever we were holding back over the last 15 years, we have it now. So we have got adjuvant immunotherapy, chemoimmunotherapy, adjuvant targeted treatment, you name it, we have it. Again, the exciting bit is probably I find lung cancer as the tumor subsite, which is probably the most exciting after breast cancer, judging by the data that has come over the last 5 years. Again, my slides are predominantly data-driven. I'm a believer of pictures speak 1,000 words rather than me saying it. So again, I would want you to focus on the multicolored slides that I've put in because we're going to whiz through 50 slides to go. Oh, yes. So we always knew that resectable lung cancer, the prognosis is poor. You take the disease out, the disease comes back. Dependent upon the stage, the prognosis is bad. 5-year-old survival stage 3A to stage 3C, 41% ranging to only 10%. Again, the most challenging bit, what to do about stage 3 cancers, such a diverse field. What to do, stage 3A, 3B, multinodal station, single station, where do we stand, what do we choose? So MDT, everybody talks about it, this is the time we get it done. MDT discussion is really important because of the choices that you have got. Again, for the residents, staging is changing, stage 9 is already released. Again, we are still getting our heads around how to deal with the stage and what implications it would have. Immune system, so we are going to talk about immunotherapy. This is all about the immune system. So the immune system, one is the innate, what we have to build defenses against the bacteria, and one is the adaptive. Adaptive is what we focus on. What we have learned is that the cancer cells are really smart, more smart than me. So they try to evade the immune system. And the guiding principle is that if the immune system is not sitting well with the cancer, how can we instruct the immune system to behave properly and try to target the cancer cells? So from this concept, we move on to the potential that if you give immunotherapy, there's potential for greater tumor-specific T cell expansion with neoadjuvant and adjuvant immunotherapy. So the proposed rationale is, if you go for neoadjuvant treatment approach, the cancer is already sitting over there, it's heterogeneous clones. You give immunotherapy, you activate many different clones of T cells because you've got a large tumor burden with many different clones. The surgeon removes the tumor, and in the adjuvant setting, you still got pre-activated T cells, which keep a good watch out and fight multiple frontiers to make sure that the cancer doesn't bounce back. The adjuvant treatment, the immunotherapy rationale is surgeon would remove the tumor. Again, patient would get the immunotherapy. Again, you don't have a gross tumor, but again, you've got the immune system in place, so the immunotherapy is activating the T cells regardless. So again, there might not be multiple clones, but again, the immune system, we hope, is activated enough to keep the cancer at bay. यार मैं बात कर रहा हूँ तो हाँ ठीक है okay right so again what are the considerations to integrate immunotherapy into the care of resectable non-small cell lung cancer? You've got 3 strategies: neoadjuvant, perioperative, and adjuvant. Again, every strategy has got its pros and cons. When you talk about neoadjuvant, we say, well, it's a shorter treatment time, better treatment compliance because you've got a fit patient. It allows you to assess the response. You have potentially downsized the tumor, and then again, we are probably looking at early reduction of micrometastasis. For those who don't like this treatment approach, perioperative, I can already see a few smiling faces which are telling me that I'm going too fast, but I need to get the 50 slides done. Right, so perioperative. So perioperative, it eradicates micrometastasis, there is response assessment, but again, the treatment time is longer because you're giving something in the adjuvant setting. However, there's always the risk of over-treatment. And again, I think it will be an interesting debate to see what the panel feels like, whether we should continue 2 years beyond progression or we just stick to our guns and just treat for whatever time we need to. The adjuvant immunotherapy treatment, again, for those who advocate this approach, they say you don't have a fit patient to begin with. These are generally patients with multiple comorbidities. You give them treatment, they would probably decondition, and by the time they reach surgery, which is the definitive treatment, they're not fit enough to undergo an operation. So again, are you risking missing out on the boat for a definitive treatment if the patient gets deconditioned or the tumor progresses while on immunotherapy? But again, if they get resected up front, we say there's no risk of surgical delay, there's no risk of increased morbidity following the surgery, and then again, it gives you a complete pathological staging, which allows you to tailor your treatment options, and again, the treatment time is probably a bit longer. For all these three different criteria, we have got evidence, and that's what I'm going to show you. So you've got phase 3 trials for each and every of these approaches, which have proven efficacy. So again, we're going to talk a bit detail in trial moving forwards. NGS, Dr. Sabah told no role in sarcomas, the lung wins. So again, lung has got quite a bit of role. So again, all the patients these days, we encourage having an NGS report or at least molecular panel done, basically as a bare minimum EGFR, ALK mutations, and PD-L1 expression check. Again, whether it's feasible, that is something which the local dynamics would have to see where we stand with that, and it was heartening to see that we have got NGS panels in plan within the Pakistan, and there are quite a few companies that are interested. So again, early stage, you've got a role for NGS as well in the metastatic late stages. Next on, we are moving to trials. I'm going to show you pictures and graphs. I'm going to do a bit of a refresher about statistics because you guys are going to pick up on what I'm going to show you, okay? So there are a few terminologies. Event-free survival defined as time from randomization into a trial till the time the cancer comes back or the disease progresses or the person dies because of any cause. Pathological complete response. We are giving some sort of treatment before taking them to surgery. So again, we hope that our treatment has done marvels and the cancer is completely gone. Sometimes, most of the times, you don't get a complete response, but then you settle for whatever is done. So again, you say if there's a major pathological response, which is defined as less than 10% of the viable tumor cells, then again, that should make you pretty happy as well because something worked. And again, the last bit is disease-free survival, which is defined as time from surgery until the first recurrence. And these are all the definitions you would come across the data, which I'm going to show you moving forward. Why are we so concerned about the pathological response? Because over the years, what we have learned is that if somebody gets a pathological complete remission with neoadjuvant treatment, then you hope they would be the long-term survivors because their survival outcome may be better than what you have for the non-responders or partial responders. Neoadjuvant trial data. I'm going to start off with phase 2, NADIM trial. I put this trial especially because this dictated and altered the phase 3 trials that moved on. So this trial was a single-arm trial. What they did was they gave neoadjuvant chemotherapy with nivolumab as well as chemotherapy for stage 3A. And it was a single-arm trial. It was not a phase 3, not a well-balanced one because there was no control arm. But surprisingly, what they saw was that when you give this regimen, PCR rate was 63%, the MPR rate was 83%, which is major pathological response, and then 3-year and 2-year progression in a stage 3A cancer beyond 70%. So this got people excited. They were like, well, okay, the treatment really works. So this was the first data that we had. Meanwhile, concurrently, a phase 3 trial was being run, which was Checkmate 816. So again, it tested neoadjuvant nivolumab and chemotherapy in resectable stage 1B, for simplicity, 4 centimeter and above, and node-positive non-small cell lung cancer. So well-stratified trial, a phase 3 trial, what they did was they checked the molecular panel, EGFR and ALK mutations, and if the mutation was present, those were filtered out. So essentially speaking, NGS panel checking no sensitizing mutation and ALK mutation, and again, to go for a PD-L1 expression check. These people, the patients in this trial, they had chemotherapy, immunotherapy versus chemotherapy alone, went on to have surgery, and after that, it was just follow-up. It was left to the discretion of the treating physician whether he wants to give more chemotherapy or radiotherapy, but the trial did not mandate that. Again, you see these blue bars are for chemoimmunotherapy, the red bars are for chemotherapy, so again, the response as per stage is quite remarkable. Pictures, diagrams, colors, if you could just focus on these. Again, you look at the pathological complete remission rate, 24% in the chemoimmunotherapy arm versus 2.2. And then again, if you look at the graphs for event-free survival, we are 4 years down the line, and again, the curves are still well separated. Forest plot, because I thought it's easy to show the impact. So you look at stage 3A are the ones that benefited the most with reduction in hazard ratio. You've got the PD-L1 expression. Anybody who was PD-L1 expression more than 1% benefited. And again, there was a trend that more than 50% also benefit. And again, all favored the chemoimmunotherapy arm. It's not a very nice angle to look at it. So let me just tell you that I'm trying to struggle. So again, bear with me, please. Again, overall survival curves. 4 years down the line, the two curves are separate in the intention to treat population. In the lung cancer specific survival, again, the curves remain separate. So again, this was not happening before you had this, because we just saw on the first slide that patients who have resectable lung cancer, the survival from stage 3A, 40% at 5 years goes down significantly. And here, you're talking about 71% 4-year survival. So just see what the impact of the difference is. And again, for those who had PCR, the 4-year survival was 95% versus 63%. That's what you get if you respond completely to the chemoimmunotherapy. Surgeons in the room, a raise of hand? No? Anyhow, good for us oncologists, because we can talk about making a case here, okay? No voices in opposition. So, we also checked the impact of surgery on chemoimmunotherapy. So what we find was that they looked at hilar fibrosis in this subset of patients, and they find out that chemotherapy, neoadjuvant treatment did make it a bit challenging, but the chemotherapy and the neoadjuvant arms, they were comparable. So not much difference. And again, if you look at this bit, you see a red arm over here. This is what the phase 2 NEDIM did. Checkmate was originally a 3-arm study. They had combination of ipi-nivo, dual immunotherapy over there as well. So again, that arm was rejected or closed early just because the NEDIM data came out. So again, depending upon the surgical hands, there was a report that 40% people, surgeons felt that the lobectomies were more difficult, but it was particularly more noticed in the dual immunotherapy arm, which is this red bit over here. Again, what happened with the surgeries? So again, was there any complications post-op? So again, comparable in both the chemotherapy and chemoimmunotherapy arm. Again, you would notice over here that even in the chemoimmunotherapy arm and the chemotherapy arm, everybody nearly made it to surgery. So again, not much of a difference over here. And again, just to look at this one, people managed to have minimally invasive surgery compared to a pneumonectomy. And again, despite chemoimmunotherapy, a R-knotted resection was possible. So again, depends on having a good surgeon. So again, the gist of it is, if you're going to operate on any lung cancer which is resectable, take the surgeon on board first, because you need to tell them that you're going to give them treatment which can make the outcomes better, but the surgeon needs to be on board with you. It can't be a one-man show. Right. And the operative times were not so different as well. From the neoadjuvant, we move on to the perioperative trials. I envy the guys who are going to get 15 minutes to go over the next trial. Right. So, Keynote 671, again, neoadjuvant had already opened the door for nivolumab, right? So again, the other competitors jumped into the race. So again, you got pembrolizumab, the same concept. So again, what they did was, they had pembrolizumab and chemotherapy compared to chemotherapy alone, did surgery, but now this is perioperative, so there is an adjuvant treatment as well. So again, in adjuvant, you got immunotherapy maintenance for good 13 cycles. Again, this was based on the 8th AGCC study. So again, we have to look at the TNM classifications and figure out the data based on what the inclusion criteria was at that point in time. As with all the studies, the primary endpoint was event-free survival. The secondary was PCR and MPR. Just to show you that we did select the cases which were more in terms of disease burden. You see the stage 3 over here, which is about 70%. You see N1 and N2 stations, which comprises quite a good chunk of the tumor. Again, in this study, they were not very particular about taking out EGFR mutants or ALK translocation tumors. So again, there was a quite bit of patients over here which did not get formally checked for this, which is a caveat for this study. Again, when they looked at it, they found out that with this pembro and chemotherapy, you got 18% pathological CR and 4% in the chemotherapy arm, so somewhat similar to which we saw in the neoadjuvant arm. And again, you look at 75% patients got lobectomies, which is really good because, again, smokers, lifestyle changes, advanced stage for lung cancer patients, having multiple comorbidities, you want to really save their lungs so that they can have a good quality of life moving forward. So again, you want to avoid procedures like having pneumonectomies or big excisions. And again, most of them managed to get a R0 resection, which is basically clear tumor margins. Again, what we see in these green bits over here is the MPR and the pathological rate. So again, they basically looked at node negative. They probably did a bit better in terms of response rates, both in the PCR and the MPR, and again, in the node positive as well. Though it was, MPR was more or less the same, the PCR was slightly low, not a surprise over there, because again, more tumor burden in the node positive patients. Again, graphs and forest plots. So again, what the forest plot and the graph is showing is that it's a sustained benefit down the line at 48 months, in the tumor group, which is node negative. And again, forest plot all favors chemoimmunotherapy. If you look at the node positive disease as well, the graphs are well apart. And again, the forest plot says, give chemoimmunotherapy, it works. The 5-year survival update from this data is that you have got, again, quite a wide separation of curves. No treatment is without adverse effects. If you get immunotherapy for a long period of time, you're bound to run into trouble. People do lose lives. People do come across toxicity, that goes without saying. You lose patients within a matter of days. So again, I think the caveat is that if you're going to do chemoimmunotherapy, you need to engage the wider team from all specialties, because when things go south, they really go south. It can be a matter of time before you lose somebody. Again, you look at the side effects of immunotherapy, and they are more or less the same across the board, whichever drugs you are using, PD-1s or PD-L1 inhibitors. So again, you find out that endocrinopathies are most common, followed by pneumonitis, and then again, you got the hepatitis and colitis, but the risk is relatively less. But again, you get one bad patient, and that can make you lose your sleep. Again, checkmate 70-70, because nivolumab was only doing the neoadjuvant first. They did not check perioperative, so they said, well, if pembro can do it, we'll come and do it as well. So they replicated what they did earlier on, gave in the neoadjuvant setting, and then followed it up with perioperative. Again, the criteria was the same across the trials. 8th AJCC addition, more than 4 centimeter tumor with node positive disease. And again, they exhibited the same results like what we saw. There is good pathological CR, up to quarter of the patients got over here, 25% versus 4.7%. And you have got the event-free survival down the line at 18 months reported, and with the curves apart, and again, exploratory analysis showing that you expect that this to remain the same. Agent study, this is again durvalumab with chemotherapy, and then versus chemotherapy alone. The same concept or the eligibility criteria for the patients to come through. You have got stage 2A, more than 4 centimeter, up to stage 3B, so a bit more advanced staged. Give them chemoimmunotherapy, do surgery for them, take them on for maintenance durvalumab down the line, look for event-free survival, look for the pathological CRs. Again, what I found interesting in this one was durvalumab, because they were the latecomers in the race, so they took the experience of everybody else, and they scheduled their data in such a way to show that we really took bad aggressive tumors, so T3 and T4. This is what catches my eyes, that quite bulky tumors were included, and again, N1 and N2. So again, the tumor bulk was even over there in the nodes. And again, interestingly, they did a pre-specified group analysis for carboplatin versus cisplatin, because again, old age patients with bad kidneys, with multiple comorbidities, all the previous trials are looking at platinum, preferably cisplatin. But again, in real world, probably we would prefer carboplatin. So these guys, they were good. They picked up a carboplatin as a subgroup analysis and focused on those patients as well. So PCR, 17% versus 4.3% in favor of chemoimmunotherapy. The MPR, 33% versus 12% in favor of chemoimmunotherapy. You got event-free survival with the curves widely separated apart. You got exploratory analysis for N2 disease, which is basically advanced disease burden. And again, you see that the curves stay wide apart. And then again, you've got the comparison between cisplatin and carboplatin, and then they showed that yes, cisplatin is probably better, but again, carboplatin doesn't do as bad as well. So when you've got patients in the clinic, you have to really make a judgment call if they're fit enough to have 7 to 8 hours of treatment with prehydration and everything, or can you just get them out of the chemo room in 4 hours by giving carboplatin with less hydration, thereby not straining out their heart and kidneys. So again, it's a individualized discussion with the patient and yourself, how you feel your resources are. Again, interestingly, chemoimmunotherapy versus chemotherapy, the grade 3-4 toxicity is around the same, and adverse events, yes, slightly high in terms of leading to death in the durvalumab arm, but again, even chemotherapy makes you neutropenic, and there's always the risk of death which you get on the consent form when you're talking to these patients and informing them about making an informed decision. I need to take a break. Okay. Adjuvant trial data. So, we know that lung cancer services, when you talk about resection, it's a referral service. The patient is not going to come to you. They're going to land up from the GP or from the primary services to the surgeon who's going to see the patient. So you need to have a good rapport with the surgeon if you're going to get this evidence into practice. So you reach out to your surgeon, the surgeon is very nice with you, and he says, you know what, I'm going to refer you a patient, I believe in the data that you present. Or if somebody's like, no, well, I'm going to operate first because I don't feel comfortable operating after chemoimmunotherapy, then they operate upon it and then they send to you. So the IMpower 010 atezolizumab after chemotherapy in the adjuvant setting is what set the benchmark. So what we did was, this was based on 7th AJCC staging. It was stage 1B to stage 3A non-small cell lung cancer, essentially tumor more than 4 centimeters. With the PD-L1 analysis, and EGFR and ALK-positive tumors were permitted over here, because at that point in time, the results for the osimertinib was not out. So that changed things a bit. But again, that's a discussion for another day. So patients had after surgery adjuvant chemotherapy, and then they went on to receive durvalumab. No crossover was allowed. And if you look at the disease-free survival, this is probably the most important bit. Patients who had PD-L1 expression proportion score of more than 1, their curves got separated out quite remarkably well. If you look at all the other stages, the data becomes less convincing, but again, PD-L1 expression more than 1%, these are the ones that do benefit in the adjuvant setting. And again, with the significant p-value of 0.0039. Again, like I said, immunotherapy is not without its adverse reactions. Just looking at the clock. Yeah, so again, quite a range of side effects. Again, nothing too worrisome. They all got managed in the chemoimmunotherapy arm, and again, patients did relatively well. But again, 17%, so 17 to 20% is the percentage of side effects which you find in the chemoimmunotherapy arms. But bearing in mind that if you're giving it in the perioperative setting, these are longer treatments, carry a financial cost, carry a burden psychologically and financially on the patient. So there needs to be, like I said, the debate is going to be quite interesting what the presenters have to say when we move on to the last session. Pembro was, Atezo was not the only one that was in the race in the adjuvant setting. You had the Keynote 091 Pearl study. Pembro decided to jump in, and they said, well, the sea is wide enough for 2 sharks to exist. So chemotherapy was not mandatory in this particular trial. So again, patients had surgery, moved on straight up to having immunotherapy versus placebo. And again, we looked at the overall population. So again, the curves are overriding each other. But again, if you look at those who are more than 50%, this is the area of uncertainty, because again, at one point, the curves were nearly about to overlap, but then they separated again. If you look at the first plot, I've got both the IMpower, which is Atezo, and again, Pearls, which is Pembro, side by side. So if you look over here, there's pretty convincing evidence to suggest that if you've got a high tumor proportion score of more than 50% or more than 1%, these patients, okay, probably the battery is down, but again, more than 1%, more than 50%, these are the patients that are benefiting because they're getting better advantage from Atezo. Again, if you look at it over here in the Pembro trial, what you feel is that more than 50% is crossing the confidence line. So again, we are really not sure what's happening over here, but anybody who is more than 1% would benefit. And again, less than 1% probably don't benefit that much. Thank you very much. So to summarize, You have got adverse events in both of these trials. So again, about 20% which need to be managed. So again, collaboration is very important. And again, how do we decide? Probably a repetition of when I started off by telling you that you have to balance it out according to your patient's needs and having a meaningful discussion with them, because it's a commitment, not only on a psychological level, but on a personal level. And again, financial toxicity and side effects are linked to it. The key takeaway points: immune checkpoint blockade has become the standard of care for curative intent treatment of multiple tumor sites. We need to incorporate these novel drugs in the perioperative period. The choice between adjuvant, neoadjuvant, or perioperative strategies should be individualized to the patient and tumor-specific properties. And multiple randomized trials, like I've shown you the pictures, they show that the treatment works in combination. So to say that it's a standard of care, probably most would agree. We know that if you get a PCR, then probably the patient is lucky enough to have a better survival than those who don't achieve it. Atezo is recommended in the adjuvant setting for more than 1%, and as well as pembrolizumab, and they've got approval. We need more data on the PD-L1 negative patients and the node negative patient tumors, how they would respond, and what are the treatment options available to them. And we need more data on biomarkers, for which the perioperative approach helps, because you can do further testing and guide individualized tailored treatments based on what sort of response you got after surgery. So thank you very much. That's all for now.
Thank you, Dr. Adil, for a detailed discussion on immunotherapy and resectable lung cancer. Now moving forward, we are moving towards unresectable carcinoma lung. And for this, I will request Dr. Asghar Hussain Asghar. Dr. Asghar Hussain Asghar is the Executive Director of the PSCO. He's a co-chair of the ONCO 2026 and Senior Oncologist and Director of the Kiran. I am my senior and my elder brother. Thank you.
So elder brother ki base pe I got the chance. I'll spend more time than Adil. So there is no need to run that counter. Please just stop that one. So thank you very much, Adil. A very detailed talk, and I really learned a lot in this your talk. And you definitely mentioned all these things, which is resectable, which is not resectable, for where you have to go for the neoadjuvant, where you have to go for the adjuvant. But I'll be specifically talking what is up till now the standard of care, which is in the guideline now, and that have changed our practice, and that will now remain in the part of our practice also. So you know it very well. After this EGFR, there was a big change. We started with this erlotinib, and then came with the osimertinib. In the same way, in the ALK, we started with the crizotinib and came with the lorlatinib and all these things. But the thing which has been very significantly changed, that is in the case of this your chemoradiation in the lung cancer, which is not resectable. You know, the things are resectable only when the patient comes to you at a very early stage, like T1, T2, and not Leon. But there is a scenario where you have to take the surgeon on board, that whether this patient is resectable or not when it's a T3 lesion, roughly 5 to 7 centimeter, or when it's more than 7 centimeter T4 lesion, but even then it's resectable. When the lesion is involving this your parietal pleura, this your mediastinal structures, except that when not involving any great vessels, not involving any vagus nerve, something like that, then it looks to be somewhat resectable. Even we say that when it's a stage 3B, when the stage 3B, it's N2 disease. N2 disease means the mediastinal node over there. But all mediastinal nodes are irresectable. This have to be discussed with the surgeon. So I'll be discussing all these things, that which tumor is resectable, specifically from the surgical point of view, and which tumor is irresectable, and what to do after this chemoradiation. After this chemoradiation, everything is finished. Up till now, it was being finished. Everything was being finished. After this chemoradiation, we complete the chemoradiation, roughly 4 and 6 and 7 weeks treatment, then everything was finished, and we're not going to offer anything further than this. But now the guideline has changed that. They have changed that we can have a good option after this one. In the case of EGFR mutation, we have to start with osimertinib. And in the case of when it's a wild type, we have to start something other than this your chemoradiation, that is in the form of durvalumab. These both are in the drug standard of care now, so I'll be discussing something on the durvalumab and when to start, how to start, and whether this durvalumab is only for the lung cancer. No, it's other than also, like in the case of biliary tract tumor, like in the case of bladder tumor, it has been incorporated now. So let's start with this my presentation. Inshallah, I try to finish within the due time. And I have the disclaimer that some of the slides have been shared by the AstraZeneca, and they have launched this drug in the Pakistan. So let's start with this one. You know it very well for the non-small cell lung cancer. When it's a very early stage, stage 1, stage 2, you have to go for resection, no doubt in that. But how many patients, you're all senior oncologists over here, how many patients of having this stage 1 disease you see over here? Stage 1 disease, we have the good option of even SRS also, we have a good option of this resection also, but we rarely see any such patient with a stage 1 disease, like tumor having roughly 3 centimeter less than that, so it's very difficult to see. But you almost 7 to 80% of the cases are coming in this stage, and most of the time, even it's a good resectable patient disease, but patient is not so physically fit to go for the surgery. Patient is not a good candidate for the surgery because of the anesthesia issue and all these issues. So then again, the oncologist role comes in, that we have to go for some chemo radiation, all these things. So even this, when we are going to say it's an advanced stage and we are going to say it's a palliative, and we start some systemic chemotherapy and all these things, we have another option also. We can start something other than this field, immunotherapy and all these things. But in between this stage 1 and stage 4 disease, stage 2A and stage 2B, stage 3B. 3A is quite easily resectable. Most of the time, surgeon cutoff limit is stage 3A. As in the case of cervix, 2B is the cutoff for the surgeon. Here in the case of stage 3A, the cutoff for the surgeon. But not all surgeons even touch this stage 3A patients. We have to look for the good thoracic surgeon who can very well operate the stage 3A also. But the stage 3B, even a good surgeon will definitely hesitate to operate. So stage 3B mean we have to check whether this patient is having the mediastinal node or not. If there is a carina involvement, there's a big mediastinal node, we have gone for the PET scan, that is not a resectable disease. So when it's not a resectable disease, then what to do? We offer chemoradiation. And offer this chemoradiation in the form of combination with the cisplatin and all these things. But after completion of this cisplatin, we have to offer something more than that, which is in the form of immunotherapy, and that's the durva. Concept of resectability, I know. If your surgeons say that I can go for R0 resection, that is a good option. It should be taken out. But if R1 resection, that is not a good option. That patient will be coming back to you very soon with some recurrences also. So operability depends upon whether it's R0 resection possible or not. Or secondly, patient will able to tolerate this much lengthy surgery or also, if not. So if not resection possible, or if it's N3 disease, mean contralateral nodes are over there, or the supraclavian node are over there, this patient is not a candidate for surgery, this patient is a candidate for some chemoradiation. So you need a good MDT decision at that time. So this is a basic workup that we have to go for the clinical workup. CT scan, histological confirmation, you can go for the PET scan, but the surgical point of view, PET scan is mandatory before moving this patient for any surgery. After this surgery, after this PET scan, if it's resectable, then it should be resectable. If you just see, it's a very simple, basic T3, TNM staging. If this portion, this one, this looks to be somewhat resectable. This portion easily resectable. This portion is somewhat resectable. This portion is difficult to resect. So if you just see, even this T4 lesion, 7 centimeter plus lesion doesn't mean that it's not resectable. That needs a good surgeon who can take it out easily. But even with this T4 lesion, if this tumor is involved in some vagus nerve or any vascular structure or in this your any greater vessel, then it's not resectable. But if this tumor having N status higher, like N2 disease or N3 disease, it will become the stage 3B, then it's not resectable. So you have to look for this area, whether this patient is falling in this area or not. This one is easily resectable, this is barely resectable, this is easily somewhat resectable, but this is very difficult to resect. Okay, if you're going to pick incidental N2, stage 3, definitely we can go for possible resection with the MDT discussion and then adjuvant therapy as has been discussed. You can offer the neoadjuvant chemoimmunotherapy also or simple immunotherapy, but if resectable, then adjuvant. Most of the time, all these medicines which are easily resectable, you are going to start in the neoadjuvant setting, like in the form of Nivo or Pambro, then you have to continue in the adjuvant setting also. In this way, if you just go through this diagram, this lesion, both are resectable. But if you just move forward, this is the T3 lesion with the ipsilateral lobe, ipsilateral different lesion, it also looks to be resectable. But if this T4 ipsilateral node with N1, this also looks to be resectable. But if you just see this one, multiple hilar node, opposite contralateral node, and 3, but lesion is T1 and T2. So even if it's not so easily resectable, prognosis of this patient is so not so good. But if T3, T4, ipsilateral hilar node, but not supraclav, you can take it out. But when the supraclav involvement or opposite side of supraclav involvement, then it's not so easily resectable. So this all depends upon your good MDT discussion. But if you see, if you're going to resect this your stage 3 alien, your 5-year survival goes up to 38%. And if you don't resect, it's just only 14% with your clinical staging of this. And if you're going to go for this stage 3B, your 5-year survival is 24% versus 10%. So you can take it out if you have a good chance, otherwise your chemoradiation is going to cover all this thing. So 3-year overall survival, you can say not more than 20-25%, whether you're going to resect them or you're going to start with the chemoradiation. Specifically for this locally advanced disease, either surgery or chemoradiation. Survival is plus minus poor. And this is the 3-year survival rate. Law. If you go through this, your basic concepts of my next session, in my next talk, in the other session is about what is the basics of immunotherapy and how it's worked. I'll discussing all this thing over there, but just for the, I took this understanding that you all know everything about the immunotherapy and how it works. What is the PD-L1, where is the PD-1, where is PD-L1? I just assume that you know everything. But this is next to that. What happens, why are you going to start immunotherapy after chemoradiation? You can start with the immunotherapy alone and we don't need for the initial, we are not going to give anything that after this chemoradiation. Now, why this is the concept of starting immunotherapy in the form of Durva after this chemoradiation, whether this your immunotherapy is going to potentiate the results of chemoradiation therapy or it's something. If you just see, there is a concept that this your radiation therapy prime the T cell. Dendritic cell, it's going to increase the antigen presenting cell, APCs also. There is upregulation of PD-L1. So then this your drug is going to affect much better way when after this chemoradiation as compared to before radiation. So this is a basic concept that there is just like you are going to give some stimulus to the tumor, the cell which is in the dormant phase, they're coming in some mitotic phase, and then you're going to, same way is you're going to activate the PD-L1 combination. They're going to inhibitory signal started, you have to block that inhibitory signal, so T cell are activated in this way. This is a basic concept of immunotherapy. So if you can block this your binding of this PD-1 with PD-L1, like in the form of any Durva, Pembro, or something Nivo, so you can have a better T cell activation. So your inhibitory signal will be less likely to be effect on that. So these are the famous Pacific trial, phase 3 trial, Durva with the name of Imfinzi. In the stage 3 trial, they randomized this patient with this chemoradiation, and they start with the Durva with 10 milligram per kg body weight. It's a fixed dose in the form of 15 milligram after 4 weeks, or it's in the form of 10 milligram per kg body every 2 weeks, and then they continue that. And if you just see the response rate, there's 32% reduction in the risk of death, overall survival. Overall survival is, I'm not preaching this group, but here was 28 months, and 1 year and 2 year survival was better with the continuation of the Durva after this chemoradiation. Same way, and if you just see, it's difficult to read over here, but even this was going to affect in the PDL1 less than 1% or more than 1%. You can start with the PDL, but if you have the good PDL1 expression, you can have a better response. But if it's not there, if you've not done that, you can even then start this PDL1 one because this is going to have a response in the both in the less than and more than 1%. So this your forest plot is showing that Durva is going to affect in both groups. Same way, this is your progression-free survival with the 11.6 month improvement with the median PFS with the Durva as compared to the placebo. So this is also going to show on the basis of this trial, it got into the guideline also that this is going to give you the overall survival benefit, not only the progression-free survival, it's also going to give you the overall survival benefit. So you can start with this one, and it is the guideline now. So, okay, now this is the 5-year survival. Now it has been updated. The 5-year survival, 42% versus 33% with the placebo, with the continuation of the Durva. But continuation is up to 1 year, not more than 5 years, more than 1 year. Up to just 1 year. After that, you can stop this one. Okay, and now we are moving towards this another trial. We have a shortage of time. Let's see. After this chemo radiation in EGFR mutation. Before that, this was the wild type EGFR. Now it's EGFR mutation when it's a when to start with the TKI. This is the LAURA trial, very famous trial. And after this EGFR, even after this surgery, you have to go for this. But if you've not gone for the surgery, this LAURA trial is going to show you that after this chemo radiation, you start with this osimertinib, and you can have a better results with this. Continue in the same way, it's also going to give you the oral survival benefit and all this one. So up till now, in the stage 3 inoperable disease, Durva is the standard of care for EGFR wild type after chemo radiation, and OC is the standard of care for EGFR mutation after chemo radiation. So both are the standard of care now. So this is the final last slide. If you just see, go just one minute more. If you just in the last slide, these are the multiple trial. Agent trial has been discussed by Dr. Adil just now. Pacific trial I have just shown you. This is after chemo radiation in the case of lung cancer. Durva. Capsin trial in the case of small cell lung cancer. Also recommended in the small cell lung cancer, the first line treatment in the extensive stage small cell lung cancer. Topaz trial is for the biliary tract tumor where it's not resectable disease, locally advanced or metastatic biliary tract tumor. You can combine Durva with Gemcis. Agent trial, I would just say in the neoadjuvant setting of this lung cancer, and then we can continue that. This is a Adriatic trial. This is a single agent trial, single agent for the patient with a small cell lung cancer whose disease has not progressed after the concurrent chemo. So the counterpart of this non-small cell lung cancer is this your Adriatic trial. This is the DUA-E trial. This is the combination of paclitaxel with the first line treatment with the Durva for the recurrent cases of metastatic tumor with the endometrial tumor, and specifically for the MMR deficient tumor. You can start with this combination with the paclitaxel and Durva. And the last trial, which is the Niagara trial, where they use this Durva in the neoadjuvant setting for the Gemcis combination, and then they underwent this patient radical cystectomy, and they have shown the good response rate. So I think this is end from my side. So if you have any question, you can ask. Thank you very much.
Thank you, Dr. Asghar. Now moving towards the last but not least presentation of the first part, I will request Dr. Tariq Mahmood, Dr. Rana Irfan Mahmood साहब.
कल शायद उम्मीद वाला ही हादसा हो गया ये उनसे
आप दिलों में बसते हैं सर.
चलें बस ठीक है, नो प्रॉब्लम, बस ठीक है, इसको खोल लेते हैं. चलें, टाइम कम है. थैंक यू वेरी मच. Okay, so while the slides are loading, this is a very simple and brief presentation about which some of the centers I have already been talking to. It is an idea to implement spatially fractionated radiotherapy to treat advanced cancers which we see all the time in our practices. So there are two different words which you will see in the literature. One is called GRID and the other one is called lattice. Both mean the same thing. Grid is using 2D and lattice is using 3D, but the idea is the same, that you don't have to treat the whole cancer. You can just treat part of the cancer, leaving the tissue in between, not exposing to much cancer, and relying on bystander effects, immunomodulatory effects to affect the neighboring cells. It's not a new idea. It was tested more than a year ago, more than like 100 years ago now. And that was basically to save people from the skin toxicity when you have to give radiation deeper. Instead of giving the full open field, you just gave the radiation through open and closed fields, so avoiding the skin burn. But then we are talking about here the tumor effects, not the side effects of the skin. And I will not put a lot of data in terms of the background, but I will encourage people to read the review articles which are available online, that why there is very convincing evidence of bystander effect and immunomodulation. Just one interesting the cells which were not even radiated. So 30% of cells showed an increased frequency of this change, while only 1% cells were supposed to be traversed by the alpha particles. So that is the kind of start of that thing. And Dr. Mohyuddin, our mentor in Saudi Arabia from US, his son is here, Dr. Majid Mohyuddin. Their name will be in another publication later on as well. Both are carrying on the grid and lattice idea to the next generation. So there are lots of biological mechanisms. I don't think we have time to go through that. But here is the point, that there are lots of clinical studies all along for nearly half a century now, which shows that not radiating the whole tumor, just radiating the part of the tumor, it actually does work. So I will just give you a couple of case reports before we move on to the practical aspects of that. This is a 33-year-old male, lung cancer, PD-L1, perhaps the case which Adil highlighted, more than 70%. Rapid progression of the chest wall from 2 cc to 63 cc with pain and bleeding. I don't know whether you can see the images. I think you can. The tumor there, it was rapidly progressing with causing a lot of pain and bleeding. And this patient was given SFRT of 20 gray. And this patient has multiple other sites of METs, but this are the only site which was progressing, despite the fact that the patient continued on the immunotherapy. So only giving SFRT led to this outcome, which is very clear on the screen. So the interesting part is that if you go back and try to estimate the uniform dose given to the GTV, you find out that this 20 gray, yes, it was given, but it was given to kind of 7% of tumor. So this means that if you uniform dose, if you calculate that, you only gave 1 gray to the GTV. And do you think the people who practice radiation in this room, do you think that 1 gray would have caused this? Answer is no. So what's going on? And that is the kind of thing which we see in clinical practice. What could be the reason? The reason, we postulate it that when you do the spatially fractionated radiation, the name sounds a big jargon, but basically what it is that you treat a small little part of the tumor and then leave in between the empty spaces, which means that you want to escalate the dose to the part of the tumor and really de-escalate and low dose to the normal, the remaining tumor in between, to allow the internal tumor circulation, perfusion, and potentially facilitating the infiltration of APCs to prime cytotoxic cells. And that could reprogram the immunosuppressive microenvironment to become more immunogenic and could be synergistic with checkpoint inhibitors. And these are the kind of work which is going on, and it will go on for next many years to come. And I think we're going to see much more results coming on in the next few years. So this is my journey into SFRT for the first time with Dr. Mohyuddin. We did 33 cases and we presented that in like 13 years ago now. 33 patients we did. And here you can see that the outcomes were kind of this. that you basically give 18 to 20 gray single shot, followed by your standard palliative, whatever you decided. I was going to give 20 in 5, 30 in 10, whatever, but you just gave single shot of SFRT, and this is the kind of thing you get. We also treated some sarcoma patients with preoperative radiation, standard 50 and 25. What about just give a grid? And I saw these kind of things on the skin, and I called it leopard sign, and that was the only evidence that the patient had a grid. And that is the dose profile here, which is high dose and low dose areas in the tumor. So this is another study which was published actually this month, where there is a large institutional experience radiating lots of these tumors with the grid followed by the standard palliative radiation, and very encouraging local control rates, much higher than what you will otherwise imagine. And this slide is relevant to the last slide I'm going to show you, where I'm going to talk to you about discussing the cervical cancer program incorporating the grid. So here you can see that these guys, they did this study where the patients had 200 cc of tumor, more than that, and they gave the grid followed by the radiotherapy part, and saw excellent tumor response and local control. So we are going to talk more about the cervix cancer at the end when I convince you that the grid works. And the way a grid works is very, very simple. It used to be Dr. Mohyuddin had that big physical grid. You plant it onto the machine, turn it on, and that's it. But that had its own problems as well, because it's a heavy thing putting in, and then you can't have three-dimensional dose distributions. So the people in Mayo Clinic, in discussion with Dr. Majid Mohyuddin sitting here, they came up with the VMAT approach to create the grid pattern inside the tumor by planting virtual spheres in the tumor for high dose, and in between leave the empty spaces. So that was the lung tumor, and this is the abdominal tumor, and you can see that 3 months later the tumor is showing significant shrinkage. Not all the tumor is getting radiation. High doses are here and very low doses are here, reflected by this dose profile. So that went on to publish also in the same journal that how to do this grid. And in my department, this is what we practice, and we started at Inmol Hospital as well. It is such an easy thing to execute the grid and test it over and over again, that it doesn't add much into the side effects, because you're not treating the normal tissue and you're treating the partial tumor. So it is just a run through of this procedure which we do, adopted from that Mayo publication. So basically you just have a GTV outlined here, and then on the GTV we just put a mesh, a 3 centimeter by 3 centimeter mesh, and on that 3 centimeter mesh we follow the program of which published by that Mayo group, that we put spheres of 1.5 centimeter using the 3D brush of 1.5 centimeter, place them every 3 centimeter apart in one direction and 6 centimeter apart in the axial direction. So this is how the spheres will look like once you have placed them, and then you transform these structures. What are you trying to do here is that you are creating 1.5 centimeter sphere to start with, although you know that the dose you're going to give is restricted to the center of that sphere. So this is an interesting concept on its own when it comes to optimization. But as I said before, it is an extremely easy, anybody physicist in this department, we can talk later about it as well. It is such an easy procedure to optimize. So we are basically now going to create the spheres around it, the control spheres around the main spheres at 0.5 centimeter, 1 centimeter, and 3 centimeter by using a simple tool in your Eclipse program. And that is what will lead you to the control spheres, which you're going to control for the dose. So these rings are created. And then on the optimization program, you start the simple optimization to the all spheres. And then, what is this one here? Okay, so cancel. No. Something popped up on my screen, not there. Okay. So here you just optimize it as the normal you will do. And then you will have these kind of, the DVHs. And here you can see that you have the DVHs for the control spheres, and you have the DVHs for your target spheres. So what's coming up on my screen? It's hiding the whole thing. Should I just cancel it? It says cancel here. Something SAVS VMAX or
No, इसको
whatever.
cancel.
Cancel? Okay.
ये उधर नहीं आ रहा.
Oh, disconnect all devices? I hope it's yeah, it's going to disconnect the whole device.
चल, continue.
No, did not disconnect yet.
ना मैंने उसको minimize कर दिया. यहाँ से.
Yeah, that's okay.
ये pointer.
Yeah, okay. Oh, you can see the pointer there? Yeah, okay. So, so these are the spheres, you are controlling it. And at the end, what you are trying to do now is that you are increasing the priority of those spheres you created outside those, the target spheres, the control zones. Their priority you will increase, so the system will try to squeeze the dose out of the target and minimize the control, the dose to the spheres, to the control spheres. And that is how you will gain, will shrink the dose gradient. The gradient of the dose from the center of the sphere will fall off very, very rapidly. And then eventually what you will get is a situation where all the target spheres are coming at the target dose. Your plan is to give 50% of the sphere covered by the target dose. Now, the 50% of the sphere is basically 1 centimeter, which was supposed to be the initial plan that we want to place 1 centimeter diameter spheres. So it sounds a bit complicated, but anybody who is familiar with Eclipse, especially physicists and other people, we can talk after the meeting how to do it. But it is not a difficult, if a radiation oncologist like me can understand and optimize it, anybody can do that. So you can adjust the doses to the spheres to eventually reach to this conclusion, which is a high dose into the spheres and dissipating doses to the surrounding areas. And eventually you will get this thing, which is the dose profile showing a peak and the valley. So that is what you get at the end. However, we know from the literature that you want to push this valley down because you want to really spare the tissue in the middle to keep that environment going for the immunomodulation and immunogenic signals. So that is where currently we are working on the rapid arc dynamic, which is a new thing on top of rapid arc, which is just launched a few months ago. So we are working on our previous patients to see whether rapid arc dynamic will actually lower down the valleys even further. So we are presenting that in Variance Summit next week in Dubai. So the last bit here is that clinical aspects of spatially fractionated radiotherapy. Again, this is the same thing, showing that how to draw spheres. Eventually, what we do, we create 8-grade isodose as a structure to see whether everything is covered and keep away from the organs at risk. Again, this is the dose profile you get, and that's the dose distribution will look like on the planning system. So this is another example where the patient had a large malignant Floides tumor, had 39 in 13 with severe pain, came with recurrence, and had a single fraction of 20 gray grade, which is a significant benefit you can see on the other side. This patient had a sarcomatoid mesothelioma with severe chest wall pain, had 20 in 5, preceded by a single shot of 20 gray with significant benefit, and all of us know that sarcomatoid mesotheliomas are hard tumor to treat. So this leads me to the last couple of slides. This slide is dedicated to one of the co-author who is sitting here, Dr. Majid Mohyuddin. He is happy to answer all of your questions pertaining to this slide. So and this is basically related to the international consensus on design of prospective clinical study for advanced cervical cancers. So to me, it is very interesting because this is a scenario which we deal very, very often, unfortunately, in this country with large tumors. And those tumors sometimes are so big that you don't know what to do with that, whether you start with chemoradiation or you do something beforehand. Interlace is saying that give chemotherapy before, but that's another scenario. I think there is a topic somewhere as well about the interlace. The interlace did not have a proper embrace-style chemoradiation, so we don't believe that it really matters if you give proper chemoradiation. So there is a possibility that you can squeeze SFRT before you start the chemoradiation to get the rapid shrinkage. These guys have worked already for us, the inclusion-exclusion criteria and everything, and the trial protocol is already there. And I came up with the term called SARC, and Dr. Majid rightly pointed out, why not SPARC? So it could be the SPARC trial, which is done through the PSCO platform, which is a spatially fractionated adaptive radiotherapy for advanced cervix cancer. Okay, so we already done a workshop for online adaptive with a small field, large field kind of thing. Add a single fraction of SFRT before, start with 4 gray single fraction. If everything is fine, escalate it to eventually get to the 15 gray single shot, which you can technically ignore because you did not give any dose to the surrounding organs. So you can ignore that in terms of OARs. So you give 15 gray single shot SFRT, and then you forget about that and continue on your normal chemoradiation program with brachytherapy as well. And one could possibly think about synergistic effect of low dose Pembro. Although Pembro is very expensive, people can't afford it, but low dose Pembro maybe can be discussed with the company or whatever, or can be afforded. And the last bit is the basket trial, which all the big tumors we see in the abdomen and the lung and the head or whatever, 15, 20 centimeter tumor, we are going to give them palliative radiation, just give them a single shot of SFRT, plus minus, randomize them, and make it just a basket trial. So these two are very easy things to do on PSCO platform. I think other doctors, Mark Macon or somebody else is also already discussing about some trial ideas for the PSCO platform. This is one of some of the things which we could go on and discuss. Okay. So we'll be happy to take any questions.
Thank you, sir. I apologize for taking incorrect names, sir. Thank you. So we are running short of time. Now moving towards the second session. This will be our debate. So debate will be, sir, आपकी moderation है, आप ही आ जाए. Thank you, sir. I'll call Dr. Rana Irfan Mahmood, sir. Please, sir.
Thank you. Yeah. So before we go to the debate, if there are any burning questions about the subject we already covered, we can maybe take those 2 or 3 questions before we move on to the debate, because that will open another can of worms, and then one can have another discussion about that. So we had to talk about sarcoma. Excellent talk. We had talk about 50-slider lung cancer. And then we had talk from Dr. Asghar as well about lung. And then we had talk about the SFRT, just to remind those people who are here in this room an hour ago and then forgot what was it before. Okay, so any burning question about anything? Yes.
SFRTs,
yeah.
Fractionated radiotherapy, because we are doing it with lattice technique since 2023.
Excellent.
And till now we have done about more than 20 patients.
Very good.
And a wide variety of them. In fact, all of them were huge tumors. We have treated cervix, we have treated breast, and sarcomas, all kinds of sarcomas, no matter they are in limbs or intra-abdominal or pelvic, all very huge. So in all of them, in most of them, also head and neck, very huge tumors not responding to anything. And in all of them, we have found very good responses.
Excellent.
Initially, when we started, we were apprehensive. So we started with 24 grain 3 fractions, followed by conventional radiation. But now, as we are gaining confidence, now we have started giving more than 15 grain single fraction,
Excellent.
followed by conventional
good.
fractionation.
Excellent.
So this is just...
So stage is already set for these type of trials.
Yes.
The large centers already have experience just to sit together and create a protocol and shoot it.
Yes, and also with International Atomic Energy Agency, we are formulating a protocol.
Excellent.
To start it in lower middle income countries where
Very good.
see huge
Excellent.
tumors.
Fantastic. Thank you. Yeah, Dr. Asghar.
Thank you very much, sir. A question from Dr. Adil. That after this been so many significant trial in the case of lung cancer and non-small cell lung cancer and small cell also, do we see that is there a role of now PCI after this so many immunotherapy, and then we are going to continue with the immunotherapy in the maintenance? Still, we have to go for the PCI or not?
Thank you for the question. So again, I think when we talk about PCIs, we know that PCI is a very old concept. And again, because we always knew that small cells were behaving a bit more aggressively compared to what you get in non-small cell. So there's a Japanese trial in which they already figured out that given the new cognitive decline, it's not appropriate to offer each and every patient. I think if you look at the randomized trials, when they incorporated immunotherapy, they left it to the discretion of the physician to do it, whether you want to have it or whether you don't want to have it. Particularly when you talk about extensive stage trials, the trial did not specify even when you need to give consolidative radiotherapy. So again, it's more about a discussion with your patient that what do they feel about it? Again, when you don't have a right answer, that's a gray area. You don't have any evidence for it. I don't think you ever will get one. It's more about what the patient feels about it and what you feel as a treating clinician. Again, like I said, With most of these treatments, I can tell you my practice, what I do is when I give patients treatment, I offer it to them. I said, well, this was the old way of doing it. The trial didn't specify that now. Again, my personal practice is if the patient agrees with me, I continue with the standard of care as per the trial. And once things go south, they do develop some symptoms. Then I say, well, probably this is the right time now to have brain radiotherapy. And then again, I can continue with IO. I think you have to look at the criteria with a bit of this flexibility. So when you are looking at trials, there's a certain protocol. But again, it's your gut feeling, which you gain with experience, whether you want to, in real life, whether you want to carry on continuing with the immunotherapy if you don't have otherwise visceral disease.
So I was going to say that no more question, but our teacher is raising hand, so we can't say no to the teacher. So Dr. Ikram Birni.
Irfan, for a very nice talk, and this is probably one of the few occasions where even a medical oncologist can understand radiation oncology when you talk. Thank you very much for that. My question is about this basket trial, Irfan. We know that different tumors have got inherent radiosensitivity or resistance. How do you decide on the dose of radiation when you treat something which is as chemosensitive as cervix or something which is as radio-resistant as sarcoma, for example, or head and neck or prostate? So
Excellent question. So the SPARK trial is for the radical bits. The basket trial, as Dr. Humaira already highlighted, is for those comers who are just a candidate of a palliative radiation. So, and we don't differentiate between the tumors when we decide to give them 20 in 5 or 30 in 10. Our aim is just to get rid of pain, shrink a tumor a little bit, stop the bleeding. So can we gain more ground by just giving them one extra bit before it? So that is the basket trial we are proposing, not based on any single pathology or sensitivity or anything. When you decide this patient is needing palliative radiation, randomize them into just palliative radiation, which you're going to give, plus minus the single shot, which is currently being practiced already.
What are we expecting with START trial? Because already we are getting very good complete responses when we are giving dose to HRCTV in cervix more than 90 grade, EQD2. So already we are getting very, so are we expecting to
So excellent. So the thing is that we are talking about large locally advanced tumors where you have the keynote and everything else going on. So and Interlaced said that, oh, give chemotherapy to shrink it. Now, if you have a very large tumor, sometimes your concern is that, oh, this is so large that at the end of the radiation, will it be still suitable for brachy or I have to wait or whatever? There are those patients. So those patients, this is what we want to show, that there is no harm to give them a single shot before you give.
Maybe in 4A. Because
Yeah.
Maybe in 4A, because in lattice we can easily save ORs.
Just a bit to add on. Interlace on the papers look good, but again, people who have been practicing it, when you give 6 weekly carbopecli, generally they become many a time so neutropenic that you can't have full course concurrent chemoradiotherapy. So whether you're compromising on your standard of care by giving a bit more induction, that is something to
we
look
will
at.
restrict our discussion on the chemo bits in the presence of Dr. Ikram Birni. He's a gynecological medical oncologist, and he will start and then will not stop. Okay, so now we are going to move on to the very, very important debate. And the debate is about what Adil mentioned in one of his slides out of 50, where he said that should you stop or not stop when you are on the maintenance with PDL1 or PD-1s, right? So to debate that, for it, I invite Dr. Hiba Siddiqui from Ziauddin Hospital, and she will be saying that fixed duration therapy reduces the toxicity cost and avoids overtreatment with minimal impact on survival. So that is what her motion is.
Assalamu alaikum. I'm Dr. Hiba Siddiqui, and I'm working as a senior instructor at Dr. Ziauddin University Hospital. So today I'm going to talk in favor of fixed duration of ICI is better than continuous administration of ICI till disease progression. So the content of my presentation will cover the landmark trials, the real-world data, patient-related issues and attendant-related issues with continuous administration of ICIs, and pros and cons of the fixed-duration ICIs. So to begin with, what did the landmark trial show? So this is a table where you can see the phase 3 trial, which they designed for the fixed duration of pembrolizumab. And the majority of the trial, they compare immunotherapy with the chemotherapy. And their conclusion was that immunotherapy increased the progression-free survival as well as the overall survival when they compared with the chemotherapy alone. One of the phase 3 trial, the only trial, randomized controlled trial, Checkmate 153, it compared fixed duration with the continuation of the immune checkpoint inhibitors, and they reported that median progression-free survival was 9.4 months. However, in continuous group, they said that median progression-free survival was 24.7 months. So what the real-world data says. So this was the paper published in 2024. Basically, it showed the real-world data regarding the pembrolizumab monotherapy survival benefits in metastatic non-small cell lung cancer. So here you can see only for the trial, as I have a very shortage of time, limited time, so I cannot show you the all trial real-world data. But this was the Keynote 024, which is a very pioneer trial. But as you can see, the survival in the real-world data was not much aligned with this specific trial survival. This is another paper which assessed the association between the duration of immunotherapy and overall survival. So here you can again see the graph is much overlapping, and the overall survival is not much different in both the arms. This was a systemic review. It was published last year regarding the efficacy and safety of 2 years fixed versus continuous immune checkpoint inhibitor therapy. So here you can see that Ardien et al., it showed a 3.9% benefit in overall survival while giving the continuous administration of ICIs. However, it also gave benefits of 4.4% of giving continuous ICIs in the progression-free survival. And there is another study that is Gare et al. It showed 14.3% overall survival, whereas it did not show any benefit in the progression-free survival. The Kobayashi et al. Also showed no benefit in overall survival while giving the continuous administration of the ICI. Again, the Rossi et al., the Sun et al., they showed no benefit or 2% benefit in overall survival, just while giving the continuous administration of ICI. Similarly, if I talk about the toxicity, so the toxicity was definitely more in the arm where the continuous administration of the ICIs were given as compared to the 2-year or 1-year fixed immunotherapy. Here you can see that Kobayashi, they also reported grade 3 immuno-induced adverse side effects. So they reported in their discussion part that the patient was stopped after fixed immunotherapy for about 1 or 2 years, and then patient's disease progressed, and then on the second course, patient developed this grade 3 adverse effect. So my question is, what is the purpose of getting the benefit of 2 to 3% in progression-free survival while no benefit in overall survival? So what is the rationale of asking the patient and their attendant to come again and again every 3 weekly to wait in the overcrowded clinics, to ask them for the expensive labs and hospital admissions, while just you are getting benefit of 2 to 3% in progression-free survival? So now, if I talk about the patient-related issues with the continuous administration of ICIs, I am going to show you 2 very good studies. One is regarding the psychological distress with the quality of life when you give immunotherapy to the non-small cell lung cancer patient. So they divided the patients into the 2 groups, one with the psychological distress group and one with no psychological distress group. the patient in no psychological distress, they had less progressive disease as compared to those who had a psychological distress. So they were more on the side of progressive disease. Similarly, over here, you can see that the progression-free survival was inferior in the patients with the psychological distress as compared to the patients with no psychological distress. And if you combine the immunotherapy with the chemotherapy, definitely the graphs falls more. This is another study, and it is very famous, is stress lung study. And they also assist the emotional distress in the patient who are receiving immune checkpoint inhibitors in non-small cell lung cancer. So again, you can see that the progression-free survival with the emotional distress, it was worse as compared to the patients who had no emotional distress. Now look at this graph. As I'm standing in the Pakistan Society of Clinical Oncology, so I'm focusing right now on the Pakistani population that we are facing in our clinics daily. So this is basically the graph in which you can see that the depressive disorder and the anxiety disorder in male as well as in females, the prevalence of these psychological disorder is very high. This was a paper published from the Shifa International Hospital, and again they reported that unmet psychosocial needs, the most of them, they were the psychological needs. So again, my question, who checks the psychological distress and emotional distress in patients of non-small cell lung cancer in our part of the world before giving ICIs? If I talk about the financial toxicity, definitely the financial toxicity is a very huge problem in Pakistan also. Basically, the trial makers, they design the trials in such a way they enroll highly selected patients, like the patients who had the performance status of ECOG 0 or ECOG 1 with the very well-nourished patient. However, what we are receiving in our clinics, they are not much well-nourished, as well as they don't have a good performance status. Usually we are receiving the patient in our clinic on wheelchairs, patients of the lung cancer. So also I would like to highlight the attendant-related issues because they are very underestimated issues, because the attendant who are coming with the patients, they are on one hand, we are trying to treat the patient, right? But on the other hand, we are also losing something, that is the psychosocial need of the attendant as well as the patient. So this, again, I'm going to show you two studies. This was the study specifically for the attendants who were serving their relatives diagnosed with lung cancer. So they, basically majority of them, they were spouse, right? And they served their patient more than 6 months, more than 6 hours a day. And if you see this graph, this paper reported that this, the anxiety and depression in the attendants, it was more as compared to the other issues like mobility, self-care. So the most important, the adverse, you can say adverse effect of the attendant, that they are coming with the patients on the daily basis or sometimes every 3 weeks with the continuation of the ICIs, they are also having some sort of anxiety and depression. This was a very good paper, and it was not specifically for the lung cancer patient attendant, but also it is just for the lung, for the overall cancer patient. So majority of attendants were their partners, and what they did, they gave a questionnaire on the day 45 to 60 days after the diagnosis, and then they gave same questionnaire 180 to 200 days after the diagnosis. So the pattern of their total burden, emotional burden, financial burden was in increasing pattern, if you can see over here. In the last, I would just like to show you the NCCN guideline for low socioeconomic countries. If you click on the international adaptation and you select the region, like for example, I select Sub-Saharan Africa. So you can see they have fainted all the immunotherapy. Even if your patient cannot afford the immunotherapy, you can treat the patient with chemotherapy alone. And in the last, just summarizing my presentation, that the minimum wage in Pakistan is approximately 37,000 per month. However, the national average is 82,000 monthly. But look at over here. Yeah, so look at here. This is the one dose of the Keytruda, that is pembrolizumab.
We had only 10 minutes to convince you guys that the Keytruda should be continued only for 2 years and then
Yes,
stop it.
yes.
So everybody,
Maybe
please,
1 year.
Can you raise your hands who agree that it should be stopped after 2 years?
A discussion should be made with it.
No. Okay, 1, 2, 3, 4, 5, 6, 7, 8. Okay? Okay, Javeri, I think your task is easy because only 8 people are saying that stop after 2 years. So Javeri is going to tell us that no, the continuous therapy may improve long-term outcomes in selected patients. Evidence for early discontinuation is very limited, so please continue. Okay? So then we'll ask show of hand again to see whether people...
No, my job is more difficult because practically she's not doing it.
Does not matter. She's a debater.
Yes, he has to.
It's not Karachi versus Islamabad.
It's going to be.
Remember, your boss is sitting here.
This is not my slide. Assalamu alaikum. My name is Dr. Javeria Haider and I am from Atomic Energy Cancer Hospital, Noori. Before starting my presentation, I would like to thank the entire team of Pakistan Society of Clinical Oncology for considering me for this opportunity. And I would also like to thank my teacher, Dr. Humaira Mahmood and Dr. Mohammed Fahim, for always trusting me with such responsibilities. So we have had a very good session today regarding the sarcoma and lung, and I'm the last presenter of this session today. I will not be taking much time and will try to summarize the entire key points. So as we've already mentioned, that my topic is about maintenance therapy and how giving immunotherapy for longer than 2 duration may be beneficial for patients with metastatic non-small cell lung cancers. So I'll start off my presentation with this very favorite quote of mine that says that happiness can be found even in the darkest of times if only one remembers to turn on the light. So what is the importance of this debate? I'm not going to be going through the facts again. The importance is this, that we do not have a consensus on whether 2 years or whether maintenance therapy in the first place, which is the right thing. So currently we don't have a consensus guideline. We do not have a standard protocol for this. And that's why this debate is very important. And considering, of course, the financial toxicity in this part of the world, but we cannot just consider the financial toxicity. We need to understand the biology behind the immunotherapy and how immunotherapy is a bit different from chemotherapy and why is that an important perspective. We cannot, of course, offer chemotherapy lifelong, but we can offer immunotherapy because of its biological differences from the chemotherapy. So the first point is that immunotherapy has now become the backbone of lung cancer. And this is very important because now even patients with curative stages or with non-metastatic locally advanced diseases, we are offering immunotherapy, which has markedly led to improvements in survivals with very less toxicity. So that's one point in favor of immunotherapy. Secondly, as my colleague has already mentioned, that the 2-year protocol is only something which is related to the trial design. So because we need to get results of the trials by the end of 2 years, that's why majority of the trials were giving immunotherapy only for 2 years. It's not something that has been proven as a part of the protocol otherwise. Secondly, the reasons for giving immunotherapy for 2 years are generally arbitrary. They're generally based on the cost effectiveness, which of course is important, but that's the reason for it. And the third point, as I've already mentioned before, that the tumor biology dictates why continuous therapy using PD and PD-L1 inhibitors is very important and can be given as an option, right? So moving ahead, so just like in a minute, I'll try to give you a very quick overview of how immunotherapy has shaped the paradigm in lung cancer. So lung cancer was one of the most notorious cancers, and any patient who had no targetable mutation like EGFR or anything, but basically given immunotherapies. So this is the slide which I'm going to show you that shows you the tumor biology. So what the immunotherapy does is that it only escalates the immune response. It only empowers the immune response. And that is how it affects in tumor killing. And that response cannot be just shut down at like two years from the therapy. This goes on until you get a response, you can give immunotherapy because that's how it works, right? So therapies using PD and PD-L1 pathways have transformed cancer treatment. They've provided, very much effective treatments. And so that is why immunotherapy for PD-L1 expressing tumors is now the mainstay of treatment. So one, you already know that if a patient does not have any targetable mutation and a PD-L1 expression of more than 50%, that's the ideal candidate for PD-L1. We'll not be going into the detail. I'll just be addressing the real question, which is the duration of therapy. So as a rule of thumb, in other cancers as well, in any metastatic patient, we were giving chemotherapies or immunotherapies until progression or toxicity. That's the main rule that we follow, right? However, when most patients with metastatic non-small cell lung cancer who do not experience disease progression or unacceptable toxicity, we generally stop these patients at 2 years as part of the protocols that were previously published. But still, there is a lot of debate and there are no consensus that have been achieved so far, right? So as my colleague has already mentioned the trials, I'll not be going into the detail, but the Checkmate 153 trial that she just mentioned showed a considerable benefit in progression-free survival at 1 year of nivolumab as opposed to 6 months. So we can sort of extrapolate that if 1 year of nivolumab was better than 6 months, of course, continuing the therapy beyond 1 year may be, of course, more beneficial. Secondly, a very important point that I wanted to highlight is that when we're talking about a stage 4 disease, we're generally not focusing on overall survival. We're focusing mainly on progression-free survival. And that's what we get from the results. We might not get a very good overall survival benefit, but we do get progression-free survival benefit. And that is what is important when we're dealing with stage 4 diseases, right? So apart from the trials, the facts in support of maintenance therapy, only just the heading. So as I've already told you that immunotherapy biology is much more important than the statistics. So the biology says that, once you use these therapies, you boost the immune system. And stopping therapy risk loss of immune suppression and tumor regrowth. So it's very important that you don't stop the therapy because it will risk the loss of immune surveillance. As long as your immune memory persists, you might get a continuous benefit. So that's one point in favor of continuous therapy. Secondly, as I've already mentioned previously, that because of the trial design and because of the cost effectiveness and the financial toxicities, it was mandatory to stop therapies at 2 years, and that is the basis of a lot of trials that we see. But it does not align with the tumor biology. So that's the second point in favor of it. Third is that we've already seen in our practice that re-challenging a drug after that drug being used in the past is a little difficult. So maintaining control using a single drug for a longer time might be a little better than attempting to recapture the relapse. Fourth is what my colleague mentioned as well. So there are two sides of a distress. Of course, financial toxicity is a lot of distress, but telling the patient of a stage 4 disease that we will not be continuing the patient on therapy is also a distress for the patient. So for a lot of patients, when we tell them after 2 years that you're getting a good response, but we might not be able to continue with the same drug, provided that the patient is able to afford the drug, is not justified, or maybe a little stressful for the patient. So the last point is, of course, is about the toxicity that my colleague mentioned as well. So yes, there are toxicities with immunotherapies, and that can be fatal. I completely agree. But patients who have survived 2 years of immunotherapy with very good responses, with very little toxicity, there are very low chances that they might be experiencing a fatal toxicity in the future. And of course, we're seeing these patients, we're keeping them on follow-up. So generally, the late immunotoxicities are often low grade. If a person has to experience a toxicity, they might do it in the first year, right? So, and lastly, some patients might not have achieved CR, or they might not have achieved a complete response at 2 years. So unless we've completely eradicated a tumor at 2 years, we might not continue the treatment beyond 2 years, right? So biasness in an optimal duration, what is the bias factors? Of course, the first is financial toxicity. And the secondly, because there are no randomized trials, there are only non-randomized studies done for this. And so my conclusion is that despite the above stated documents, we cannot, I think, come to a conclusion as far as this debate is concerned. There's still a lot of ongoing research before we come to conclusions. But of course, in other developing countries, I completely agree that the social and the financial status must always be taken into account in addition to whatever biological benefit you come up with the continuous therapy. And so that is the...
that's the best. Okay.
So one of So that's my last slide. That one often meets the destiny on the roads he takes to avoid it. Thank you so much for listening to me.
Thank you very much. Excellent debate. I don't know whether there is a right answer or wrong answer, but again, show of hand for the purpose of it. Who will discontinue and who will continue? So let's see. We already know 8 people discontinue. Who will continue beyond 2 years? You didn't bring your friends? Even Dr. Humera is not arranging.
I'm neutral.
Okay, thank you very much. I think it was all done. We are very late.
Thank you very much.
But she spoke very
So I guess the debate will remain the debate. I will request the next session to start with because we are short of time, please. I'm grateful to the panel and chairperson and Dr. Rana Irfan and Dr. Amin Abbasi. Thank you very much. Our next moderator, please. I will introduce the moderator. Okay, please.
Thank you.
हाँ करो 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 करो
Assalamu alaikum. Madam, should I start? Thank you. I welcome you all to the very precious session for the gynecological tumors. So before going on for the further session, I would like to invite the chairperson first of all, Dr. Nasser Ali, who is an associate professor in the Radiation Oncology Department, AQU Karachi. And you are clapping. Sir. For the panelist, I would like to inform the Dr. Humera Mahmood. She is MBBS, FCPS, FRCP, and a chief oncologist and director at Pakistan Atomic Energy Cancer Hospital, Noori, Islamabad. My second panelist will be Dr. Nadia Azhar. She is a consultant gynecologist and director of the Thalassemia Prevention Department at Padma Foundation, Karachi. साथ साथ में अगर क्लिपिंग हो तो अच्छा होगा सर ताकि सब बुट जरा सा हो जाए and my third panelist will be Dr. Harry Mandor. He is a radiation oncologist, abdominopelvic specialist, and also director of biomedical sciences in the Chapto Mangkungo Sumo Hospital and Medical Faculty University of Indonesia. So now, before going on for our first presentation, I would like to call Dr. Khadija Mahmood. She's our first speaker, and I would like to introduce her because she is a MBBS Master in Medical and Radiation Oncology and Fellow of the College of Radiation Oncology of South Africa. She is a Senior Consultant Radiation Oncologist at Sultan Qaboos Comprehensive Cancer Care and University worked at Wenton Hospital, New Zealand, and Clinical Senior Lecturer at the University of the Otago, active in research global collaboration including Sparnoit IAE project now led by Noori. Sorry in advance if I don't pronounce properly. Yes. Before, first of all, I want just one thing. We have to remain in limited time. Okay. Sorry, but we would like
Don't
to remain
worry.
all the
I
day.
think everybody is exhausted. Nobody wants to listen now. So we'll make it very clear message and quick. Okay, can you start my presentation and I'll move this and this. Oh, he will start. Okay, yes. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm very honored to be here again. This is my second time, and I believe there will be many to come, inshallah. Karachi, and I will be moving around in Pakistan. The topic that I'm going to discuss is the two major trials in cervical cancer, locally advanced. We know EMBRACE and we know INTERLACE study. The induction chemotherapy and the EMBRACE is the optimal radiation technique. So I've been asked to discuss both of them and to choose one or the other, and what we will do in the setting of our clinical daily practice, and which one is the optimum one or the best one to choose in locally advanced cervical cancer. Okay. Please don't, really? Yeah, it is. It's not coming. I can email it to you. So while they are repairing this, we all know that over the past century, the standard has been chemo-RT. Since the publication of the 5 publication in NEJM 1999, chemo-RT was the standard over radiation, and since then we've been practicing gold standard chemo-RT. The incidence of cervical cancer, cervical cancer is not decreasing, it's increasing, especially in our this part of the world. And we have, like, in the last 2022, more than 500,000 of patients will have cervical cancer, and half of those will die, and particularly within South Asia, North Africa, Middle Africa, and Latin America. So we know we have a problem, and we still have 30% distant metastasis, which remain the key. And then when people try to address the problem with micrometastasis and the distant metastasis, then the Outback trial came in 2023, which was led by Prof. Linda Melinsky from Australian New Zealand group, international randomized study, to look at adjuvant chemotherapy, whether that will address this metastatic problem. And actually, that was a failure. It was a negative study. It seemed adding adjuvant treatment, it was too late, and with little advance and also toxicity, so that was a failed trial. Okay, alhamdulillah. Okay, Bismillah ar-Rahman ar-Rahim. Okay, so it's not showing. Okay, perfect. And then the EMBRACE group, which is led by Jack Estro, European group, they've been working over the years in retro EMBRACE, and the time, can you just started the time. So. It's 10 minutes. Anyway, so they were trying to optimize the radiation technique, and retro-EMBRACE and EMBRACE over multiple centers working together into image-adaptive brachytherapy, image-guided adaptive brachytherapy. They were actually improve the survival and local control by more than 92% with just optimal radiotherapy treatment. But the main challenges still remain. We still have 30% distant metastasis. Although we have tried to reach and improve the volume of cervix brachytherapy, in particular of 90 gray. And when INTERLACE, which was a different thinking of priming the tumor, came 2023, and then final publication in 2024, everybody was excited because it looked at induction chemotherapy weekly, carboplatin and paclitaxel, cycle, and then followed by 1 week gap, and immediately start the standard chemo-RT versus chemo-RT alone. It included 500 patients, and it's locally advanced cervical cancer, and it was a randomized international study from multiple centers, around 30 or so. And the results were amazing because for a long time we did not have this. We had 8% improvement in progression-free survival, improvement in overall survival, and not only that, the distant metastasis was also improved by 5%. So it's proven that there is induction chemotherapy is effective against micrometastatic disease. One have to consider many things to achieve this benefit. That not without a cost. We have almost 17% increase in hematological toxicity, which we expect in neutropenia. We also have more than 10% increase in a long-term grade 3 toxicity, so that's another thing. And we also, in a setting where we thought it's actually called like in the setting of low-middle income, but the study were not done in the middle income, like a modest income country, that we have to stick to the 7-day gap because of the fear of repopulation. So fast forward, we have EMBRACE-2, which was presented last year in May 2025 and won the award of Donald Holloway, presented by Richard Potter. Everybody know their work, and they just work on over more than around 50 centers. They work on optimizing radiation technique and trying to minimize toxicity. That's basically what they did. And 100% of the patient, they have to do image-guided radiotherapy, IMRT, VMAT, and image-guided adaptive brachytherapy with improved target coverage through interstitial brachytherapy. And the time also, they work on the time, so they have less timing, overall treatment time, less than 45 days. So that resulted in great improvement. This is just an early 3-year and 5-year, 3-year local control, 93%. 82% of survival advantage over 5 years, and not only that, very low morbidity, less than 10%. So that was a great achievement with just perfecting radiation and high-tech, and depending on very rigorous QA, depending on a highly proficient team across all the discipline, RTT, physicist, physician, and of course needed MRI, so to adapt every brachytherapy insertion. So the message is, without this condition, you cannot reach the benefit what EMBRACE group has reached. But it was amazing because it's almost 50 centers that they could do this quality assurance, and they could optimize the treatment like that. So the question remains, we have same disease, we have 2 different philosophy, and we have 1 decision to make, and when and how and why we will choose a different strategy over the other. And so if we look at them very quick, because of the shortage of time, you could look at them. They are 2 different designs. One randomized setting. One is a real-world optimization of treatment. More than 1,500 patients in EMBRACE-2. They included more advanced, was a para-aortic lymph node, which was not included in INTERLACE trial, and a mandatory 100% that to perfect radiation treatment, high state of the art radiation technique. And on the other hand, those were only 40%. And only 30% received what we will usually do 3D or image-guided adaptive treatment for brachytherapy, and 70% at that setting was just planning for 2D point A, and they have the same result. So why we think that EMBRACE now reached the same, although now INTERLACE had good survival? We think this is particularly to do with the dose response curve. Brachytherapy technique, good brachytherapy technique equal survival modulator, because if you look at the steep dose here, the steep response dose, you can see the minute you don't have radiation up to 90 gray, you actually could compensate that with the chemotherapy. So suboptimal radiotherapy will be compensated by the chemotherapy, and that might be why Interlace had achieved the result. And of course, in real world data, if you look at the literature, you will see anybody who improves their radiotherapy technique and using interstitial guided brachytherapy, they have achieved 15% increase in local control. So those all the factors that which led to improvement or similar survival in Interlace. There was a review done by Lindegard, which is part of the Embrace group, because of the initial push when Interlace presented that they wanted to actually discuss the result and to actually draw some kind of a conclusion. What is the benefit? Why we have achieved that? And then when they did Interlace-like, which is no para-aortic lymph node, just with a good radiation compared to the chemo-RT in Embrace type, they found actually better survival of almost 6%. So it appears that good radiation it's an optimal solution. Now, looking at the cost, if we look at our setting, chemotherapy is very easy. Everybody has access. Just give six weekly cycles of chemotherapy. It's a normal practice on every time. But if you look deep into the actual cost of Interlace, you will find multiple visits. The patient required multiple visits, multiple impact on financial for the whole family and also the country. And not only that, then the overall treatment time prolonged, and of course the decrease in compliance because of that. So, and on top of that, as I discussed, the increased morbidity. Whereas Embrace, if you set from the beginning a good radiotherapy practice, and the government invest in a good clinical image-guided MRI brachytherapy and skilled personnel, upskill the personnel and the staff, then you actually could do the same without all of that. So these are very important things to note. And we have to remember 10 years, this is JOTRAS, which is now Eve a bill because it's led, there is a significant quality of life decrease in survival. Up to 50% pain, mental issues, sexual problem, GI problem. So all of this we have to consider. So, so in general, this is in my opinion, it is one question and one answer. Do we have the capability and ability to provide good radiation in the same setting of Embrace? If yes, then the question is very clear. We will go to Embrace type, we will deliver good chemo-RT with less toxicity, and the survival is the same. If we don't have that, and we are in that setting where we are constrained and we cannot access good radiation, then Interlace is an alternative. It has shown there is proven benefit, especially particularly with patients who had a bigger tumor, and but we have to really make sure that we are constrained, because it is a constrained setting, so we have to make everybody in the team, including medical oncology, that they have the 1 week gap, not more than that. And of course, you have to be acceptance to the increased toxicity. And you never add chemotherapy to fix radiotherapy, so you really have to work hard in order to optimize the delivery of radiation. إتقان in Arabic, in إخلاص in the عمل. So anyway, so my last conclusion, Embrace is a high standard chemo-RT, optimal radiation based on a high technical rigor. This is the standard of care. Interlace is an alternative. It has proven benefit, and all the experts conclude that if you have the standard of Embrace and the capability, then induction chemotherapy is unnecessary and maybe even harmful when that applied. And still the question remains what we will do with micrometastasis. We know Keynote trial A18, we know that there is some work, hypofractionation, and also still the work in progress. And by that, I finish my talk, and thank you very much.
Thank you, Dr. Khadija Mahmood, for a wonderful talk. Now my second presentation is endometrial cancer, changes in the staging, risk stratification, and therapy options by Dr. Ikram Barni. Dr. Ikram Barni is a senior consultant and medical oncologist and director of the Women Health Program at the Sultan Qaboos Comprehensive Cancer Care and Research Center, Muscat, Oman. He's completed his medical training. Thank you, sir. Thank you.
Save time. We'll save time, yeah, inshallah. Assalamu alaikum, and first of all, thank you very much, the organizers, Dr. Azhar and Dr. Muhammad Ali Memon, for the very kind invitation. It's always a pleasure to be here back in Karachi. And as the chairman said, this is what we are going to do. Talk about some of the recent advances in staging and prognostication of endometrial cancer. Those are my disclosures, and the agenda is very simple today, and I think now I've got 10 minutes. It's been reduced from 15 to 10, so let's see how much we can cover in that period of time, inshallah. I think what I'll do is I'll use some cases for illustration purposes, and the first case is over here, which is a 67-year-old lady who was diagnosed to have a cancer of the uterus, and she was fit on comprehensive geriatric assessment, which is what we always do for patients who are more than 65 years of age. And she was treated obviously with a TAH and a BSO and a pelvic lymph node dissection, and that is the histology, a grade 2 histology with a 67% invasion of the myometrium, and she was staged like that. Who would treat her with external beam radiation, and who would treat her with chemotherapy? Anybody? If you do not say yes, then I would say that you would not. You would use, how would you treat her? Vaginal brachytherapy? Yes. Is that the standard of care? Okay. Only vaginal brachytherapy. Thank you very much. And I think that is the point I'm trying to make over here, which is the classification now, and what you saw on the previous slide, that she was P53 mutant. And what P53 mutant does is it does this thing here, and that is how the classification has now changed. And any histology, irrespective of the myometrial invasion, irrespective of the LVSI, if P53 is abnormal, these patients are upstaged to what is called as 2C P53 abnormal. And I do not know, and this is a question that I want to ask you, which is, do you in your routine practice always ask your pathologist to do P53 staining, MMR staining, and HER2 so that you can make the decisions? You can make your decisions in the tumor board based on P53 staining, because now that is the standard of care now. And this is the biomarkers that people would say should be used, but at least that probably should be done at the level of the tumor, at the level of the tumor board should be P53 and MMR, and if possible poly mutation as well, because that helps you decide how to treat in adjuvant setting in early stage cancer. And obviously this dates back from the times of the genomic characterization more than 12 years back. Nobody actually believed in that for a long period of time. Only in the last 2 years we know that not only the classification has changed, but also the way that we treat endometrial cancer has changed, both in the early stage setting as well as the latest advanced stage setting. Basically, you have got 4 types of tumor. What used to be called as the poly unmutated or ultra mutated, that remains the same. What used to be called MSI is now MMR deficient or MSI, because you can do immunohistochemistry. What used to be called copy number high in there is actually P53 mutant, and that is the case that I presented to you. And what is copy number low is P53 normal, which is now called as the non-specific molecular profile, which is about 40 to 45% of all cancers. So that's where the debate comes in, whether you need to treat them more aggressively or not. So back to our patient, as you said, if you only looked at the morphology, you would probably treat with vaginal brachytherapy, but having the information of P53, you would treat that definitely with external beam, and more likely with systemic therapy. I don't know the medical oncologists in the audience, do you use systemic chemotherapy for 2C P53 abnormal or not, but I do, and the reason for that is over here. In the PROMISE, as well as in the other prognostic classifications of PORTAC3, P53 mutant disease has got a 5-year survival of 50%, and most of them would be recurrent, would have systemic recurrence. So I think it is prudent now to treat these patients with
P53, with systemic chemotherapy in PORTAC-3 style. So you give radiation as well. Going back to this slide, this is the impact of the new classification that has on it. And we looked at our data together with Dr. Sara, who is sitting here in the audience as well. We looked at our data of about 80 patients. In 23% of patients, chairpersons, there was a difference in staging system. Either we upstage the tumor to 2C or 2C53 abnormal, or sometimes we even were able to downstage the tumors to 1C or 1 when there was a poly mutation, etc. So 1/4 of the patients would have a upstaging or downstaging based on the current classification. And I think that is significant. And if that was the only message that you were to take from here, and if I were to give that message, I think that would be very, very good. The second case was diagnosed to have a clear cell carcinoma, high grade, and she was ER negative, P53 abnormal, MMR proficient, and HER2 was 2+. And what we have in house is a system called, for looking at the genes, we have an ONCO. We do it for all patients in house, so we have full information about 300 genes or so. Past medical history was significant only for hypertension, and staging CT scan showed peritoneal involvement, and based on the new classification, this now becomes stage 4B disease. So there are a few questions over here. Question number 1, P53 by immunohistochemistry, which all of us use, or by gene expression profile. Is there a difference? And the answer is very little, if any, 10% discordance only. So it is okay to go with P53 immunohistochemistry unless you have a doubt and you think really that this tumor may not be P53 mutant, and then only you go to next generation sequencing to see whether there was a mutation or not. The second question is, what's the prognostic role of estrogen receptors in ovarian cancer? And clearly, absence of estrogen receptor makes the tumor much more aggressive. You can see the hazard ratios over here, 6.75 and 3.48 for overall survival. So chances of death because of endometrial cancer are very high in patients who are estrogen receptor negative. And those are the patients where you need to use systemic treatment as well as full hog treatment that you would need to treat. So here, this lady who had a peritoneal involvement has got this new 4B classification over here, which is peritoneal involvement, which did not exist in the previous staging system. So back to our patient. And in 2023, in March, these two papers came out, the GY018 trial as well as the RUBY trial, which showed an advantage of adding pembrolizumab or dostarlimab to chemotherapy in terms of progression-free survival and to some extent in overall survival. Subsequently, in the same year, two more trials came out, durvalumab and atezolizumab, and with some differences in trial designs. We are not going to go into details because of the want of time. But anyways, what they showed was that the disease-free survival was significantly prolonged if you added an immune checkpoint inhibitor. Now, we had this debate over here, 2 years versus et cetera. In most of these trials, it was 2 years, except for the durvalumab, where it was used till progression. But generally, I use it only for 2 years because obviously cost constraints is not only in Pakistan, it's all over the world. Even in the MMR proficient disease, there was an improvement in survival as well. So at least for the GY018 and the RUBY trial. So this patient of ours was treated in the RUBY fashion with the addition of dostarlimab to chemotherapy. And as you can see, there was a very significant response, and she continues to respond. I think I'm running out of time over here. It's still a minute and a half to go. So I will just raise 3 or 4 questions and then leave it to you. Would you add a PARP inhibitor like a DuoE at this stage, whether you would use durvalumab with olaparib? And if yes, can I ask how many people in the audience and the chairs would add olaparib to durvalumab in patients who have got MMR proficient metastatic endometrial cancer? Seems like nobody, although there is a clear survival advantage, which I can show you here. There is an advantage over here, but obviously there is a lot to be discussed in terms of the details of the trial, which we do not have time for. The second question that I wanted to ask you, should all patients receive immune checkpoint inhibitors in the first line after the RUBY and the GY018 trial? Would you treat everybody? Yes or no? Yes. I did not hear yes, so which means that I'm asking a wrong question. And the answer is that probably not. Let me just show you this slide. I think for P53 mutant tumor, it's important because those have got poor prognostic, very poor prognostic group. You should add an immune checkpoint inhibitor even though the tumors are MMR proficient, but not for the NSMP. You can see that in this post hoc analysis over here in the RUBY trial, there was no significant advantage. I think I've run out of my time. I'll stop over there. So I had only a very few slides more, but what I would like to show you, the last slide, which is our group at the cancer center where I work. And if you do get a chance, please do visit Oman. Be our guest, please. Thank you very much.
Thank you so much, Director Ambarni sir. You are a very wonderful and interactive session, but we are short of time. For our next presentation, I would like to call Dr. Eri Mandor. He is a radiation oncologist and abdominopelvic subspecialist in the Cipto Hospital Medical Faculty University of Indonesia. He will deliver his talk on the gynecological cancer, especially hybrid brachytherapy. I would like to inform, sir, please. Talia honi chahiye na, sir? Third talia. Yes.
Ari. This one. This one. Assalamualaikum warahmatullahi wabarakatuh. Bismillah, alhamdulillah, wassalatu wassalamu ala rasulullah. All praise is to Allah that has given us the blessing that we can gather here. And thank you to the organizing committee, especially Professor Fahim and Dr. Azhar Rashid, that have given me the invitations to be part of this wonderful event. So in this opportunity, what I would like to share is probably not fully scientific, but it is more about the story of experience in effort to create a standardized practice pattern in a developing country. And specifically, it will be about enhancing cervical cancer radiation treatment through hybrid brachytherapy in Indonesia. I am Ari Munandar, and I am from Indonesian Radiation Oncology Society, and I am currently working in the National General Hospital in Jakarta. So, this is Jakarta. It is the capital of Indonesia. It is one of the major populous cities in the world. It is actually 5,000 kilometers from Karachi, and it is around 14 hours to get there by flight. And this is the hospital where I work. It is located in the central of Jakarta. It is surrounded by a dense building, and it is the largest hospital in Jakarta. And this is where I work, the department. So in the department, we have 4 linacs currently. The oldest is the variant, but it is capable of doing MRT. And the most sophisticated one is the Radixact tomotherapy. We also have Halcyon and Versa HD. Also, HDR brachytherapy using iridium. We treat around 1,800 patients per year. That is 150 patients per day, and 7 brachy procedures per day. The majority with IMRT and 3D brachytherapy. 70% patients are in locally advanced stage. So that is for the introduction, and now it's the content of the presentation. First, I'm gonna share a little about the comprehensive treatment of cervical cancer and why brachytherapy is essential, especially hybrid brachytherapy. But I'm sure all of you have understand about this. And then I will talk about the landscape in Indonesia and how we develop hybrid brachytherapy there. So recent advances in health technology has made significant changes in cancer treatment. In cervical cancer, not only in therapy, but it starts from the diagnostic and staging phase. We have now the so-called functional imaging, radiogenomics. Pathology examination has reached molecular level and even genomic mutation analysis. Therapy has evolved. We are now in the era of immunotherapy, We have image-guided and sophisticated equipment which allow us to give high dose, not to forget the integration of artificial intelligence. All of those, when managed effective and efficiently by multidisciplinary approach, inshallah will give ultimate outcome to the patient. So why brachytherapy is essential? We all know that EBRT alone is not sufficient to cure large tumors. And with brachytherapy, we can place radioactive source directly inside or near the tumor to give boost up to the optimal dose to the tumor, while sparing the organ at risk. It is the gold standard now, especially using image-guided radiotherapy plus image-guided brachytherapy. But sometimes, by using only intracavitary brachytherapy, the traditional pear-shaped dose volume cannot cover all the HRCTV, especially the dose to the parametrium area. We know from established data that the ideal dose should be more than 85 gray EQD2 in HRCTV. So to achieve that, we can add interstitial needle to cover the area where the dose is needed. So the summary from my first part is using hybrid brachytherapy provides better coverage for higher risk CTV while at the same time reduce the radiation dose for the bladder and the rectum. So, and from observational Indonesia data, and this is from the Cipto Hospital, it shows that higher local control rates in Indonesia patients in especially locally advanced tumor. So move to the second sessions. So this story is actually start from 2022, when the pandemic era starting to fade away and people start to get back to the normal life. And we also think it is the best time to do restart. We start to begin collecting data. We analyze the gap between the usual practice and what can be improved. At that time, we already doing 3D brachy, and it started actually from 2018. But we do it only in around 50% of the patients. So we try to give more 3D brachy. We adjust the dose. Our pattern is usually 25 times 2 gray external radiation, mostly using 3D CRT, plus 3 times 7 gray brachytherapy, 2D or 3D. We know that the cumulative dose is still under, so we start changing to 4 times 7 or 7.5 gray using 3D brachy to the HRCTV. And to gain the confidence in doing hybrid brachytherapy, we follow workshops and training. We try to innovate and improvise in complex cases. And to objectively know the result, we continue to collect the data and see the improvement area. So from the data, we understand that we still have homework in the chemoradiotherapy part. The median is still 2 cycles in patients, and the overall treatment time is still long. It's still 72 days. The main problem is the waiting time for the brachy. We have tried to shorten the waiting time. The latest update is now we can give in 65 days, but it is still the process. And then for the dose, we can actually achieve now 85 grays. And in 2025, we try to encourage other centers to do hybrid brachytherapy. We perform national training and project, and we also collect national data. So why are we focusing on cervical cancer? Because in Indonesia, it is the second most prevalent cancer for women. In our hospital, the average is around 600 patients per year, and 70% are in locally advanced stage. And this is also aligned with the National Action Plan from the Ministry of Health to ensure 90% of diagnosis women receive specialized treatment. And this is what the implementation so far. We encourage major centers to perform 3D brachytherapy, especially now hybrid brachytherapy. We give national trainings. This is the example from our annual society meeting. This is just happened last month. We collaborate with Ministry of Health to increase the brachy equipment, but also with the quality control from the regulatory agency. This is the updates of centers development in Indonesia. In probably year 2020, 2023, there were only around 50 centers in Indonesia. But right now, we have 79 centers and have spread in almost every region in Indonesia, from the east to the west. For centers that have brachytherapy, there were only around 25 centers, but in mid-20 and 25, it has grown to 42 centers. And as the projection from the Ministry of Health program, also from the private centers, we expect that in 2029, there will be 134 centers all over Indonesia. We also perform national survey. At that time, there's still 27 centers perform brachytherapy, and new centers are majority start using cobalt because it is more efficient. Most center is still using 2D, 50% 2D and 50% 3D. And mostly still didn't do hybrid brachytherapy. So that's why we conducted the trainings and also encouraged the procurement of suitable applicators. Majority has actually performed CT-based IGBT. None of the centers are performing MRI at time of the brachy. They do MRI before the brachytherapy. And for the dose, it is also in balance between 3 or 4 fractions. And what is the challenge right now? The access become the greatest challenge because Indonesia has many islands, and we hope that the expansion from Ministry of Health can solve this. Overall treatment time is the second challenge. This is also because related to the SIM provided by the National Health Insurance. The flow of patient consultation and procedure is not seamless yet. So what is the future? We think that artificial intelligence will become one of the main support in upcoming years. And also with practice skills, we hope that many radiation oncologists can perform hybrid brachytherapy with adaptive technique, adjusting the needle placement based on the tumor condition. And for the conclusion, hybrid brachytherapy is no longer alternative, but necessity for the Indonesian clinical context. And we hope to achieve higher cure rate in the future, bismillah. So that concludes my presentation, and thank you.
Thank you, Dr. Ariminder. Now, our next presentation will be IGNRT brachytherapy in gynae tumors by Dr. Sardar Khatun. Dr. Sardar Khatun is a Principal Medical Officer, Radiation Oncologist, Head of Oncology Department, Atomic Energy Commission Hospital, Noreen, Nawab Shah, and member of the Pakistan Society of Clinical Oncology. Over to you, madam. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum and good evening to all participants and panelists, chairman and moderator. Dr. Sardar. First of all, I am focusing my presentation. This is on cervical cancer, as we are doing brachytherapy since 6 years, since 2020. So my mentor, my teacher is also sitting here. She learned me all these things, and I'm very thankful, Madam Humaira. My topic of presentation is long-term results of 3D brachytherapy treatment in locally advanced cervical cancer. Retrospective data from Noreen 2020 to 2024. But more of the patients which we are treated at the Noreen in 2005, still that follow-up of that patient data is not matured. That was, I am not including that cases in the in this study. This is beautiful look of my institute, Noreen Cancer Hospital, which is located in the center of Sindh. And we have referral from many centers. Brachytherapy, as we are doing, we have more cases of cervical and endometrium cases from referral from other institutes. Cases which are presented at Noreen Cancer Hospital, Nawab Shah, most of the time from 2012 to 2024. These are the incidence of cases. The patients ratio more in 2021 onward because of referral. Patient referred from other centers such as Sinar, Linar Larkana, and Nimra Jamshoro. Brachytherapy is a type of radiotherapy used to treat gynecological tumors and prostate cancer. As my seniors and other colleagues already described the EMBRANCE, RetroEMBRANCE, and other trials to give me just easy to present my data. It involved placing radioactive material directly inside and close to the tumor. Image-guided 3D brachytherapy treatment have shown important and improved survival and reduced treatment-related toxicity in locally advanced cervical cancer. So we are doing intracavitary brachy. Cervix is the most among the first cancer site where response of the adaptive radiotherapy have been successfully implemented in clinical practice. Brachytherapy play a anchor role in the management of carcinoma of cervix, and it is responsible for most of cure. Brachy is used in form of intracavitary applicators where radioactive sources are placed in uterine cavity and vagina inside the predefined applicator with specific geometry. Advantages of high-dose brachytherapy. A highly localized radiation dose to small volume, highly local control spares surrounding normal organ and tissues, and ultimate form of conformal radiotherapy. Shorter treatment time and convenient, non-homogeneous dose distribution to the tumor targeting the hypoxic central core. And its disadvantages, there is invasive procedure, and this needs 3E, mean expertise, experience, and equipments. It's also time consuming. We are doing just 2 cases in per day. Difficult to maintain uniformity across the various centers. We are using modern Manchester applicator. These are the type of applicator we are using in our preparation of patient. We admit in ward 1 day before procedure and encourage oral fluid intake, nutrition on day 1 before procedure, laxative 1 day before brachytherapy, and we maintain IV line, start antibiotic before brachy. Keep patient NPO midnight and bladder filled with 150 ml of normal saline for ultrasound. Rectal air removed by rectal tube staff nurse. This is also the labs advised before procedure, and PV examination to see the gross tumor volume and involvement of vagina, parametrium. These all the things after EBRT. Image-based brachytherapy planning. After the application of patient, we shift patient to image room and doing CT 3D for 3D planning. Targeted volume are defined on CTV, volumes defined by GEC ESTRO guidelines, gross tumor volume, residual tumor, high-risk clinical volumes, and intermediate risk volume. Treatment was performed with Electa high-dose rate brachytherapy machine. This is because this is image-based brachytherapy planning. So 6 steps for image-guided brachy. First off, after insertion, 3D imaging on the CT machine, contouring was done by doctor, and then reconstruction of applicators with 3D planning system, and then final dose delivery. EQD2 sheet, according to that, D2CC is more than 70 to 75. These are the international guidelines, and now I am describing my own data. A study was conducted at Noreen Hospital, and patients which are already registered at my institute and patient which receive EBRT at Atomic Energy Cancer Hospital, Noreen Hospital, and also refer from other center. So there are two protocol of EBRT. Patient receive 45 gray and 50.4 gray along with CCRT, including criteria. Patient which was included in my studies, inoperable locally advanced cervical cancer, which receive more than 90% patient receive CCRT and EBRT. And excluding criteria, patient which have no any history of EBRT and operated case, some patient just only receive operated THBSO was done and brachy alone. Number of patients treated in total 5 years, 230. In patient which included in this study, 92. Mean age of patient, 64. And histopathology, most of the patient, 98% patient have histopathology squamous cell carcinoma, while 2% of patient adenocarcinoma. Stages patient which are registered at my institute, 2A and 2B, 27.5% patient, and more of the patient are present in stage 3, 54%, while in stage 4A, 90.5. According to EQD2 sheets, the patient which receive average dose HRCTV is 84.2 gray, while bladder 2 cc dose 63.8 gray, and rectum receive 55.7, sigmoid 52.2. 3 to 5 year oral follow-up and oral survival and local control of disease, number of patients with locally advanced disease 13%, and number of patients with distant mates 10.8%. Survival rate of disease-free patient total, which is still on follow-up, 42.5%. While patient, most of them advanced stage present with retrovaginal and vesicovaginal fistulas, 8.7%. Patient loss of follow-up and expire, 25%. Oral survival, 75%. As all of you know that according to Embrace trial, local control is 89% at 5 years with every stage. And combined with intracavitary interstitial applicator, we can developing for the targeting tumor not well covered with intracavitary. So image-guided 3D brachytherapy treatment have shown important survival and also improved survival, reduced treatment-related toxicity in locally advanced inoperable cervical cancer. Challenges we are facing, limited machines, high patient load, and scaling delayed. Challenges, so delay referral from brachytherapy after EBRTs. After EBRT, when patient complete EBRT, then patient refer to us. So according to Embrace 2, brachytherapy plus EBRT, treatment should be complete less than 50 days. So appointment for brachy before start EBRT is very must. Our further direction, MRI guided expansion and hybrid technique, more infrastructure. Thank you so much for your attention.
And thank you, Dr. Sardar Khatun, for such a nice presentation. Now the last presentation of the first part of the session will be delivered by the Dr. Tanzir Khalid. Dr. Tanzir Khalid is a clinical oncologist, obtained CCT and worked as a consultant at Leeds Teaching Hospital, UK, and recently moved to the SMC Hospital, Abu Dhabi. He is also a CR examiner for the FRCR clinical exam. Sir, over to you. पीछे ऊपर वाला था वहाँ से कर रहे हैं ये वाला अपडेटेड वाला ये थैंक यू
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind introduction, and very grateful to the scientific committee of the PSCO for arranging such a fantastic meeting and giving me this opportunity. So in the interest of time, I'll be very quick, but we'll try to summarize, I think, what we need to really think about in ovarian cancer. So I'll try to cover the main points of the systemic treatment. I think this slide is very impressive, where if you look at the prevalence of ovarian cancer, and Pakistan is in the highest prevalent region. So we see the highest number of patients in the country when we look at the global data, which is quite concerning, but at the same time gives us the opportunity to do more appropriate and optimized treatment for our patients. So we know about ovarian cancer. Unfortunately, majority of patients present at advanced stage. There's a large number of patient population who's diagnosed every year, and it's growing. Survival outcomes overall in 5 years, still not great. A lot of room to improvement, remain less than 50%. I won't go into the details of this, but we know epithelial cancers are most common, and in that we talk a lot about the serous, high-grade, and low-grade, that we will talk more in detail going forward. This kind of gives you a good idea that if you can pick up the disease early, you can really change the survival outcomes, which is a big challenge, especially in countries like Pakistan, where patient education needs to be highly worked upon. But when you see the distant metastatic disease, survival drops significantly and makes it challenging for clinicians as well as patients. I think probably the most important slide of my presentation is that now we need to have molecular and genetic testing at the start of our patients, because that really defines their treatment journey. As a clinician, it makes it easier for you at the start how I'm going to plan the treatment journey of this patient rather than just the first-line treatment. We know the BRCA mutation is the commonest, and 10 to 15% of patients will have that, and 90% of that is the BRCA1 and 2. HRD is another very important thing, and we know more than 50% of the high-grade serous tumor patients will have that, and we'll see that how PARP inhibitors' role come into that place. Now, I think it's impossible for me to talk about systemic treatment without mentioning PARP inhibitors, but I know we've got a debate on that very topic after this discussion. So I'll briefly mention that, but I will not go into details of that. So if you see over the last 20 years, we've gone from chemotherapy, which still remains the backbone treatment. We have bevacizumab, then we have all the BRCA-targeted drugs, and more recently, ADC inhibitors have come approved by FDA, but I think probably not going to be something that we will be using in this part of the world, but it's important to know that things are coming in this arena. When we look at the ESMO guidelines, stage 1 and 2 disease, relatively straightforward, but I think the key here is the surgical staging, which we have to get it right. So it's very important when we are in tumor board discussions that we have an idea that how our surgical colleagues felt about the disease stage and what the results of histology were, because we know that 30% of patients will be upstaged. In terms of indications for adjuvant chemo in this setting, so the main indications, stage 1C to A, any high-grade tumors, possible benefit if the surgery is not optimal. We know we can use single-agent carboplatin, but usually it's the doublet that we'll be using. Optimal debulking, we know this has impact on survival, so the idea is to get the disease out completely. There shouldn't be any gross disease left, and we use 1 centimeter very commonly as a criteria. In terms of neoadjuvant chemotherapy, this trial looked at using upfront chemo more in the sandwich role with the surgery, and it showed improved rate of optimal debulking and reduced complications, which kind of led to change in practice, and we commonly see this being used. Bevacizumab is the next drug that we had available, and we will look at the 2 trials, ICON 7 and GOG 218, but essentially the bottom line is that this is used mainly, benefit is in stage 4, but we use an inoperable stage 3 and also suboptimally debulked disease. I wouldn't go to the details, but if you just look at the graphs on the right side of the screen, you'll see the benefit. This is mainly the PFS, but the OFS benefit, or the groups which showed more benefit, was again more high-risk disease, or if there was disease left. So I think if you can take that message away, I will be very pleased with that. But you also see here you are getting overall survival benefit. So I'll just quickly show you PARP inhibitors, very important drugs. Concept of synthetic lethality, essentially when you look at the cell repair, you will have single-strand breaks if you block that, and patients who've already got BRCA deficiency or HRD deficient, they will not be able to repair themselves, and that's how we try to kill the cancer cells. I think the most challenging part of the patient's journey, and as a clinicians, what's challenged to us is this nature of this disease, which is relapsing. And as we see the relapse, unfortunately, the time interval decreases. So it becomes more resistant, and you have to deal with disease a lot sooner. And I think that is something that makes it quite tricky, and we hope we see improvement in that. I wouldn't go into details of PARP inhibitors, but there's very good evidence now to use that as maintenance in first-line settings. There's some evidence in second-line setting as well. I think these trials will be talked in detail after this presentation, so I will skip these in interest of time. But if you see the graphs, the progression-free survival, the overall survival data is very, very compelling, and that's why they are standard practice now. So again, this is the PRIMA trial. Then we have the POLA study, which look at combination of olaparib and bevacizumab, which showed benefit across all the population. I think that's really important. HRD status is pretty important to know. Just a quick look at the POLA study when they looked at patients which had the HRD deficiency. They actually did better. But if you look at patients who did not have this, did not show much benefit. So, it's becoming a little bit of a mathematical management. If you know, if you have this information, it kind of makes your life a bit easy. Again, sorry, in the interest of time, I'll skip that. ESMO guidelines kind of summarize this really well. So when you start the journey of the patient, either whether they have chemotherapy 3 cycles up front, or go for surgery, or they go for upfront surgery straight away, or they are not operable in stage 4, all these patients ultimately will lead you to the bottom part of this slide, where you have the BRCA and HRD profile. If you have BRCA mutation, you go for olaparib, or you have other options. I'm not exactly sure what we have available in Pakistan, but essentially it gives you a lot of options. When you have got BRCA wild type, but you have got HRD positive, then again you have niraparib, but you can also use combination of bevacizumab with olaparib. But if you don't have either of them, then you can either use bevacizumab or olaparib. So I think it is pretty straightforward to work out once you have that vital information. In terms of relapse, 6 months is a pretty standard duration that we use, so we wouldn't go into much more details of that. So again, recurrent disease is quite a challenge, and I think this is an area where you probably need a little bit more experience to work out what to do. Patients who can have platinum, usually you will go for a platinum combination, and then you look back at what was used in the first phase. If you haven't used a PAR inhibitor, or you haven't used a bevacizumab, which should not be the case, but then you will have this option at this stage. How you will pick that? If you've got somebody who you're worried about the disease progression, which is quick, and you want to get on top of things in a short time, you will go for bevacizumab. Otherwise, you can have a PARP inhibitor. We know that combination of 2 drugs is actually better than monotherapy in this setting. So I think that's another important thing. And when you don't have platinum as an option, unfortunately, it's bad news for the patient. You're heading to palliative treatment quite early. Your options are limited. You can use single-agent drugs. Unfortunately, we will not have access to the more fancier drugs, but the ADCs are coming into the picture. So this kind of summarizes that which combination of drugs we can use. Again, the meta-analysis about the combination is better than a single agent. I think this is a very important document. I'm sure most of you would have come across that. So I just put in few slides here where we had these consensus statements, and they actually give you all the scenarios. So I wouldn't go to the details of that, but essentially it gives you the scenarios, how patients started, what mutations they had, and if you have a relapse, how you pick the treatment. So I'll skip those in the interest of time, but I think I'll just summarize with this slide that now we have got maintenance option at each stage, depends on what we have used before. So if you have used a PARP inhibitor in first line and it's a relapse and you haven't used BEV, consider that. If it's other way around, you consider the PARP. But when you use the both, that's the gray area, and I think that's that you as a clinician need to make a choice. There is evidence, some evidence to support that you can pick if you have relapse like at 18 months or 12 months. So there are options that we can consider. So key take-home messages, there's been advances in DNA repair targeted therapies. This has transformed the cancer journey. BRCA and HRD testing is absolutely vital. There's good data to support in first-line setting with these drugs, which results in long-term improved outcomes. And I think the earlier we use the PARP inhibitor, the better the results are. Thank you very much.
Thank you, Dr. Tanzir Khalid and Jawab, for such a nice presentation. Now the debate session for our next will be maintenance PARP inhibitors for all versus biomarker restricted use. For that, I would like to call upon the stage moderator as a Dr. Mohammad Afzal. Please welcome, sir. Thank you.
Assalamu alaikum, everyone. Thank you, Dr. Feroz, for a kind introduction. Before starting it formally, I would like to say thanks to Dr. Azhar and Dr. Nasir for inviting me and giving me an opportunity to discuss the very important topic of maintenance treatment in ovarian cancers. And I would like to congratulate all of you, the PSCO organizing committee, and every member of the PSCO for organizing such a wonderful event in the heart of the country. So thank you so much. स्लाइड करना इसी से करना है ठीक है So the topic that was assigned to me was ovarian cancer, maintenance of PARP inhibitor therapy, all versus the biomarker directed. And Dr. Azhar requested me to have a debate on this. So in the interest of the audience and to make this session interactive, I make a case-based discussion, and I would like to discuss this with my colleagues, Dr. Saad Naviwala, who is a consultant oncologist at Cancer Foundation Hospital, and with Dr. Faiza Ahmed, who is working as a consultant medical oncologist at Cancer Foundation Hospital. She's basically practicing gynonc and breast cancer, and Dr. Saad is practicing genitourinary and head and neck cancers. So I would like to request both of them to come on the stage and join us to have a discussion of PARP inhibitors, all versus. Thank you, Dr. Saad and Dr. Faiza, for accepting my request. So here are my disclosures. So starting with the case, so my case is a 45-year-old pleasant female who has no comorbids, presenting in my clinic when I was doing in a private practice in 2022. So she had an abdominal distension and the nausea and vomiting. Image was done which showed there was an enlarged adnexal mass with a peritoneal carcinomatosis and omental nodularity. There was a moderate amount of ascites in the ultrasound, so image-guided ultrasound therapeutic ascitic tap was done, and later it was followed by image-guided omental biopsy. So on the omental biopsy, the immunohistochemical stains were performed, and which shows cytokeratin A1, A3, PAX8 was positive, WT1 and ER positive, and that concludes that this is in a primary female genital tract origin tumor, likely ovarian. So considering this is in a stage 3 disease, I started her on combination carbopacli, which you all know that is the standard of care treatment, along with the bevacizumab, and we discussed the option of genetic testing with the patient, and later when her chemotherapy was going on, she turned out to be positive for BRCA1. So after giving the 2 cycles of bevacizumab and 3 cycles of combination chemotherapy, she underwent debulking surgery, which shows that there was a significant residual disease, and later she completed the 6 cycles of chemotherapy along with bevacizumab. Now she was in my clinic and asking what next? Should I give further, should I have to receive further treatment? And what are the options of maintenance therapy? And why the maintenance therapy is required in ovarian cancer, and does any particular tests are there? Because these are the questions that you frequently encounter in your clinical practice, that patient who are literate, they usually ask that why I'm going to be put on an extra medicine for next 6 months, 1 year or 2 years. So, so the question comes, does any particular test require before putting me on a maintenance therapy? And do I really get benefit in my case? So these are the questions that everybody encounter in clinics. So I would start with answering the question 2 and 1, and later Dr. Saad and Dr. Faiza will comment what is the data behind that. So why we are discussing the maintenance therapy is necessary for ovarian cancer. So majority of the ovarian cancers usually diagnosed at advanced stage disease. 70% of them were high-grade serous carcinoma, and when they were diagnosed at advanced stage disease, combination chemotherapy followed by surgery is the standard of care. Till 2010 and 11, when the data from the GOG 218 trial, which Dr. Tanzeel have mentioned, and ICON 7 trial came, and it shows that by adding the bevacizumab, which is an anti-angiogenic agent, you can reduce the risk of recurrence by few months, approximately 3 to 4 months. So whenever there is a disease recurrence, your cancer becomes incurable. And in ovarian cancer, 70% of the patients have a recurrence in next 3 years after completion of treatment. So there was always an unmet need that something should be given to the patients to delay the progression of the disease. And once you have a disease, if your disease is stage 4, your 5-year survival is less than 5%. So that was an unmet need that was initially fulfilled by the anti-angiogenic agent bevacizumab. And later in 2017 and 18, the paradigm has been shifted. The list of the drugs from PARP inhibitors in combination with anti-angiogenic agent comes and play a role in the maintenance therapy. So we are going to discuss this. So for the residents or for the junior faculty, the two concepts, HRD proficient and deficient. So there are the two repair pathway. One is, you all know that the DNA is a double helical structure. When there is an abnormality in the single strand, it is being repaired by the PARP enzymes. And when there is an abnormality in the double stranded structure, it has been repaired by the homologous recombinant pathway. And when the pathway is absent due to the mutation of any of the genes, it's not only the BRCA1 and BRCA2 that account for the HR deficient status, it's other genes that are responsible for that. So when there is a deficiency of or mutation in the genes that is responsible for homologous recombinant pathway, we call it deficient pathway, and when they are active, it is called proficient. So my question to Dr. Faiza is that, Dr. Faiza, keeping the case in view, so she was diagnosed with stage 3C ovarian cancer, and she was being given bevacizumab as an maintenance therapy, or can be an option of maintenance therapy. What are other options considering that she is BRCA1 positive?
So the options we have, apart from bevacizumab in maintenance setting, as a patient is BRCA positive, one could have a role of PARP inhibitors in maintenance setting. We have a landmark trial, which is SOLO 1, published in 2018, which looked upon the patients who have stage 3, stage 4 advanced ovarian cancer, who had received chemotherapy. On that, they have a complete clinical response or have at least partial response after platinum therapy. All of the patients were BRCA mutated, and they were given olaparib, which is a PARP inhibitor, for 2 years in maintenance setting. So in 2018, the primary endpoint, which was the progression-free survival, was looked upon. Next, please. So regarding the patient characteristics, majority of the patient, approximately 80% were stage 3, rest of them were stage 4. All of them were BRCA mutated, either 1 or 2 or both in some patients as well. Patients who have a complete clinical response were around 80% in both the groups, while the rest of the group had a clinical partial response. Next, please. So in 2022, updated progression-free survival and our overall survival data was published, which showed that the benefit of olaparib was quite bit. There was a delta of 42 months. That was around 4 times the placebo at 7 years, with a hazard ratio of 0.33. Next, please. Regarding the subgroup analysis, all of the patient population regarding the stage, BRCA1, BRCA2, age, all of them benefited with the maintenance olaparib. Regarding the OS benefit, the data was not fully mature at 2022 analysis. Around 50% patient had maturity at that point in time. Even with that, the graph starts to separate over here.
I think all can visualize that graph starts separating after 60 months.
Yes, but the hazard ratio was 0.55 and it was not statistically significant. But we still need to have an updated analysis on that to have a better understanding regarding the overall survival benefit.
So yeah, so in majority of the patient in the SOLO-1 trial were stage 3 and stage 4, and they have not been used PARP and bevacizumab anti-angiogenic agent in the neoadjuvant setting. And all of these patients have been tested for the BRCA1 and BRCA2. None of these patients were tested for the HRD status. And it was the first landmark study, as Dr. Faiza mentioned, that shows a dramatic increase in progression-free survival in ovarian cancer with the maintenance treatment. So, Dr. Faiza, do we have a trial in which PARP inhibitor was combined with the bevacizumab?
Yes, definitely we have. The next trial which I will be discussing is Paula trial. Again, published after 1 year of SOLO-1. Same patient population, stage 3, stage 4, high-grade serous or endometrioid tumors were taken into account. Patient received chemotherapy and they did benefit on that, should have a clinical response to chemotherapy. Plus, the patient also received bevacizumab with chemotherapy. The difference was that in Paula trial, patients with BRCA2 unmutated, those who were not mutated were also taken. Approximately 70% of those were not mutated, while 30% of those were mutated, either BRCA1 or 2. Again, 2 years of olaparib with bevacizumab in maintenance setting was given in the treatment arm. Next, please. So the progression-free survival data, which was published in 2019, showed the difference of around 22 versus 16 months. That is approximately 8 months benefit at 3 years of analysis with a significant significance p-value and hazard ratio of 0.59. Regarding subgroup analysis, patients who have BRCA mutation shows benefit, while the patients who do not have a BRCA mutation but had HRD positivity. Mind you, HRD testing was done in this trial and the cutoff of 42 were taken into an account. The patients who were HRD positive were above, the cutoff was 42 and above. So patients who do not have a BRCA mutation but had HRD positivity also showed benefit with olaparib in combination with bevacizumab as compared to bev alone, with a hazard ratio of 0.43. 26 versus 16 months benefit was there in patients who have HRD positivity. Again, on subgroup analysis, all of the groups benefited except for those who do not have BRCA mutation or those who do not have HRD, HRD positivity. Apart from that, all of the groups benefited. Next, please. Regarding the overall survival, an updated analysis was published in 2023. Here again, as the prior SOLO-1 trial, the graphs were started to separate at 60 months, but they were not statistically significant in overall intention to treat population.
So both in the SOLO-1 and the Paola trial, the overall survival data was not mature because majority of the patients in the placebo arm subsequently received PARP inhibitors. So this is what the Dr. Faiza is telling us, that HRD positive patients only have a better
OS.
Even with overall survival as well, only HRD positive patients had benefit in long-term data.
So you can see from the graph on the very left, the HRD negative patients, the hazard ratio was not significant. So what are the major toxicities that one can encounter or one can expect, Dr. Faiza, when we are putting the patients on the PARP inhibitors like olaparib, as per the SOLO and the PAOLA trial?
Regarding PAPA inhibitors, one of the most common toxicity which needs to be looked upon is hematological toxicities, starting off with anemia, cytopenias, and leading to more advanced toxicities like MDS, AML, and apart from hematological toxicity, new primary malignancies is one of the reason as well. In both of the trials, SOLO 1 and PAOLA trial, the grade 2 and grade 3 anemia was both common, but the most important toxicity which we were worried about was MDS AML incidence, which was around 1.2 and 1.5 in overall analysis in patients who received SOLO 1, and which was pretty much similar in PAOLA trial as well. So the incidence is though low, but it's still there, which has to be looked upon. Apart from that, the new primary malignancies, specifically breast cancer was there, which were again, the number of patients were very low, but it was there in the patients who received olaparib and compared with those who do not have.
So yeah, as Dr. Faiza mentioned, 2% risk of developing secondary malignancies, AML or MDS, with first-line use of the PARP inhibitors. I recently got the updates from the aerial trial, another trial in platinum-resistant ovarian cancer, where the FDA have withdrawn the recommendation of using the PARP inhibitors in platinum-resistant cases. They found that patients who have been on PARP inhibitors and they were platinum resistant, their risk of developing AML and MDS was quite high, like 8%. So based on that and no overall survival benefit, the indication of using PARP inhibitors as a second-line maintenance therapy or in a platinum-resistant cases as in a treatment have been withdrawn by FDA. So Dr. Saad, so are there any trial in which PARP inhibitors are used regardless of the genetic testing, regardless of the BRCA status or HRD status?
Yes, Dr. Afzal, thank you so much for inviting us. And I would like to say that first thing, that PARP HRD negative does not mean PARP insensitivity. So yes, there are two trials. I'll be going through them. First one is the PRIMA trial. It was randomized phase 3 trial, international, double-blind, and randomized control trial that was conducted in 2019 and was published in New England Journal of Medicine, in which high-grade ovarian cancer patients were taken, stage 3, stage 4 cancers who have received platinum-based chemotherapy followed by cytoreductive surgery, who have a response PR or complete response, were randomized to 2:1 ratio, in which niraparib was given as per the platelet and weight basis. If the platelet were more than 150 and weight was more than 70 kg, so 300 milligrams of niraparib was given for 3 years, as compared to those who had less than 150 of platelets and weight of less than 70 kg, they were given 200 milligram of niraparib.
And sorry for cutting, there is a separate trial called PRIME trial that was done in Chinese population, in which they basically look the same characteristics, like patients who have less than 70 kg of weight and platelet less than 1,50,000. Yeah.
Yes.
Go ahead, Dr. Saad.
So the primary endpoint was the progression-free survival by investigation choice, and the secondary endpoints were the overall survival and progression-free survival and treatment for the subsequent therapies. So as we go through the patient characteristics, there were about 50% of the patients who are HRD deficient, out of which 30 were BRCA mutated. The population, the niche of population that I'm looking is what the homologous recombinant proficient patients that were about 34%. Next. Okay, so as you can see, the primary progression-free survival update, that was roughly, as you see, the curves have been separated from the starting and have remained separated till the end. The progression-free survival was roughly more than double, 24.5 versus 11.2, with a hazard ratio of 0.51. About 49% patients remain disease-free for 3 years. So that's an interesting.
So this is for the HRD positive?
Yes, that was for the HRD positive one. I will be more focusing on the HRD negative tumors. So there was a 3-month PFS benefit, 8.4 versus 5.4, with an hazard ratio of 0.67. So there was a modest response, but not as significant as in HRD positive patients. Coming on to the overall survival, you can see there was no OS maturation or benefit in any of the population, in overall population, in HRD positive population, in BRCA wild type population, and HRD negative population. Next. Coming on to the secondary endpoints, this is the forest plot curve. We can see that niraparib clearly give advantage in treatment for the subsequent therapies. There was more time to start the next treatment. And coming on to the progression-free survival, there was a modest response in that. Next. Okay, so there were few potential explanations why all these trials, as discussed by Dr. Faiza, Solo 1, Paola 1, and my trial, Prima trial, why they didn't show the overall survival benefit. The possible explanation for these could be that there was a crossover, as Dr. Afzal explained earlier, and duration of the PARP maintenance inducing additional resistance that can lead to the platinum resistant in subsequent lines. So these could be the possible explanation for the lack of maturation of overall survival in all these trials. Next.
So there is another interesting trial that Dr. Saad will tell us, the Athena Mono trial that was presented in ASCO 2022.
Yes.
So Dr. Saad, can you go through this?
So, Dr. Afzal, this trial was present in ASCO 2022, Athena Mono. It was a randomized phase 2 double-blind trial that was that included all high-grade stage 3, stage 4 high-grade ovarian cancer patients and tubular cancer patients who received platinum-based chemotherapy followed by cytoreductive surgery. Were randomized into 4:1. One arm received rucaparib, that was a potent PARP inhibitor, 600 milligram twice a day. And another arm received the placebo. The duration for rucaparib was about 2 years in this, and there were 2 other arms, but later they basically disregarded those 2 arms. So now this arm.
So they do the separate analysis of these 2
Yes.
arms. So basically, Athena Mono looks at the PARP inhibitor rucaparib versus the placebo. Yeah.
So the primary endpoint of this study was the progression-free survival. And as we go on to see the progression-free survival curves in HRD deficient patients, you can see the clear benefit. The curves tend to separate from the starting and remain separated till the end. There was more than double progression-free survival benefit with a hazard ratio of 0.49. So about 51% patients remain disease-free for at least 3 years, more than 3 years. And coming on to our overall population, there was a separation of curve, but the separation the curves start to hug each other in later line. And the amount of, the main point of this study was that they basically evaluated the BRCA wild type and low patients that had a hazard ratio of 0.66. So it was a statistically positive population. And I think there was a modest response to rucaparib in HRD negative patients also.
So in the Athena Mono trial, they basically checked the HRD status by different assay. In the other trials, the HRD status was checked by My Choice and My Right test, while in this Athena Mono trial, they basically checked the HRD status by Foundation 1. So there are inter-trial variation of checking the HRD assay, and that's why the results are vary in terms of having a positive results in HRD positive population. So what are the toxicities and the real world consideration? Dr. Saad, can you elaborate us quickly?
Yes, Dr. Afzal. So as Dr. Faiza discussed, there are mainly hematological toxicity, as we all see in our clinics, that olaparib causes FAN, fatigue, anemia, and neutropenia. So these are the major side effects, and these are manageable side effects. When we compare rucaparib or niraparib, we see thrombocytopenia as one of the causes. We see there's a ALT, AST elevation, there is nausea, vomiting, and these are the manageable side effects that we usually see in our clinics. We usually the kind of, if we want to make these patients on these PARP inhibitors, we usually discontinue them. We make treatment gaps in that, so it becomes easy for them to continue. Then there was, as you have explained previously, that there is an MDS AML risk about 2%.
Yeah.
And the biggest problem that in our region is the cost effectiveness.
The cost, the unavailability of the drugs, the reliability
So we have
of the drug.
olaparib, we have niraparib in our areas, but the problem is that expensive.
Yeah,
It's
and we
expensive.
don't have rucaparib or niraparib available in.
We have niraparib.
Yeah.
Yes, we have olaparib and niraparib, but we do not have rucaparib.
So these are the costs. So these are the challenges that one can face in the low middle income countries, like cost, unavailability of the drug. You and we all don't know that whatever the patient is getting in terms of the drugs like olaparib and all the PARP inhibitors, the immunotherapies, that whether the patient is getting the right amount of the drug or not. We are not sure about the quality of the drug that is present inside the box. So what the ASMO guideline says and what the NCCN guideline says. So the ASMO guideline says that if the patient has a BRCA1 or BRCA2 mutation, one should consider PARP inhibitors, and it is strongly recommended. And if there is an HRD status, you can consider PARP inhibitors. And if the HRD is negative, you can give bevacizumab or niraparib, as Dr. Saad mentioned. Regardless of the HRD status, you can give PARP inhibitors. But you have to discuss this with the patient about the cost, about the duration, about the toxicity, about the long-term side effect, and for how long. The main question is the 2-year benefit, or you can extend this drug beyond 2 years. What the NCCN guideline says, NCCN says the same thing. Test the germline, check the germline testing. If turned out to be positive, give the PARP inhibitors. And if germline testing was negative, do check HRD status in the tumor. And if it turned out to be positive for HRD mutant or deficient, then you can give PARP inhibitors, or you can even combine PARP inhibitors with bevacizumab if the patient has received it in the first-line setting. So to conclude, BRCA mutated, so benefit of the PARP inhibitor is usually in the BRCA mutated or HRD deficient subgroup, and we should discuss that the benefit is just the delaying the progression of the disease. There is no benefit of PARP inhibitor in terms of overall survival in all of these trials that we discussed today. Long-term risk like AML, MDS should be discussed with the patient, and the cost, and especially in low middle income countries like us, should always be discussed. At the end, I would like to acknowledge my mentor, my teacher, my spiritual ma, Dr. Azmeena Tajuddin, from whom I learned a lot, Dr. Ali Aziz Begum, who is the gynecological oncologist over there, surgical oncologist in Aga Khan, and Dr. Nasir, whom I call directly whenever I stuck in a case, and he is very kind enough to reply me, and the Dr. Azhar Rashid, who invited me. Thank you so much. And last but not the least, thanks to Dr. Saad and Dr. Faiza for accepting my request. Thank you.
Now the session is concluded. Any question? Because no audience is there. कोई सवाल जवाब तो है नहीं, कोई तो है नहीं, सारे तो वही लोग रह गए.
Everybody has explained well everything.
Yes, ma'am. Thank you.
It's there from the audience.
Thank you, madam. मैडम एक लास्ट हम पिक्चर लेना चाहते हैं जी.
MS और देखिए MDS और AML के लिए फाइनल रिकमेंडेशन क्या हो, जो मेरा ट्रायल आपको बताया, तो we should continue
So both long-term topics. हमने कितने पेशेंट डॉक्टर फायजा नवाज के जानते हैं. डॉक्टर नासिर ने हमें रेकमेंड किया था कि मुझे वही तुम कर लो डॉक्टर अजय ने कॉल डॉक्टर अजय ने कहा यार दो अच्छे से ऑनकोलॉजिस्ट मैंने कहा अच्छे ऑनकोलॉजिस्ट फिर अपने जैसे लोग अपनों बड़ों ने तो मैं तो स्पीकर था ही मॉडरेटर था आपने भी